Hello.
Hello.
Hello, good morning. I would like to welcome all on the behalf of IMA Akluj. I would like all the office bearers to be please on stage. Respected Khartare sir, our IMA president, to please be on stage, as well as all the office bearers. Office bearers, please be on stage, please. Dr. Vinod Chete sir, on stage, please. Sambhaji Raut on stage, please. Dr. Dobre on stage, please. Dr. Sachin Fade on stage, please. Dr. Mukund Jamdar sir, Dr. Sachin Fade on stage, please. All the office bearers, all the queens of our IMA office bearers, Dr. Priya Kadam madam, Dr. Revati Rani, Dr. Mansi Namdar, Dr. Aditi Rite madam, please be on stage. Mukund Jamdar sir, please be on stage, sir. We would need to start the conference. नाही खडतरे सरांना माईक घ्या तिथला माईक सर स्टार्ट सर स्टेजवर सर सर उभा राहून घे पटकन चालू करतो 10:30 सर आगावर. So good morning everyone. I would like to welcome you all from Akluj. I would request our IMA president Dr. Khartare sir to please start the conference, please.
Good morning all. Today on this auspicious day, first time in our history, in rural place we are conducting the state level Academy of Medical Specialty Conference. This is the IMA Maharashtra State AMS Annual Conference AMSCON 2021. In this conference will be on 2 days, 4th and 5th September, and theme of the conference is emergencies in the medical field. There are 4 sessions on the first day and 2 sessions on the second day. Today is a World Sexual Health Day. On this day, we have covered 4 different sexuality lectures from 4 corners of the India, and eminent speakers, national and international speakers, are talking on this sexology topic also. Here, different faculties from all fields of the medicine, they are also talking. So here, I declare the conference is open for all, and I request our clinical secretary Revati madam take a charge of this conference.
Very welcome and thank you, sir. Now we would start with the conference for the first session, that is for the devoted to medicine. I call upon Dr. Nitin Rane to coordinate the session.
Hello. I would request our chairperson, Dr. M.K. Namdar sir, to please be on stage. Sir needs no introduction actually. He is a stalwart He's known nationally and internationally as well. He's been felicitated with a number of awards. He's a practicing physician for almost 40 years in Akluj with extensive expertise in cardiology as well as in all intensive critical care units. He runs a 60-bedded ICU hospital. And I would like him to introduce our first speaker, Dr. Sanjay Agarwal, sir, who will be speaking upon diabetic emergencies in DKA. So please, over to you, sir.
Hello friends, I welcome you all for this auspicious day for IMA Akluj. I'm glad that this conference started, and the introductory lecture is given by eminent physician diabetologist Dr. Sanjay Agarwal. I'll introduce him. Actually, he is a very eminent personality in diabetology. As a formality, I'll just introduce him. He's a director of Eagle Clinic Diabetic Care in Pune. He's the head of the Department of Medicine and Diabetes, Ruby Hall Clinic. He's a senior consultant in diabetes and medicine, Jahangir Hospital, Pune. He's a fellow of American College of Endocrinology, honorary secretary, governing council of National RSSDI, member, editorial board, BMJ, Open Diabetes Research and Care Journal. He's associate editor, International Journal of Diabetes for Developing Countries, member of writing committee for RSDDI guidelines on inpatient management of hyperglycemia, consensus on glucose monitoring in type 1, type 2 diabetes, RSDI ESI clinical practice recommendation of type 2 diabetes, guidelines on management of diabetes and heart failure, guidelines on management of diabetes and oral health, guidelines management of diabetes and thyroid disease. He is the author of book Clinical Atlas in Diabetes, chief editor in RSSDI Insulin Monograph, contributed chapters in various books, actively involved as a principal investigator in landmark international research trials. His faculty of various national and international meetings, mentor for the postgraduate program. So such an eminent personality we have for the opening lecture. I request Agarwal sir to continue with this.
Thank you very much, Dr. Inamdar. Am I audible to you? Just wanted to check my audio.
Yes,
Yeah.
yes.
All right. So thank you, Dr. Inamdar, for this kind introduction. And I would like to thank the meeting, the office bearers of IMA for inviting me today to give this lecture. Let me just begin by sharing my screen so that I can share my presentation with you. Is my presentation visible to you?
Not yet, sir.
All right. Yeah, thank you. Yeah, thank you so much. So essentially, I would like to thank the IMA branch of Akluj and the office bearers for giving me this invitation. I bring greetings from the National RSSDI as well as the IDEC meeting. So today I'm going to delve a little about diabetic emergencies, and one of the most important emergency that we really need to talk about is diabetic ketoacidosis. And this has been a rather in focus as of now because of various reasons. Even in COVID times, we've seen people have presented with diabetic ketoacidosis. So if I have to really make my pitch and talk about where are we, so the earliest report about diabetic emergencies comes way back in 1867, where they did characterize that one of the reasons for patients going into coma is diabetic ketoacidosis. And the earliest report about a patient treated with diabetic ketoacidosis dates back to 1921 in the Toronto General Hospital. That's when insulin was still not discovered. And what they did show was that patients who presented with severe glycosuria, when they were given a pancreatic extract, the glucose urea tended to go down. Patient tended to improve. And once the pancreatic extract was stopped, then the glycosuria came back again, and the patient developed features again of DKA. And here's a documentation that is there from literature about ketonuria and how it tends to go down after the pancreatic extract was given. So we have enough data dating back from the previous literature to show the effect of insulin producing cells. This was, of course, given in very raw form as pancreatic extract. Now, of course, we've got sophisticated insulins available which do the job. If I have to talk a little bit about epidemiology, it's one of the most common hyperglycemic emergency. We really don't have too much of data from India as to how often do we see this in our clinical practice, but I'm sure each one of us at some point of time have managed diabetic ketoacidosis as an emergency. And it's not really all that uncommon, given the fact that we have a huge population of patients with diabetes. So diabetic ketoacidosis is one of the most common occurring diabetic emergencies. We know that we need to treat this condition aggressively because patients tend to improve. Any delayed or improper management of diabetic ketoacidosis increases the chances of morbidity and mortality. I'm going to give you data actually that doesn't come from our country. It comes from the National Hospital Discharge Survey from US, and this data is from the CDC. And what they have shown is that the incidence of diabetes is, of course, going up, but there is a disproportionate increase in the occurrences of diabetic ketoacidosis when listed as a primary diagnosis for hospitalization. Way back in 2006, the incidence, as they reported, was more than 1 lakh of patients with episodes of diabetic ketoacidosis. But what is important is to see that despite the age-adjusted rates and the crude rates, the incidence is going up. Now, if you break it down in a sub-analysis in terms of occurrences of age, and they looked at 3 groups of patients, 0 to 44, 44, and more than 65, you do see that the incidence of DK is much higher in the first 4 decades, that's 0 to 44. And that's understandable because the incidence of type 1 in this population is high. So that drives the increased incidences of diabetic ketoacidosis. Late onset of ketoacidosis is usually either ketosis-prone diabetes or something which is not ketoacidosis, is hyperosmolar states. So these are the more common emergencies that we see in later life. There is no really predilection in terms of gender, but we do find that there is slightly increased incidences in the Afro-American population as compared to white population. And that's because they are a highly insulin resistant population. Now, here you can see that majority of the patients who do tend to develop DKA are type 1s. And it's seen by this paper that 56% of the patients who develop primary DKA episodes are type 1s and 34 are type 2s. But because we have a high volume of type 2 patients, obviously the absolute number of patients who present with DKA and type 2 tend to be higher because type 1s constitute only about 5 to 7% of our population with diabetes. Why do really DKA occur? And it's basically an imbalance between insulin deficiency, insulin availability, and the counter-insulin hormones. And when there is an absolute or a relative insulin deficiency, then there is a higher chances of developing a DKA. And this is balanced out by an increased secretion of counter-insulin hormones, that's glucagon growth hormone, cortisol, and catecholamines. What it really translates down to is that there is an increased glucose production in the liver. There is a reduced peripheral uptake because of insulin lack in the tissues. And this results in a net hyperglycemia, which leads to osmotic diuresis and volume depletion. Now, on the other hand, there is an increased free fatty acid mobilization from the adipose tissue, which goes into the liver and causes an increased ketogenesis. And in absence of presence of insulin, there is a higher presence of ketoacidosis, reduced alkali reserve, and patient ends up with metabolic acidosis. So the hallmark of any patient with DKA is insulin lack, volume depletion, hyperglycemia, and metabolic acidosis. So the patient usually presents with very common patients who present to us with the upper abdominal pain. So any patient type 1 who's got slight tachypnea, severe upper abdominal pain should not be disregarded, and this patient just could be having a DKA. But patients do present with polyuria, polydipsia, extreme weakness, weight loss, dehydration, nausea, vomiting, and they may have a typical acetone breath, what we call, and the patient may develop Kussmaul's breathing. So acetone breath, Kussmaul's breathing are hallmarks again of DKA. Patients may have tachycardia, tachypnea, because of hypoxia they tend to get, and patients often present to us with altered sensoria. The onset may be relatively short, ranging from hours to a day or two. Remember, as I just talked to you about, that the patient may come with altered mental status, and this was a paper that looked at from Dr. Umpiras, who looked at a serially 144 patients, and they found that patients are alert in half the population, about 48%. 39% of the patients do come with lethargy, and 13% may come in a comatose state. And this is directly related to the serum osmolality that the patient has got. And higher the serum osmolality, the higher the chances that this patient will have mental obturations. Okay. If I have to make a diagnosis of any hyperglycemic crisis, so patients who come to us with severe hyperglycemia, is we have to differentiate between diabetic ketoacidosis and hyperosmolar states. Usually in DKA, the plasma glucose is more than 250. In hyperosmolar states, it's more than 600. pH is usually less than 7.3 in DKA, but more than 7.3 in hyperosmolar states. Bicarbs are low in DKA, less than 15, usually more than 15 in hyperosmolar states. Beta hydroxybutyrate more than 3 in DKA, less than 3 in hyperosmolar states. And I'm going to refer to beta hydroxybutyrate a little more in the coming slides. And the acetoacetate is high in DKA, but it may or may not be present in hyperosmolar states. And again, the osmolality is more than 320 in hyperosmolar states. So if you have a patient who's probably later in life, has got a blood sugars of more than 600, and does not have a presence of acidosis and osmolality of 320, then you bang have a diagnosis of hyperosmolar states. But any patient who comes to you with more than 250, with a severe acidosis, dehydration, presence of more with the high levels of beta hydroxybutyrate, then you have DKA. And then, of course, now with the advent of SGLT2 inhibitors, you have more and more patients coming with euglycemic ketoacidosis. The patient may tend to have a normal glucose values and all the presentation of diabetic ketoacidosis. So that's where you need to make a little differentiation. Now, you can categorize the patients of DKA into mild, moderate, and severe. And usually the patients who have, if you have to categorize them, then this is based on the pH values and the bicarb levels. So if you have anybody with a pH between 7.25 to 7.3, it's mild. 7 to 7.24 is moderate, and less than 7 is severe. And similarly, the bicarbs follow the pH values, whereas the ketones are quite positive in all the three stages. Again, altered sensoria is more as the severity increases of DKA. As I said, that you have to differentiate this against hyperosmolar states. Some of the reasons for presence of DKA are, of course, new onset diabetes, particularly type 1s, where the patient may be presenting with a diabetic ketoacidosis. Any failure to take insulin or miss insulin doses that could result in DKA, presence of infection, or any severe stage where insulin requirement increases, then you may get patients presenting with DKA. And of course, concomitant medical illnesses, which may be responsible for occurrences of DKA. A good history is important. And when you evaluate the patient, check his ABC, that's airway, breathing, and circulation, assess his mental status. Important is to look at his cardiovascular and renal status and try and identify the source of infection or the precipitating factor. It is very necessary that you evaluate the patient's hydration status and at the same time send the patient's lab studies for assessment of the patient. So you look at, of course, the counts, the ABGs, their metabolic parameters, We commonly do actually urine ketones, which is a little fallacy. What we really need to measure is either the serum ketones or beta hydroxybutyrate levels. And if there are presence of any infections, then you need to necessarily send the required cultures. And sometimes patients, because of severe dehydration and not timely rehydration processes, may end up with thrombotic states like strokes or myocardial infarctions. So we need to be careful when we assess these patients. I was just talking to you a little while back about why urine ketones are a fallacy, because usually the urine ketones are a measure of the hyperglycemic states. If you really need to measure ketoacidotic state, then you need to look at the beta hydroxybutyrate. And if you do a serial monitoring of the beta hydroxybutyrate, then you will be able to assess the resolution of DKA. But because beta hydroxybutyrate are not available everywhere, as a default, we tend to rely on urine ketone testing, but should not be the standard practice if you have measurement of beta hydroxybutyrate levels in your labs. Management is, of course, replacement of fluids, and that's one of the most single important thing that you need to do. And I'm going to talk about it in a little while. Correction of the hyperglycemia and metabolic acidosis, replacement of electrolytes, find out the precipitating causes. And of course, once the patient has resolved DKA, you need to put this patient on a maintenance diabetic regime. Usually, very often than not, we need to keep these patients on a continuous insulin regimes. Now, as I was mentioning to you, that fluids are very important. And usually when the patients come to us, they are quite volume depleted. So you have to do a rapid correction of the fluids. You may have to give almost to the tune of 1 to 2 liters over 1 to 2 hours. And then, of course, follow it up with almost 250 to 500 ml per hour till you are satisfied that the patient is adequately rehydrated. The advantage of rapid volume correction is that obviously you protect the kidneys. Number one, as you do a volume rehydration, you find that the blood sugar levels also come down. And there have been reports which showed that they have delayed the insulin initiation just with volume correction itself, that the blood sugars have tended to come down. The third thing is you prevent severe lactic acidosis, because very often you may end up with getting a mixed acidosis because patients tend to have a wide anion gap acidosis in presence of DKA. And when the acidosis is not getting corrected, you have to suspect a presence of concomitant lactic acidosis. And the last thing is, of course, when you give a lot of volume hydration, the acidosis also tends to improve. So one singular thing, if you have to, the first thing is just do volume hydration as fast as possible. This is going to have a lot of benefit. And once the blood sugars come down to less than 250, you transfer these patients onto dextrose drips. Please do not use dextrose insulin drips. This is given up the world over. You have to use separate lines for giving dextrose and insulin, because it's very erratic that the insulin delivery will tend to have with dextrose insulin. And we still find that there are centers which practice dextrose insulin infusions, which is absolutely something that we don't practice anymore now. You have to run separate insulin and dextrose drips for that matter. We now adopt a low dose insulin titrations. So you give a bolus of 0.1 unit per kilogram of body weight, and then follow it up with a maintenance of 0.1 unit per kilogram per hour. There have been studies which have looked at high dose versus low dose, and the resolution is no difference between the high dose versus low dose. You only end up giving more hypoglycemias to the patient. So it's much easier and more physiological to adopt a low dose insulin infusion rates. And once, of course, the glucose comes down to less than 250, you need to step back in terms of insulin dosing. Please bear in mind that if the patient has got any sort of organ failures like kidney failure or liver failure for some reason or the other, you have to do a little slow titrations, because there could be insulin stacking and the patient may end up with hypoglycemias. I don't want to get onto this busy slide, but this slide just gives you the protocol for transfusion of fluids, insulin, potassium, and bicarbs. So that's very useful. If you can keep these charts in your wards, it will help your doctors to titrate the process. Remember that all patients with DKA tend to potassium depleted. So when the patient comes to you, they may come with hyperglycemia, but once you start the insulin infusion, there is an intracellular translocation of the potassium, and the patients may tend to become hypokalemic. So you need to necessarily start potassium replacement early. Once you see that the potassium levels are coming down, you need to do more frequent estimations of the potassiums. Bicarbs are given only when the pH is less than 6.9 or 7. Usually, depletion itself is very important. And if you can do that, very often than not, with the addition of volume and the insulin, the bicarbs tend to get corrected. There's no need for phosphorus. Two importance that I really want to talk about is there have been studies which have looked at IV versus subcutaneous insulin of infusion. And I'm going to talk to you a little about the importance of this. But what they have really done in the studies is they've given IV insulin in a bolus of 0.1 units. Infusion until blood glucose comes down to less than 250, and then of course down titrated. And this has been compared against subcutaneous insulin with a bolus of 0.2 units per kilogram subcutaneously, and then you down titrated to 0.1 units per kilogram per hour. Once it is less than 250, you down titrate further to 0.05 units per kilogram. What it did show is that the importance is that whenever you're giving IV insulin, very often you need to treat these patients in ICUs or step-down units. As in a lot of peripheral areas, you may not have that advantage, and the patient comes to you with DKAs. When you give subcutaneous insulins, you can probably treat these patients in emergency rooms or wards. What they have really shown is the time to resolution, in terms of glucose coming down, bicarbs improving, the pH improving, the beta hydroxy butyrate levels coming down, and free fatty acids improving, are identical when you give IV versus subcutaneous insulin. If you look at the length of stay, the subcutaneous insulins have a slightly shorter stay as compared to IV insulins. The important is the cost factor involved. Obviously, when patients go into ICUs with IV insulins, they tend to have a higher expenses in terms of hospitalization. Whereas if you give subcutaneous insulin, then you need to, the cost comes down. The only thing that you need to be really careful about is the volume hydration, because when the patients are dehydrated and you give subcutaneous, there could be pooling of insulin in the subcutaneous space. And when you volume hydrated very rapidly, there could be a runoff of this insulin, resulting in possibility of hypoglycemias. Although the chances of such a thing happening is very less. I've had a talk with the authors of this study, and they said they have never seen this happen, but it's quite safe to give subcutaneously, and the resolution time is identical between IV and subcutaneous. The other thing that I want to really talk about is the use of analog versus regular insulins intravenously. Very often we have been propagated that analogs are better, human insulins may not be as good IV insulins. And this study looked at the comparison of IV glulysin versus regular insulins, and then they were transitioned from IV to subcutaneous. So glulysin was transferred to glulysin plus glargine, and regular insulin was transitioned to regular plus NPH insulins. And what they did show is it does not matter whether you use analog insulins or regular insulin. The time to insulin to resolution of DK is identical, whether it is in terms of glucose lowering, pH improvement, bicarb improvement, anion gap narrowing. All of them are identical when you give regular versus analog. But what is important is that the hypoglycemia rates that they tend to get with when you transfer them onto subcutaneous insulin. So analog insulins do tend to have lower hypoglycemia rates as compared to subcutaneous insulin. Also, you have to remember, and this is just as a digress that I'm going to do, that all insulins, whether it is glargine, whether it is NPH, or whether any of these, when you give any of these insulins intravenously, they all behave like regular insulins. So in times of crisis, when you don't have insulin, although this is not kind of something that I would promote, but remember that in terms of the pharmacokinetics, all insulins intravenously behave exactly like regular insulin. They get their properties of delayed absorption, and the length of time that they work is when you inject them into the subcutaneous space. Okay. So if I have to conclude from this particular study, then regular glulysin are equally effective when given for the treatment of DKA. Transition to subcutaneous insulin is better with analog insulin as compared to regular insulin, and basal bolus with glargine glulysin is safer and should be preferred over the regular insulins. Some of the dreaded complications of DKA is, of course, cerebral edema. Can I just take one more minute of time to conclude my lecture? Okay.
Yeah.
So cerebral edema is a dreaded complication because mortality is almost in 1/4 of the patients. So you have to be very careful. And the rebound ketosis hyperglycemia due to inadequate insulin dosing and timing to transition should be kept in mind. And you have to educate your patients well on insulinization and keep a proper follow-up care. There should be a pre-discharge checklist that you need to do in terms of what the patient requires after going home. Just a point of difference is when diabetic ketoacidosis occurs in pregnancy, usually they are more of euglycemic ketoacidosis, and the patients may necessarily require a 5% dextrose infusion right from the start of treatment, and the decision to deliver should be individualized and as per the recommendations. So in summary, DKA is common, serious, and expensive complications in patients with type 1 and type 2. Prevention of metabolic decompensation through patient education, strict surveillance of glucose homeostasis, and aggressive diabetes management might reduce morbidity and mortality associated with DKA. And recent treatment protocols have improved clinical outcome in patients with DKA. Thank you very much for your patient listening.
Thank you, sir. Now I request Inauguration sir. I request Inamdar sir to felicitate sir
Yeah, thank you,
and
Agrawal, sir.
summarize.
It was very lucid and very informative lecture in a short period of time. Almost you have covered everything. Few of the points we have, but there is no time for, because of paucity of time and huge registration, question answer is not possible. I hope Akluj Medical Association will have some other time your elaborate lecture for 1 hour. Thank you very much, sir.
Thank you so much for inviting me. Thank you very much.
Hello. Thank you, sir. We will immediately go to the next lecture. I would like to request Dr. M.K. Inamdar sir to introduce Dr. Samiri Melinkari sir for the next lecture.
I invite Dr. Samir Melinkari, another friend of us, Akluj physician's friend. I'm very delighted that he has accepted our invitation. Little introduction for him. From August 88 to January 1999, he was lecturer medicine at BJ Medical College and Sassoon Hospital. June 2000 to June 2001, he was senior resident in clinical immunology. June 2001 to 2007, he was senior registrar in Department of Hematology. March 2000 onwards, he's head of the Department of Hematology in the Dinath Mangeshkar Hospital, Pune. He's a clinical researcher activities as a principal investigator. He has been principal investigator in numerous international studies. He has numerous publications on his name. He's very devoted hematologist. Present position, he is a consultant hematologist and head of the Department of Hematology, Dinath Mangeshkar Hospital. Established the blood and bone marrow transplant unit at the hospital. A regular transplant program has been established. Performed the first unrelated donor transplant in Pune. Instrumental in organizing a state-of-the-art apheresis center in blood bank of this hospital. So vision for the future, his visions are to establish the latest techniques and therapies in hematology and bone marrow transplantation at an affordable price near in Pune and around Pune. So I request Dr. Melinkari to continue with his talk. Thank you.
Thank you, everybody. Let me just share my screen. Okay. To make, I hope I'm audible. To make things a little more interesting, currently, I am admitted with COVID-19 infection in Dinath Mangeshkar Hospital, as you can all see, and I've just taken my antibody cocktail day before yesterday. So instead of doing a 3-minute walk test, I think I will do a 20-minute talk test and see how my saturation fares. Okay, so in 20 minutes, I can only give you a smell of the hematological emergencies that one can have. There are too many, but I thought I'll give you 3 examples of slightly different situations which you may encounter in your clinical practice, but may not think of these as what the cause could be. Okay, so the first case is a 35-year-old man who was admitted a month ago with fever and mild headache. So his WBC count was 3,000, hemoglobin was 13, platelet count was 40,000. There were no clinical findings, and the tentative diagnosis was dengue fever. As you know, mild leukopenia, mild thrombocytopenia. In the presence of a normal to high hemoglobin, one would first think of dengue fever. So labs were sent and symptomatic treatment was started. Next day, he developed sudden intense headache, and over the next 1 hour, suddenly became drowsy. So immediately we did a CT scan. And the CT brain, he was not under my care, he was under a physician, and the CT showed a parenchymal bleed. So he was immediately taken up for craniectomy or decompression surgery. And intraoperatively, what the neurosurgeon saw is that there was complete thrombosis of almost all the cerebral veins, right? So this is a dural venous sinus thrombosis, and that to a massive one. And so normally one would immediately start with heparin. One would give symptomatic treatment, give mannitol, dexamethasone, etc., etc. But in the current day and age, what one must not forget to ask the patient is whether he has taken his first dose of vaccine in the last 2 weeks and maybe up to the last 6 weeks, right? Because we have this unusual and new entity now called vaccine-induced thrombosis with thrombocytopenia. Okay. So what is this condition? It was first reported with the AstraZeneca vaccine from Germany, and subsequently the US FDA had paused the Johnson & Johnson vaccine, which is also an adenoviral vaccine, to allow investigation into many of these sort of cases. And initially this was called vaccine-induced ITP, thrombotic thrombocytopenia, but now the CDC and FDA have called it thrombosis with thrombocytopenia syndrome. They've removed the word vaccine probably just to make sure that people don't get scared of vaccine. But then looking at the risk and benefit ratio of the number of people that are benefiting with the vaccines, the FDA did permit the J&J vaccine to continue. The approximate incidence with the J&J vaccine was 2 per 10 lakh people. The highest incidence is incidentally in women less than 50 years of age. So normally you are worried about thrombosis in people who are on the older side. Funnily, with the vaccine-induced thrombosis, the incidence is more common in people who are younger, and especially in females. And many people are critical at the time of diagnosis. Remember, it's not just a gentle little bit of thrombosis here and there. 40% of people who have developed VITT have died. So it's a syndrome characterized by arterial or venous thrombosis, mostly at unusual sites. And the commonest is in the cerebral venous sinus thrombosis and splanchnic venous thrombosis, so abdominal thrombosis and cerebral venous thrombosis, but also rarely in other sites also. And typically the patient will have mild to severe thrombocytopenia, often less than 20,000. And there is, so which vaccines cause it? Typically it is only the adenoviral vectors. It is not seen in the mRNA vaccines as yet. Only one case was seen with the Moderna vaccine, but otherwise all of them have been seen with the adenoviral vaccines. And this condition apparently is very similar to what happens with heparin-induced thrombosis with thrombocytopenia. HIT is a common, it's a rare condition, but we know this since many years now, that after about 3 to 4 days of exposure to heparin, some people develop antibodies to heparin, and these antibodies cross-react with an epitope called as a platelet factor 4. It's a complex between heparin and the platelets, and it binds to this complex and causes activation of platelets. And because of the platelet activation, one tends to thrombose, and because of subsequent removal of these platelets by the circulation, you have thrombocytopenia. So you have thrombosis and thrombocytopenia, and the diagnosis is established by doing a test called an ELISA-based test called anti-PF4 antibodies, and this is exactly the same test that we do in suspected VITT cases also. The management of the thrombocytopenia is don't first transfuse platelets unless severe bleeding, because you're going to aggravate, you're going to put fuel into the fire. Give IVIG 1 gram per kg once daily for 2 days and steroids as per the situation. And for the thrombosis, do not use heparin when it is suspected. Use other agents such as fondaparinux or the newer oral acting anticoagulant drugs, and anticoagulate for a period of 3 months. Okay, so that was VITT. Let's move on to the second emergency. So this is a primary gravida, 30 weeks pregnant, no past medical history, develops thrombocytopenia on routine testing, and the hemoglobin is normal, WBC differential count is normal, platelet count is 30,000. PVS is unremarkable. Biochemistry, LDH normal, PT, PDT are normal. So this is 30 weeks of pregnancy. So diagnosis is pregnancy-induced ITP. Why? Because you can do a bone marrow to confirm it, but in 30 weeks, we prefer not to do a bone marrow. As long as the hemoglobin is normal, differential count is normal, and it's only isolated thrombocytopenia, one can almost always assume that this is immune thrombocytopenia. You've got to rule out more dangerous causes such as thrombotic thrombocytopenia, purpura, which has mild hemolytic anemia and schistocytes in the blood. You must rule out EDTA-induced platelet agglutination, which is pseudothrombocytopenia common in pregnancy. And then you come to that conclusion. So usual plan is that you treat the patient for ITP only if the platelet count is less than 30,000. And you would attempt to maintain a platelet count of more than 50,000 at the time of delivery. So this patient was started on steroids, but there was no improvement. At 34 weeks, the platelet count had dropped down from 30 to 20,000. Then azathioprine and dapsona were added. As you know, all drugs are not permitted in pregnancy. So these were added, but at 37 weeks, the platelet count had dropped down further to 10,000 now. So then the patient received IV immunoglobulin for 2 days, and with an attempt to try and improve, but there was no improvement, and the patient actually went into labor. And at the time of when she went into labor, the platelet count was 1,000. She was not bleeding. Why she was not bleeding at 1,000? Because in pregnancy, please remember that naturally the coagulation factors are massively increased by the body to prevent bleeding during placental removal, and therefore you always have a very thrombogenic state at the time of term and in puerperium, and therefore despite thrombocytopenia, most patients will not bleed. So she was not progressing for labor, and therefore she was planned for elective cesarean section at a platelet count of 1,000. Was I worried? Well, I was not worried because I've handled lots of patients who have delivered at a platelet count of less than 10,000. So I was not worried. Okay, now a little bit of theory. Thrombocytopenia can be because of decreased production or increased destruction, or because of sequestration. So production of platelets are decreased when there are bone marrow disorders, which patients tend to bleed more easily in these patients because the ability of the body to produce platelets is very poor when the body demands it. On the other hand, destruction-related defects. So the marrow is producing platelets adequately, but they are getting destroyed in the periphery. These are such as this situation is typically in ITP or increased consumption of platelets, such as sepsis, DIC, etc. So they bleed less since the body can increase production of platelets whenever required, and therefore in ITP, not in DIC, but in ITP, you will have almost very minimal incidences of bleeding. And the third is sequestration. Okay, and the sequestration of platelets is typically seen in hypersplenism. When the spleen is massively enlarged due to any reason, it can sequester up to 90% of the platelet mass within itself. And but these are always a part of the exchangeable pool of platelets. Whenever the body needs these platelets or the red cells or the white cells, they are immediately mobilized from the spleen and they are available. And therefore, these patients also will have very little chances of bleeding. So this patient underwent LSCS under the cover of 1 unit of SDP. The surgery was uneventful. The baby was delivered, but through my horror, the patient had a tethered placenta which had to be manually removed, right? And that's a difficult situation because you're doing it blindly, and while doing it, manually removing it, the patient started bleeding and bleeding. And persistently, the patient kept on bleeding. And as you know, so if you don't have a proper retraction of the placenta, this can be a very dangerous situation. So when the patient of ITP bleeds, typically what you must do is, and this is a refractory ITP. So you must keep giving platelet transfusions continuously until the bleeding stops. Okay, so keep giving bulks of platelets or give platelets as an infusion and until the bleeding stops. And the other option is to give a drug called Novo-7, which is recombinant factor 7. And 1 to 2 doses often help in sealing the bleeding areas. And how this happens is that, as we know that, in the body, coagulation always starts when there is tissue factor exposure because of a raw area in the circulation. The tissue factor 7 combines with the factor tissue factor to form the final clot, prothrombin to thrombin, and thrombin actually activates all the intrinsic pathway factors, and that leads to the formation of a good clot. So if you can give NOVO7, which is recombinant factor 7, it will find a tissue factor within the circulation. Wherever it finds the tissue factor, it will quickly form seal that area with thrombin. With a nascent fibrinogen clot, and therefore in many times you can get away by giving a few doses of NOVO7. Unfortunately, it's a very expensive drug, so with the patient receive 2 milligrams of NOVO7 and tranexamic acid single dose, and the bleeding immediately sealed. So that is about another emergency where ITP patient bleeds. And finally, the third case was a 35-year-old lady who presented with fever of 2 days duration, body ache and fatigue. She took treatment from a local doctor, and blood tests revealed dengue NS1 positive state. The hemogram was 16 of hemoglobin, 2000 WBC count and 90,000 platelet count. But the patient kept feeling unwell and hence came to the Nanath Mangeshkar Hospital. On examination, she was sick and toxic. Her CBC showed a hemoglobin of 14, WBC count had dropped further, and a platelet count of 20,000. The LFTs showed a bilirubin of 14. The liver enzymes were 2,000 and 1,500. So massive elevation of liver enzymes. Creatinine was raised. She was oliguric or almost anuric with raised lactates and a deranged PT and APTT. So what would be your diagnosis in this case? The commonest diagnosis which any physician would naturally think of, and which is quite appropriate and often correct, and that is dengue shock syndrome, right? That dengue can spread all over the body, and some patients it can really cause a shock syndrome. And in this state, there's no drug for it. You just have to give renal replacement therapy. You would give some treatment, supportive therapy for the liver, and you would give blood products, plasma products, and treat the deranged PT-APDT, and then just hope and pray that the patient recovers. But one thing which you must not forget, one entity which you must not forget is this. So we did these 3 biochemical markers of HLH, what is called as hemophagocytic lymphohistiocytosis, also called as macrophage activation syndrome. So the ferritin, which is normally up to 150, was 50,000 in this case. The triglycerides were massively raised, and the fibrinogen was very low. And with that, concomitant with fever, with the cytopenias that the patient had, made a classical case for dengue-related HLH. If this condition is unrecognized and is treated only as dengue shock syndrome, the patient it is usually fatal. So what happens in this condition is that in some situations, some viruses, certain bacteria, even tuberculosis, many of the common tropical viruses and bacteria that we see, these and sometimes in certain hematological malignancies such as in lymphomas, and thirdly in autoimmune disorders. What can happen is that normally when the virus comes in your body and activates your cytotoxic T lymphocytes, the cytotoxic T lymphocytes would have this perforin granzyme pathway with which it would dock onto let's say bacteria, and it would kill it, right, by digging holes inside the membrane of the target organism. It will kill that virus. But if it is for some reason, if this process is inhibited by what nobody knows, these mechanisms have not been deciphered. Sometimes patients have a basic defect, a genetic defect in their perforin granzyme pathway, which is not manifested until late in life. There are some patients where early in life itself, these things are manifested, right from birth. The children have a defect and they develop with HLH right from birth. But sometimes up to the age of 40, 50 years, you have never faced this problem. But all of a sudden, something just triggers, some infection triggers this defect, and therefore the cytotoxic T lymphocyte is not able to kill the target. And therefore, what it does is it keeps on secreting and more cytokines and activates the macrophages. Macrophages get massively activated, and then they will actually try and phagocytize everything that comes in its path, including normal red blood cells, normal white cells, normal platelets, normal liver cells, normal kidney cells. Wherever these macrophages are, they will kill surrounding subject and secrete cytokines, causing sepsis-like state and hypotension. This is all called HLH. The diagnostic criteria are: one, if you have a known familial defect or a genetic defect, which you often screen for in all patients of HLH now. And the clinical abnormalities are fever, splenomegaly, cytopenia of either of at least 2 cell lines, raised triglycerides and decreased fibrinogen, and a ferritin more than 500 nanograms. Remember, in our patient, this was 50,000. And then if you actually do a bone marrow or a target organ biopsy, you will see actual hemophagocytosis. You'll see the macrophages engulfing your normal red cells, white cells, platelets. And these are 2 other markers which are not easily available, but they're still a part of the criteria. But if you have any, say, 4 to 5 out of all of these, and the clinical setting is there, we now just call it as HLH and treat as such. And what is the treatment? The treatment is, you have to suppress the hyperinflammation with steroids and sometimes with cyclosporin, but most often it's only steroids. You have to kill the macrophages with a drug called etoposide, which is a chemotherapy drug, and you have to treat the inciting agent. So if it's tuberculosis, say, you have got good treatment of the source. The long-term goal is to replace the defective immune. So if you have a defect, if you have a perforin mutation in your genetic system, then you're going to require a bone marrow transplant in future. This keeps recurring. But most of the times, in patients, it is typically just one-time event. It comes and it goes away. So this patient received etoposide 50 milligram per meter square weekly doses for 2 doses, and dexamethasone 10 milligram IV BD. Patient rapidly stabilized over the next week with, of course, intensive supportive care in the ICU. Neutropenia was supported with filgrastim. Patient received blood products and ultimately was discharged in the normal state with normal blood parameters. But we have lost patients. If you diagnose these patients late, even in our hospital, patients have died with this particular condition, thinking that it is only an unusual manifestation of a virus. You must think of this condition whenever you have an infection such as dengue or leptospira or whatever infection, and something goes unusually wrong. The patient doesn't follow the regular, the regular course, and suddenly becomes worsened with multi-organ dysfunction. You must check the serum ferritin, triglyceride, fibrinogen, and then treat it with steroids, etc. If the criteria for HLH are not met with, you should not use steroids, because giving steroids in dengue shock syndrome actually just worsens the situation. It's of no benefit whatsoever. Only if you have proven that it is HLH, steroids will help. So with that, since I have limited time, I just wanted to cover these 3 emergencies. And with that, I thank you for a patient listening and thank IMA Akluj for this opportunity.
Thank you,
sir.
Dr. Samir. It was wonderful. This another 3 emergencies we learned from you. Thank you.
Thank you, sir.
Because of paucity of time and huge registration, question and answer is not possible.
Yes, sir.
Sir, can you please stop sharing the screen?
Yeah, I've done that.
Thank you. Yeah, thank you, sir. I request Namdar sir to please felicitate Melankari sir. Virtually, we have presented few e-mementos. And virtually we are felicitating sir. And now I request a coordinator, Dr. Nitin Rane, to felicitate Inamdar sir for chairing the session. Now for the next session, that is pathology, I request Dr. Shrikant Devdikar to please come on the stage to coordinate the session and welcome the chairperson for the session.
Good morning, everybody. As we can see, the conference is evolving into a very good, knowledgeable feast. We have already reached 1100 registrations online. So I would like to invite Dr. Santosh Doshi sir as the next chairperson for our topic, interpretation of coagulation tests by Dr. R. Manchanda madam. I would request Dr. Santosh Doshi sir to introduce our speaker, Dr. Manchanda madam.
Good morning, everybody. I am here from Pune.
Hello. She passed her MBBS in 1969 with gold medal. She also did her MD pathology from LH Medical College, New Delhi. She worked in Safdarjung Hospital, Maulana Azad Medical College and LH Medical College, New Delhi. She started practicing at hematopathologist and joined KM Hospital, Pune in 1984. Presently, she is a professor and director of pathology, head of hematohistopathology, KM Hospital, Pune. She is a postgraduate teacher of Pune University, past president of the Indian Society of Hematology and Blood Transfusion. She is a member of International Society of Laboratory Hematology. She had many publications, international and national, in international and international journals. Her special interest is in neonatal and pediatric hematology. With this brief introduction, I request Manchanda Madam to continue her lecture. Thank you.
Thank you so much for the kind introduction. I will just take a minute to share my screen with all of you. Am I audible and seen?
Yes, ma'am.
Okay, great. Very good. I don't see the, 1 minute, my, full screen. I can't, sorry, 1 minute. Can you make me full screen?
Hello, ma'am.
I can't come to the full screen. Can I? Wait a minute.
Ma'am, actually your screen is visible.
Yeah, but is it full screen?
Yes, ma'am. We can. Yeah, you can make the full screen.
That's the problem. I'm not getting that. Maybe I'll just decrease this.
Yeah,
Wait,
click that link, ma'am. The same link, yes.
yeah, wait a minute.
Ma'am, you
Right,
can just click
right
on the
lower
button.
corner where it's written 168%.
Yeah, okay.
More towards the. There's a screen icon over there to the left of your.
Yeah, I don't know what happened suddenly. I was quite fit. Okay. Wait a minute.
Just, yeah, just left side to the volume.
Yeah.
There's a screen icon. Yes, same, yeah.
I'm sorry, 1 minute. Where is it?
Can you see the second cursor on the screen?
Second cursor.
Yeah, that's moving now. To the animation. Please move your cursor, I'll tell you.
Here?
Yeah, take it to your right lower corner.
Yeah.
There's one comment scene. Comments are written. Comments. to the right lower corner. There are two options, notes and comments.
Notes and comments.
Yeah, you have to move right towards it.
Sir, let me help here. Ma'am,
I don't know, I had the
ma'am, go on the
screen.
top, click the slideshow button on the top, on the left.
Sorry?
On your left, there is a button called slideshow.
Ah, now I can see.
Yes,
Okay.
click on that.
Yeah, yeah. Okay.
Now click on the first button that says from beginning. On the top, ma'am. Top left, first button.
I'm sorry for this. I was all set and I don't know suddenly what happened. Anyway, thanks for helping. Technology sometimes, you know how it is. This thing is am I audible and clear?
Yes, ma'am.
Okay, great. Thank you, IMA Akluj and Dr. Doshi for inviting me to talk on this very, very complex topic of coagulation tests, its interpretation and how it affects us. It is very important to understand this because it affects all the branches of medicine. We know, coming to the basics, that arrest of flow of blood from an injured vessel involves three processes: the contraction of the blood vessel, adhesion of the platelets to form a platelet plug, and then the coagulation cascade starts. We have here the classic coagulation cascade, which all of you are very, very familiar with. And this is what we have been taught always, the two pathways, the extrinsic pathway and the intrinsic pathway. We know that the two pathways are here very separate. The extrinsic pathway starts with the tissue factor, activating factor 7, coming to factor 10 and starting the common pathway. On the other side, the intrinsic pathway starts with factor 12, activating 11 to 9, using 8, coming to 10, and again joining the common pathway, and form what is known as the blood clot. The fibrin is formed from factor 1, that is fibrinogen. Factor 13 is there, which stabilizes the fibrin. However, it always intrigued us that how in the body decides which pathway to take when there is an injury. Take the extrinsic pathway or the intrinsic pathway. It's very difficult at that time, nearly 40 years back, to understand. However, we have now evolved and we are much advanced, and we know that this is not what is happening inside the body. What is happening inside is the physiologic coagulation. This is what is happening inside the body. Starts with tissue injury. Of course, that's the center point, with tissue factor acting 7 coming to common pathway, forming fibrin. But this is also interacting 7 and tissue factor complex activates 9. If you see here, uses up 8, comes to 10. Again, the common pathway. However, the center point is the thrombin generation. This thrombin generation goes and activates factor 11. If you notice, factor 12 is out of physiologic coagulation pathway. It has no role in the normal physiology of coagulation. So that has been taken away. It is a contact factor. Kallikrein and high molecular weight kininogens, they are not part of the normal coagulation. So it's very important to understand what is happening. Now, coming to the proper physiological coagulation, the injury contracts the blood vessel, platelets come, get activated, they try and form a plug. On this other side, the injury causes collagen to be displayed to the blood and activating the coagulation factors. to come and form in the plug which has been formed by the platelets to form a network and fibrin strands to form a very nice clot, which is stabilized with the help of factor 13. What is the screening coagulogram? Then what do we do? So we would like to see all the elements, that is platelets, the coagulation factors. So you do hemogram to look at the morphology of the platelets and the count of the platelets by doing the bleeding time. Clotting time is the clotting factor, screening test, platelet count, platelet morphology. Clot retraction is another platelet function. Besides these, we have the coagulation test with the prothrombin time, activated partial thromboplastin time, thrombin time, and urea solubility test, which is for factor 13. Doing all this gives us a complete evaluation of the coagulation process. This affects all the branches of medicine, right from neonates to obstetrics, pediatrics, cardiology, orthopedic, and we are the center for you people to understand. But please understand, the interpretation of these tests changes from a neonate to a cardiologist to an orthopedic or an obstetric specialist. How it does, we will come to this a little later. Now coming to these, the first four, these in red are basically related to platelet number and platelet function. Last four are basically for the coagulation pathway, clotting factors. We know platelet count is normal if it is more than 150, thrombocytopenia less than 150, spontaneous bleeding occurs when the count is less than 20. But with that, if you have giant platelets, it's more likely to be ITP. If they are very small platelets, probably it's a marrow failure syndrome that you're looking at. Less than 50,000 will only bleed on injury. And if bleeding occurs at platelet count more than 40,000, please look for platelet function defect. So looking at these, we have a lot of people, let's say dentists, surgeons who are always ordering TBC, platelet count, BTCT, and maybe at the most PT. Now, BTCT PT will never give you a complete evaluation of the coagulogram, because as I go along, you will understand that this is totally incomplete. You are only looking at one arm of the coagulation. APTT and thrombin time with clot solubility test factor 13 will complete the clotting procedure. How we report in our hospital, the coagulation profile is always reported like this, with last clot solubility test, which is the parameter for factor 13 deficiency, and without an interpretation, the whole screening coagulogram is no importance of no value if a pathologist or a hematology lab is not giving you the complete evaluation with an impression. It must write what does that, all these readings, what do they mean? Now, here you see I have put a classic coagulation cascade. I have come back to classic coagulation cascade because in the laboratory, please understand, thank God for that, we have separate system, the extrinsic system and the intrinsic system. Because the tests when we perform with the reagents, they are evaluating two different systems. There is no interaction between these two in the laboratory, and that is how we can give you the complete picture by eliminating certain things and giving you the report of which is the factor which is deficient. Coming first to the prothrombin time, if you see this and this red circle, prothrombin time is tissue factor which is thromboplastin, part of the reagent, combines with factor 7, gets activated and comes to common pathway 10, 2 and fibrinogen to form a fibrin, and that is your prothrombin time. It is only evaluating 7, 10, 5, 2 and 1. It's not telling you anything about the other factors. So prothrombin time is expressed, all of you are familiar with, it is expressed as a test over control in seconds, or you can report it, we report sometimes as ratio. INR is the normal, INR is the international normalized ratio. Why this was devised? Because there was a lot of variation between the laboratories on the prothrombin time test. I will come to this a little later for you to understand. Because the reagents that we use have a different ISI, that is the International Sensitivity Index. Depending on the reagent that we use in the laboratory, your PT ratio will change and your subsequently INR will change. And that is how it's important to know what is your INR according to the ISI ratio. This the laboratory must understand and give you the correct reading. Now coming to the prothrombin time, we know it is 10 to 14, normal 0.8, 1.2 INR. If you are doing anticoagulation, normal 2 to 3 times. However, for cardiologists, for valve replacements, you probably would prefer 2.5 to 3.5. However, please understand these days, number of newer coagulation anticoagulants are available, which do not need any monitoring for these, but still there are many patients who are on warfarin, and you will require the monitoring by prothrombin time. Now, why does variation occur in the INR? It's very important to understand right from blood collection. So when the blood sample is collected, it should be for people who are on warfarin. We advise to please collect it at the same time every time they come for the test. Use the same reagent. As I come along, you will understand. Because different reagents will give you different ISI. Analytical methods also change your INR sometimes. So it's important for the laboratory to know. This is especially for all the pathologists in the audience, that the analytical methods also change. It depends on the method used and the method of clot detection. Let's come to a case. This is a 54-year-old male smoker, headache, had hemoglobin which was very high, PCV which was very high, WBC platelets were normal, prothrombin time was normal, however the APTT was prolonged. How do you interpret a case like this? You must know blood collection. If you see, sorry, I want this out of the system. If you see that the person is polycythemic, what we are anticoagulating is the plasma, not the RBCs. We are taking 50% RBC, 50% plasma, and our blood collection of 9 volume blood to 1 volume anticoagulant applies to this. However, if we put the same anticoagulant to half the amount of plasma that is happening in this individual, you will realize that we are diluting this patient's plasma factors. Obviously, the reading is going to be high. Same thing happens to neonates who are polycythemic. Plasma is very little, but you are diluting with the same amount of volume of anticoagulant. You are diluting the coagulation factors. Similarly, patients who are severely anemic, you have large amount of plasma, you are under anticoagulating your sample. So this has been what has been worked out. It's good to talk about this, but once you collect the sample, you do not know what is the PCV of that individual. However, while you are interpreting, you must know that if it's a severely anemic or polycythemic individual, you must take it with a little pinch of salt. that the reading may not be giving you the correct evaluation of that patient. Let's come to another patient. She is 65-year-old female, aortic valve replacement, stable with an INR of 3.5, visits a doctor in another city, and the INR comes to 2.6. She thinks that she must change her dose and is very confused. Please understand that prothrombin time test is influenced by the reagent that we use, the technique that we use. So it's very important that what is the reagent? Basically, it's a thromboplastin plus phospholipid, can be derived from human placenta, brain or lung, or animal source, or recombinant. Different labs use different reagent. So the sensitivity of each is very different coupled with other things in that reagent. Now these sources, animal brain, you can have a lot of variability. You can understand one animal may have more thromboplastin than another, and the quality of phospholipid will depend on the extraction process. Of course, you may not have all the animals when you want them. The company who makes the reagent may have a short supply, and you have animal rights people running after these companies to not use the rabbit brain for making these. So many companies are using human tissue factor, mainly from placenta, and these are also in short supply and are source of HIV and other viral infections. However, these days we are using recombinant tissue factors because it has control over the combination and the sensitivity with less lot-to-lot variability. So we would prefer a recombinant tissue factor reagent for prothrombin time. We know that factors affecting prothrombin time, it's important for you people to understand that many medicines can affect the prothrombin time reading. Besides that, severe diarrhea and vomiting will affect it. Many foods which we eat, like green leafy vegetables like spinach, can affect it, especially people who are on warfarin or oral anticoagulants. Drinking a lot of alcohol will affect your prothrombin time readings. Many herbal products are in use these days. Please understand, they will also have an effect on your prothrombin time readings and affect your INR. Now coming to the second test, which is the activated partial thromboplastin time. It's a very non-specific.
Hello.
Yes, please.
Yeah, ma'am. Sorry to disturb you. Because of the time constraint, we would like to consider cutting down the time.
Okay, I will
Yeah,
quickly finish
thank you.
this then. Okay, and these reagents are also there, and this, I'll just quickly go. ABTT is telling us right from factor 12 to coming down. You can see it takes more time. This 12-year-old boy was for operation, but because of more clotting time, the screening coagulogram also showed the same. The surgery was postponed and he was not put up, but we must realize that factor 12, which is working in the lab, is clinically not a bleeding clotting factor, which affects clinically. And we have to use another reagent. So please understand, different labs must have different reagents. Those which are using for coagulation labs must use factor sensitive and ox-gynae lupus sensitive. We in our lab keep both the reagents. Especially 2 slides for neonates. Neonates, if you have a neonate with a 40 APTP, please understand that the coagulation proteins do not cross placenta and the reagents are the same. But if you can see that the readings of other factors are half that in the term neonate. So their APTTs cannot be compared to adult controls, but that's what we have in the labs every day. No normal baby will come and give us a control sample. Normal term infants have more APTT. So coming to the coagulation, final slide, ET, APTT and thrombin time are 3, which will tell you cover all the coagulation factors, except it will not cover factor 13, for which clot solubility test is the one which should be there. This is for pathologist friends. So friends, interpretation of coagulation tests, all should be interpreted with caution. Do not change the laboratory because the reagent used and the method used is different. Neonates have to be interpreted very carefully. Don't ever evaluate a neonate for an inherited factor deficiency. Thank you so much. Sorry, did I overstep my time?
No, ma'am. It's
Thank
okay.
you
It was
so
a
much.
wonderful. Thank you, ma'am. It
Thank
was
you.
a wonderful presentation, and I request Dr. Santosh Joshi, sir, to felicitate ma'am. Ma'am, can you please stop sharing the screen?
Yes, please. Yes.
Yeah.
Thank you.
I request sir to thank you, ma'am.
Thank you so much for inviting me and sharing some of the pathologist's views.
Hello. Thank you, ma'am, for your nice information. Thank you.
And I request Dr. Shrikant to felicitate sir for chairing the session. Thank you, sir, for taking out time and chairing the session. Now I request Dr. Abhijit Gandhi, sir, to please coordinate the next session. The lecture is on upper GI bleed.
Good afternoon. Next lecture is by Dr. Rajendra Pujara sir on upper GI bleed. I would like to invite Dr. Arvind Gandhi sir to chair the session. Dr. Arvind Gandhi sir is a senior general surgeon practicing since last 45 years. He has done his MBBS and MS from JJ Medical College, Bombay. I would like to invite Dr. Arvind Gandhi sir.
Dr. Rajendra Pujara, who is a known consultant gastroenterologist and interventional endoscopist. He is honorary consultant in Department of Digestive Disease and Liver Disease in Dinanath Mangeshkar Hospital. He has performed many endoscopic procedures such as luminal endoscopy like gastroscopy and colonoscopy, ECPR. He endoscopic ultrasonography and intervention, third space endoscopy like Akluj cardiac. He has attended many conferences nationally and internationally. He has presented papers in nationally and international conferences, and he has taken part in teaching juniors in conference. Ladies and gentlemen, I introduce Dr. Rajendra Pujara and request him to enlighten us on upper GI tract bleeding management. Thank you.
Hello, over to you, sir.
Yes, am I audible?
Yes, sir.
Okay. Thank you for a kind introduction, sir. And I like this another surname, Pujara, because Cheteshwar Pujara is our cricketer. So I like this. Thank you so much. So at the outset, I congratulate the entire team of Akluj IMA for organizing such a fantastic state level conference with such a huge response. So without much ado, I'll start the presentation. Is my slide visible? Hello?
Yes, sir. Yes, sir.
Yeah, okay. So the today's topic of discussion is upper GI bleeding, its approach and management. As you all are aware, upper GI bleeding is one of the most common emergencies in the field of gastroenterology. And the name itself suggests that the bleeding originates from esophagus, stomach and duodenum, that is anatomically proximal to the ligament of Treitz. And it typically presents with hematemesis, that is vomiting of blood, If it is bright red, it suggests that the bleeding is ongoing. If it is coffee colored, it suggests that the bleeding has stopped some time ago. Melena is a passing of black cherry stool, which is a result of degradation of blood products and formation of acid hematine. At least you should have 100 ml of blood into the small bowel to cause melena. Hematochezia is typical fresh red blood in the stool. It suggests bleeding from colon. However, if upper GI bleed is severe and brisk, it also can present with hematochezia. So if you see the epidemiology, the most common cause of upper GI bleeding is peptic ulcer, and it accounts for 30 to 40% of the cases. However, despite of advancement in medical treatment, endoscopic management, ICU management, still the mortality is around 10 to 12%. Bleeding of upper GI tract is self-limited in 80% of the cases. However, those 20% of the patients who continue to bleed, the mortality is very high, it's almost 30 to 40%. So, what are the causes? The UCLA, University of California, Los Angeles, have published this meta-analysis study. And if you see the frequency, the most common cause is peptic ulcer, then esophageal and gastric varices, then severe erosive esophagitis, malarious tear, erosive gastritis, duodenal lesion, upper GI malignancies, especially esophageal cancer and gastric cancers, angiodysplasia, and in 8 to 10% of the cases, you don't find a cause. And this is an interesting pie diagram published by UCLA. If you see before 2000, ulcer is the leading cause, almost accounting for 60% of the cases. Now, after 2000, the frequency of the ulcer as a cause, main cause of the GI bleed is reduced from 60% to 33%, and gastroesophageal varices, they are going up from 12 to 18 to 20%. So it is important to stratify the risk, or the risk stratification is of utmost importance whenever a patient of upper GI bleed comes to you. There are various scores. The most important score which you do is clinical Roccal score for peptic ulcer disease. The important factors are high age, presentation with shock and orthostatic hypotension, associated comorbidities for variceal bleeding, advanced age, hypotension, low albumin, altered mental status. So higher the score, higher is the risk of mortality, length of hospitalization, and cost of hospitalization. So this helps in prognostication and giving a little bit broad idea to the patient's relatives about overall patient's management. So the most important thing in upper GI management is an initial assessment. So initial assessment involves a proper history, which includes does patient have abdominal pain, any history of NSAID, which may point out towards peptic ulcer disease, history of vomiting, weight loss, early satiety may reflect malignancy. Syncope can suggest that patient must have bled significantly. Then examination is very important. Tachycardia, hypotension, orthostatic hypotension indicate that patient has bled significantly. Then again check for abdominal examination, do if there is any surgical scar, severe abdominal tenderness, again points out towards peptic ulcer disease. Check for signs of chronic liver disease like edema, ascites, splenomegaly, that points out towards chronic liver disease. Lab, we all know we have to routinely send the labs like hemogram, hematocrit, biochemistry, liver function test, INR, grouping cross matching. Again, certain parameters may suggest certain disease. A low platelet count and low albumin can point towards a chronic liver disease. Deranged INR, prolongation of crew time indicate that patient may be having underlying chronic liver disease, or patient may be taking anticoagulants like warfarin. Now, which patient need which kind of admission? If patient is bleeding severely, has hemodynamically compromised, then this patient need ICU. Or those patients who have acute mild to moderate bleeding, but they are hemodynamically stable, they can be hospitalized in step-down units. So management of upper GI bleeding involves three important parts. First is optimal medical resuscitation. Second is initiation of medical treatment. And third is intervention. So intervention can be either endoscopic intervention, radiological intervention in the form of angiography, or a surgical intervention. So we'll come one by one to all these things. So as you all know, registration is the most important thing. It should start immediately in the emergency department. Put a large bore IV cannula, start infusing with normal saline or plasma expanders, keep systolic blood pressure above 100. Then transfuse patients according to hemoglobin level, keep HB level above 8. As just discussed in previous talk, check for INR. If INR is deranged or prolonged, FFPs, as well as vitamin K, platelet transfusion if platelet count is less than 20. Don't over transfuse the patient. Over transfusion can raise portal pressure, in particular in patients with gastroesophageal variceal bleeding, and it can aggravate the bleeding. So main aim is to keep the hemoglobin at around 8. Don't over transfuse the patient. So all patients' vitals should be frequently monitored in ICU. It is important that in patients who are having active ongoing bleeding or patients who have altered mental status, all these patients should have endotracheal intubation to protect the airway and to prevent the risk of aspiration. And again, urinary catheterization and output monitoring, particularly in patients with ongoing GI bleed or those who have a comorbidity. Now, endoscopy. When to do an endoscopy? Endoscopy should be involved right from the beginning of the management of GI bleed. The timing of endoscopy is very important. Endoscopy ideally should be done when patient is hemodynamically stabilized, systolic pressure is maintained above 100. If there is ongoing bleeding, you protect the airway by doing endotracheal intubation. Coagulopathy and thrombocytopenia should be corrected before subjecting patient for endotherapy. And another important aspect is putting nasogastric tube. It's very important because it serves three purposes. It evacuates the clot, decompresses the stomach, prevents the risk of aspiration, and allows a better endoscopic visualization. Again, returning lavage. If it is bright red color, that indicates that patient is actively bleeding, and coffee color indicates that patient has bled but bleeding has stopped. So that determines when one should intervene endoscopically. Ideally, endoscopy should be done using a dual channel endoscope. You can see over here, this is a therapeutic dual channel endoscope which we normally do in our endoscopy unit in Dinath Mangeshkar Hospital. It has got two working channels. One working channel sucks the clots, another working channel irrigates with the water pump that dilutes the clots. So it causes rapid evacuation of the gastric content, allows a better visualization. Since there are two working channels, assistant and an operator does a very good and better job than doing a normal gastroscopy for a hemostatic control. So when you should do, when patient is hemodynamically stabilized, in patients with esophageal or gastric variceal bleed, optimally stabilize the patient and then you can do an endoscopy within 6 to 8 hours. And if there is severe ongoing bleeding, high volume bloody gastric lavage, then this patient should be subjected for urgent endoscopy. So there are various equipments which we use for endoscopic hemostasis, and one of those or combination of all these equipments which we use, this is injection therapy by giving a diluted adrenaline which causes vasoconstriction and allows a better visualization of the bleeding surface. Then endoscopic hemoclips to clamp the vessel, then thermal or coagulation probe to electrocauterize the vessel, then endoscopic variceal band ligation, and the advanced endoscopic equipments like OTSC clip and US guided coiling, which I will deal in subsequent slides. So the two important conditions of upper GI bleed are, one is variceal bleeding and another is peptic ulcer bleeding. So for variceal bleeding, you want to know varices are the result of portal hypertension. These are the dilated tortuous mucosal veins. And doing variceal band ligation, what we do, we suck the varix inside the cylinder which is mounted on the endoscopic tip, and then we suck the varix, apply a band, thrombose. The idea is to thrombose the vessel, fibrose the vessel, and then the varix gets sloughed out. In a big meta-analysis study, it has been found that variceal band ligation has been found to be more effective in reducing the mortality, in reducing the chances of rebleeding over sclerotherapy. Nowadays, in our department, in acute active GI bleeding, we don't use sclerotherapy. So this is an example of a patient who presented with a middle-aged patient, chronic liver disease, presented with massive variceal bleeding. He was stabilized in the ICU and now referred for endoscopy. You can see over here large dilated tortuous vessels, right from the lower end of esophagus going up. And then what we do is we get the varix sucked inside the cylinder and apply a band. You can see over here, varix has been banded. There are 3-4 such large vessels, so every time we suck one varix and apply a band, and this is how we control the bleeding. This is another example of giving a cyanoacrylate glue injection for a fundic varix. As you know, fundic varices are more notorious. They cause torrential and massive bleeding because of high portal pressure, and they are controlled by giving a glue injection, that is cyanoacrylate injection. You can see over here a large varix with massive bleeding, and now you can see over here on endoscopy a varix of around 3 by 3 centimeter in size, and a glue injection, that is cyanoacrylate, is injected inside the varix. Cyanoacrylate, when comes in contact with the blood, it clots the blood and it thromboses the varix. You can see over here, varix is well solidified by giving an injection. Another injection was given, and this is how a bleeding from the gastric varix is controlled. These are the advancements in the treatment of controlling peptic ulcer bleeding. This is called as OTSC clip. This is a large surface over the scope clip which is mounted on the surface of the scope, and you can see over when it is deployed, it takes the larger surface area, it takes the mucosa along with the vessel and effectively controls the bleeding. The only problem with this is it has got very high cost. It costs around 50,000 per clip. Another advancement is endoscopic ultrasound guided coil embolization. So this is a bleeding from gastric varix. Patient is coming repeatedly with upper GI bleed and hematemesis, and this is what we have done. We did, and you can see over here large patent varix. Are you able to appreciate this? And on endoscopic ultrasound, you can see a large patented varix. This is a real-time endoscopic ultrasound. A varix is punctured with the help of a needle of 19 gauge size, and you can see a coil is been deployed inside. Once the coil is inside the varix, it clots the varix, and this is how a varix is solidified. This is around 3 by 3 centimeter varix, which has been completely obliterated by putting a coil inside the varix. This is another advancement in the treatment of endoscopic hemostasis as far as varicose bleeding is concerned. Now, rebleeding rates. After endotherapy, 10 to 30% of the patients, whether peptic ulcer or varicose bleeding, they bleed. However, in 70% of the cases, you can again control by doing a repeat endoscopy. However, if 2 endoscopy sessions and still bleeding is persistent, then such patients should be subjected for radiological intervention if facilities are available, or patients should be subjected for surgery. Under radiological angiography, you see a bleeding vessel and you can embolize that vessel by an interventional radiologist. This is particularly useful in elderly patients or patients with severe comorbidity. Now, when is the role of surgery? Surgery, an immediate surgery is required if patient is having exsanguinating bleeding, who is not able to stabilize medically. Such patients should be subjected for urgent surgery, or surgery should be preserved for such patients when an endoscopy feels that the vessel is very large, is very deep in the posterior duodenal ulcer, which represents or which might represent gastroduodenal artery, or a vessel which is coming from the gastric ulcer near the lesser curvature, which might be a branch or itself of a left gastric artery. Such vessels should be left for surgeons, and surgeons will do a better job and great job rather than an endoscopist. And this is one passing sentence on duodenal lesion. You can see over here, this is the submucosal artery of 1 to 3 millimeter size, which has protruded onto the mucosal surface, and they bleed torrentially. The only difficulty is they bleed intermittently. So many times the endoscopy, if you do, you don't find a lesion when the patient is not bleeding actively. And this is I am lucky that this patient presented with repeated history of upper GI bleed. On 4 occasions, gastroscopy was done outside, was normal. Here also you can see over here, stomach is normal. Fundus is looking normal. Duodenum is normal, and surprisingly, for my luck and for patient's luck, you can see over here, the vessel was actively bleeding, and within a fraction of a second, there was a torrential blood. The entire fundus was filled with the blood. I could get just 10 to 15 seconds time to control this bleeding. We have a well-equipped endoscopy unit, so I use the hemoclip to control this bleeding. You can see in a while, here hemoclip is being applied. You can see over here, the hemoclip mechanically clamps the vessel and stops the bleeding. You can see over here, that patient needed 2 to 3 clips to control the bleeding, and now you can see the entire fundus is clean and the procedure went uneventful. So this is the advantage of using a hemoclip. Malarious tear, you all know, is a tear in the lower esophageal mucosa after bouts of forceful vomiting due to sudden increase in intra-abdominal pressure. Most of the times, bleeding is limited. However, if there is active oozing, you can control bleeding by injecting diluted epinephrine or by applying a hemoclip. So this is another example of a bleed post ERCP sphincterotomy bleeding. You can see over here, patient came
So 24 hours after ERCP with massive bleed and hypotension, patient was resuscitated, transfused, and then was sent to the endoscopy unit. You can see over here large pulsating vessel at the base of sphincterotomy. And this is a coag grasper. With the help of this coag grasper, electrocoagulation current was applied and the vessel was cauterized. And we could able to control the bleeding and we could able to stop the bleeding. So these are different arrays or armaments which we have, and we use combination of all these equipments to control the bleeding. And you can see over here a coag grasper being opened up, and the grasper is applied at the base of the vessel, and we electrocoagulized the bleeding vessel. The post ERCP sphincterotomy bleed can be very massive and can be life-threatening at times. However, we were able to control the bleeding completely. You can see over here a nice clean surface now with no bleeding. So, to summarize the entire thing, this is a treatment algorithm or management algorithm. A patient with severe upper GI bleed, get a proper history, do a proper physical examination, send all bloods,
Group cross-matching, CBC, transfuse, FFP, do LFT, do a biochemistry panel, then see which way patient is going. Hematogesia, shock, syncope, severe comorbidities, admit in ICU. Vital stable, laboratory findings normal, no active bleeding, admit in standard hospital unit. If hemodynamic restoration should be continued, it should be ongoing. Gastroenterologist should be consulted immediately. Now, before calling for endoscopy, if patient you are suspecting that this is a esophageal gastric varicose bleeding, start with octreotide or start with terlipressin, because both of these drugs they cause splanchnic vasoconstriction, reduce the blood flow, reduce the portal pressure, so they help in reducing the blood bleeding. And urgent endoscopy is to be done once patient is stabilized within 6 to 12 hours of presentation. Now, if you are suspecting peptic ulcer disease, start with PPI, check for hemodynamic stability, hypotension, vomiting, hematogesia, place NG tube, see further returning lavage if it is massive, urgent surgery. If it is not massive, stabilize the patient, refer the patient for endoscopy, use hemoclips, coag probes, or over the scope clips to control the bleeding. Now, with this, if you can't control bleeding by endoscopic management, then you have got two options: either refer patient to radiological intervention by doing angiography and embolization. If this facility is not available, refer such patients to surgery, because surgeons will control such bleeding nicely, particularly in patients with peptic ulcer bleeding. So with this slide, I am going to stop my talk. Thank you so much. Because of constraint of time, I have skipped some of the slides. We'll talk about them in subsequent conferences. Thank you for kind and patient listening. I am happy to answer if you have any questions. Thank you so much.
Stop sharing the screen, sir.
Yeah.
Now I request Arvind Gandhi, sir, to thank sir and felicitate him with e-memento. Arvind Gandhi, sir.
Dr. Pujari, you have made the subject very simple, and I
Thank you
hope
so much.
we will be in a position to treat the patient with this new light. Thank you very much again.
Thank you.
I request Dr. Abhijit Gandhi, sir, to felicitate Dr. Arvind Gandhi, sir, for chairing the session. Thank you, sir.
We feel so sorry that there was some technical issue. We are back to the conference. For the next session, topic is medical legal aspect in emergencies. Speaker will be Dr. Nilesh Tumram sir, and the chairperson will be Dr. Rajiv Rane. And the next session is the common surgical emergencies in Nigeria. Professor Boshu Islamia will deliver the lecture. And for that, I'll call upon chairperson as a Dr. Dobada. He is a senior surgeon from the Akluj. Please welcome, sir. For the topic medical legal aspect in emergencies, I will request Dr. Rajiv Rane sir to introduce Dr. Tumram sir. Thank you.
Hello. First of all, thanks for IMA conference team to give me such an honor for chairing this session. Every medical practitioner has to face emergencies in his own practice day by day. And when emergencies comes, mortality, morbidity is a part of that process. And when emergencies, mortalities are there, medico-legal aspects, they arise. And how to tackle all these medical aspects. And in that situation, Dr. Nilesh, eminent personality as far as medico-legal aspects are concerned in this subjects, he will be guiding all these things. He is MBBS and MD in forensic medicine. Besides medical degrees, he is LLB, the postgraduate diploma in medical ethics. He is also a fellow of American Academy of Forensic Medicine. At present, he is HOD in Chandrapur Government Medical College. So I request Dr. Nilesh to proceed his speech.
Hello. Dr. Nilesh. Hello.
Hello.
You can share you can share your screen, sir.
Yes.
Is there any issue?
Is it shared?
Yes.
Am I audible to everybody and visible?
Sir, your screen can't be seen, sir. I suggest you share it again, try sharing it again. Yes, it's visible now. Please go to full screen.
Yes. Shall I start?
Yes, sir.
Yes, sir.
Yes. First of all, very good morning to all the delegates of AMSCON 2021. And thank you for inviting me for delivering this topic. Today's topic is related to the medico-legal aspects in emergencies. Now, it is a very vast topic, but we will try to cover some important points which are related to day-to-day activities. Yes. So regarding the medico-legal aspects, as a doctor or as a medical practitioner, why we need to know this, why it is important. So first and foremost is for avoiding to getting sued is the important thing, because the litigations are increasing against our medical fraternities nowadays. So it is very important to know various medico-legal aspects. We as a doctors are now employee to various corporate hospitals. So we can make our employers tension free, whether in government or in private. That is also a very important thing. Also to prosper in our practice without getting any blemish. Because nowadays it is very hard to earn name, but it is very easy to put down our name with one or two single incidences. Last is to avoid any adverse or untoward situations which may arise due to lack of knowledge of this medical legal aspects. So these are the important things for which as a doctor we should know the various medical legal aspects, that too in emergencies. So what medical legal aspects arises in emergencies? Now there are n number of things which can be there. First and foremost is the consent part, which is very important. Now, patient confidentiality, competence of the patient, documentation of various records by the faculty. Duty of care, yes, the duty of care is the foremost thing. Nowadays, we give our duties as a specialist to some RMOs or some subordinates. So, whether we have the duty of care during that treatment, so this can be a very important medical legal aspects which can arise in emergencies. Giving advice, transfer of responsibility. Sometimes we might not be available, so transferring that responsibility, that can also become a medical legal aspect. Very important thing is discharge against medical advice are sometimes asked by relatives or patient. Absconding of patient without informing. So what a doctor should know regarding this. Refusing the given treatment. Now patient has the tendency now to move to various other treatment modalities. So they have all the right to refuse the treatment. So as a doctor, we should know what are the various aspects for this. And last is the medical legal reporting. Now, this is also a very important thing. It can be related to the life and to the morbid or mortal patients. So in today's topic, what we will be covering is some important parts like the duty of care, consent, competence or capacity of the patient to give consent, patient confidentiality, discharge against medical advice. So what we as a doctor should do in that thing, and refusing to give refusal by a patient for the given treatment given by the doctor. And what are the various things that can come under negligence? Now these all topics are very vast. It will take lots of time, but still we will cover it within our respected time of 20 minutes. So first is, what is the duty of care? As a medical practitioner, it is the first and foremost important thing before starting any sort of medical examination or treatment, that we must be having the duty of care to us. So we should be doing not the best. We should always try to give the best treatment, but it is expected that we should give a reasonable care and treatment to our patients. So that is the important thing. So first and foremost important thing before starting, a medical practitioner should know that they are duty bound for any medical examination or treatment. Now this should be done in best of patient's interest and best of the doctor's ability. Now it should be the best, but it should at least be a reasonable thing. So best is what is expected. It should be appropriate to the situation at which the patient has come to us in an emergency situation. Should be appropriate. Whatever appropriate things needed to be done should be done to the patient. Important thing in all this discussion is that we should be reasonable while managing our patients. So while patient management, reasonable degree of care should be there. Now this duty of care, if you are lacking or if you are not providing, so your lack of providing this reasonable care will determine the degree of medical negligence. So this duty of care as a doctor we should know. Now questions where duty of care arises in medical emergencies. Now patient are coming with sudden cardiac arrest. We might not know what had happened to the patient, which has come to us in an emergency situation. He might be a heart attack case or poisoning case, head injury case. So he might have come in with sudden cardiac arrest. So that thing we should know how to diagnose, how to manage that thing. End of shift while we as a doctor are on duty. Now this is also very important thing कि मेरी shift खत्म हो रही है अभी. Now the next doctor will see. So we should always remember that this is also a very important medical legal things can happen during this period. Now, medicines which are prescribed during process of emergencies. Emergencies are always a very emergent thing. So it can be everything from head injury to poisoning. We might not know because we are just having that patient to us. We are yet to diagnose that thing. So whatever medicines we are prescribing, that can arise to the various medical legal aspects in medical emergencies. Now, clinical knowledge while attending such medical emergencies, do we, the doctor who are there at the time of attending such cases, have that clinical knowledge to attend that patient. So if it is a surgical case, it should be attended by a surgical or a specialist. So the consultant responsible or the specialist responsible should be attending the medical emergencies in such cases. So now in all these aspects, before starting any treatment, whether in emergency or in elective, we need consent. Now medical treatment requires patient consent. Now it might be implied, oral or written. So there are various aspects of consent. We will not go in details, but this is a broader thing. So we should always know. So why consent is necessary is we should involve that patient in decision making of his or her treatment and care. We should not be paternalistic while our attitude to give treatment. So in this, let the patient decide whatever the treatment we are going to impart to him. So let him decide so that he might not be in dark that मेरे को तो डॉक्टर ने बताया ही नहीं कि ऐसा कुछ करने वाले थे या ऐसा कोई फीस मेरे को 10,000 के हिसाब से है but fees was charged with 1 lakh rupees. So let the patient decide before making any treatment and care. So for that consent is very necessary. Should always be taken whether it is an emergency or any elective procedures. So what is the valid consent? It should be acceptable legally. The person who is giving should be legally capable, should be competent. He should not be a minor or a person who is under somebody's guardianship, mentally ill or disabled or having under influence of any drug or some alcohol. So consent must be informed, specific, freely given, and must cover the procedure or treatment which actually would be done. So these are the all important aspects of valid consent in any emergency situation. So as a doctor, we should be going with this consent thing. So informed consent must be clear, accurate, relevant, and whatever material we will be doing should be there in that informed consent. So it should give the patient various treatment options. What are the consequences if he or she is taking the treatment, and what are the consequences if he or she is not taking the treatment should be mentioned in such informed consent. Now this is very important because nowadays the litigations are there कि हमको तो कुछ बताया ही नहीं, हमको कोई option भी नहीं दिया treatment का. So such thing will land us for various medical legal issues in future. So informed consent must be there. It should not be a blanket consent कि nurse के पास से form sign करवा लो. We as a doctor should try to have this thing. Yes, it is very difficult for busy doctors, but we have to impart the informed consent with all these aspects. Now we have discussed the competency and capability. So capability to consent in difficult situation. As a doctor, we have to determine that the patient has capability to give consent. So doctor should know before following or before taking any consent whether the patient is children or adolescent. Now it is the doctor's prudence to notice or take notice which patient's consent we should take. So whether he is a children or adolescent, that we have to think, whether that person is mentally sound or ill, that we have to think before starting our treatment, whether he is under any influence or his cognizance has been affected by some alcohol. And last is, in emergency department, persons are coming in unconscious states without any near and dear with them. So in such situation, who will give the consent? That thing must, a doctor should be aware whose consent we will take. So if it is a dire necessity, then in such cases the doctor can proceed for the emergency treatment without any consent if it is done in good faith. This thing we as a doctor should know, so that there should not be any delay or delay in treatment of that patient. Now, as a doctor, we should know regarding this consent what is capacity and what is competence. So, capacity is the decision-making ability or understanding or comprehension of the patient. Now, this capacity has to determine by doctor. So, it is the doctor's role to determine capacity of the patient to give consent in such emergency situation or their relatives. While the competence relates whether the patient or person is legally able to manage their affairs or not. That is, yes, they should be presumed to be adult, but here there's the court's role to determine that. So competence is related to the court's role to determine, and capacity is the doctor's roles to determine. So how we determine capacity is to functionally assess the patient, whether for his name, time, place, person. So functionally we can assess ability, determine ability to understand the information whatever we are giving, whether the patient is appreciating the situation and is well aware of the consequences which might happen. The patient might be rationally enough to manipulate or to understand the information whatever we as a doctor or health provider is giving to him. He should be able to communicate a choice whether he is going to forward for the treatment or not. So he should be able to communicate. He should not be under some fear. So understanding, belief, reasoning, and choice should be there to determine the capacity of that patient to give consent. Now during emergencies, many of time we get information which are of confidential nature. So the privacy and confidentiality during emergency nature is very important and very important medico-legal aspects. So information gained in doctors-patient relationship shall remain confidential. Now there are some gray area which still exist. However, such confidentiality have some exceptions such as notifiable diseases like currently the COVID thing. So in that case, we have to not be remain confidential regarding that. The cases where mandatory reporting is necessary. If the person has committed any crime or if it is a medico-legal case, so in that case, the practitioner has to inform or have to reveal that thing or that information which he has gained, or else he will be land in trouble for omitting the information. So act of omission or act of commission will be there for preventing to give such mandatory reporting. Third is the impaired health practitioners. So in such cases, when there is break in providing the service, if that patient is not following or some facts are hidden, in that cases the confidentiality can be held, can be revealed. Now, next is the duty to the community. So sometimes there are some medical risks or some serious crimes which are happening. In that cases also we can reveal the privacy or confidentiality. So what is important is notifiable diseases and reporting is there. One must not be hiding such information. Now, refusal of treatment. Now, this is also a very important thing which a person or a doctor can land in trouble. If the patient is refusing the treatment, a doctor can't force him to go for the treatment. So, patient has all the right to refuse treatment. But for this, there is a catch situation for a doctor. So, for refusal of treatment, for this, the doctor should determine whether the patient is competent, whether what he has been informed properly regarding what will happen or what is the consequences regarding the refusal of treatment. Meticulous documentation of this refusal of treatment should be done. Should be done on paper and should be well informed to the patient wherever possible, so that the person might not deny in future that he has not refused treatment. So this is also very important. And even after doing all these things, still the person is refusing for treatment and is not ready to go under your management. So it is our responsibility as a doctor to ensure safe discharge of that patient. ऐसा नहीं कि अभी now the patient is not in under my treatment, आप चले जाओ. It should not be. It is now our responsibility as a doctor to ensure safe discharge of that patient so that he might not land in some dangerous situation. So that is very important thing. So refusal of treatment as a doctor, this is also a very important medical legal aspect which might happen in emergency situation.
Hello,
Discharge
sir.
against
Sorry
medical
to
advice.
interrupt.
Yes.
Actually, we are running short of time. So
Hello.
yeah, hello.
Huh?
Sir, sorry to interrupt you, but we are running short of time. So
Yes, I will complete. Yes.
Yeah, thank you, sir.
Discharge against medical advice. So risk for discharge against medical advice is a doctor has to look whether the patient is young or male, is indigenous or is any alcohol or drug user, or a person is of low socioeconomic status. This is also very important aspect we should know. Now, the most important is medical negligence. So this can also happen in emergencies. So in such situation, it requires duty of care situation. So whether that person or doctor has has been responsible to provide duty of care situation has happened. So there should be the medical duty of care. So if there is breach in duty of care, or if there is an harm or damage which has happened due to this, there is causation of this damages, then the person might land in cases of negligence in emergency situation. So in this, the court decides on the basis of expert opinion or guidelines or different tests. So what is the take-home message of this is the legal issues are complex. So we as a doctor should focus what a reasonable person would do. Always act in the best interest of the patient. Always take them in decision-making process. Know the features of a valid consent. Know how to assess the capacity. Documentation is very important in any situation, whether it is an emergency or elective. And our work environment should be made less difficult, because it is the difficult environment in which we as a doctor currently is working. Yes. Thank you.
Thank you, sir. Thanks a lot for the lecture. The theme of the today's conference is emergency medicine. So along with managing the emergencies, being medico-legally safe is equally important. Now I request today's chairperson to please thank today's speaker and felicitate him with memento. Sir, can you please stop sharing the screen?
Yes.
Yeah. So I request Dr. Rajiv Rane sir to thank Dr. Nilesh sir and felicitate him with memento.
Hello. Thanks, Dr. Nilesh, for sharing these key points as far as medical aspects in medical emergencies are concerned. They will definitely helpful for all our audience. Thank you again.
Now I request Dr. Zamdar sir to felicitate Dr. Rajiv Rane sir for chairing the session. Thank you, sir. Now, moving on to the next lecture, I request Dr. Zamdar sir to welcome the next chairperson and will proceed with the lecture.
I welcome Dr. Dobada sir, who is a senior surgeon from the Akluj. The next topic will be common surgical emergencies in Nigeria. And we have the speaker from the abroad. He is a Mr. Professor Bashiru Ismailia. Sir, please introduce him. Thank you.
Thank you, IMA. It gives me great pleasure to introduce Professor Bashiru Ismailia. He is a renowned surgeon from Nigeria, head of Department of Surgery, University of Jos and Jos University Teaching Hospital. He will enlighten us on emergencies in surgical practice in Nigeria. Thank you. Welcome, Dr. Usman.
There have been some questions in the chat box. Because of lack of time, we are not able to take the questions. I request all the delegates to please personally message the speaker. Thank you. Over to you. Hello.
Okay.
Hello.
Hello, can you hear me?
Yes, sir, you are audible.
Okay, thank you. May I share screen, please?
Yes, sir.
Okay, so I'll try to do that. Okay, so it's a great privilege for me to be here. I want to thank you all for this opportunity to take a presentation on surgical emergencies in Nigeria. My name is Bashiru. I work in the University of Jos University Teaching Hospital. I am a general surgeon and currently the head of department of surgery at the Jos University Teaching Hospital. Okay, so I want to use the opportunity to thank you all for this wonderful privilege of being able to present. I consider it a great honor. I also want to especially thank Professor Sachin. I think he made a lot of effort to get me to do this. So what will be the objectives of my lecture? I'll just state the common emergencies in Nigeria and briefly outline our approach to management. I'll do this in a very short time because I know that you are all conversant with a lot of the emergencies I may mention here. That I like definitions. Surgical emergency as an acute illness that requires surgeon's intervention to resolve an acute threat to life, organ, limb, or tissue caused by an external trauma, acute disease process, or an acute exacerbation of a chronic condition or complication of previous surgery or other intervention. However, if you are like me, I'll just say surgical emergency is a situation that requires immediate surgical attention. It is a major cause of mortality and morbidity, and it may account for half of all surgical admissions. Surgical emergencies are increasing world over, and for us in low and middle income countries, there's reduced access to surgical care, and it's a big problem. If we look at the global picture, basically you can, the injuries are divided into non-traumatic and traumatic, and acute appendicitis, acute intestinal obstruction, and acute urinary retention will be the most common non-traumatic emergencies worldwide. while for the traumatic ones, road traffic injuries, gunshot injuries, burns, and falls. Before I talk about Nigeria, I want to put our situation in context, since most of you, I know some of you have visited Nigeria, but most of you are not Nigerians. Generally, our population could be divided broadly into two, rural and urban population, and most of the data we have are from the urban areas. These data are also from tertiary centers like hospitals like mine and most of the federal hospitals. So this may mean that we may be missing simpler emergencies that go to smaller hospitals, which we don't have the data. It's also important to let you know that a majority of the cyclists in our country do not use helmets. So that also has bearing on the kind of injuries they get, let's say head injuries. And recently too, especially in the northern part of Nigeria where I stay, we have had a series of conflicts, and a lot of the conflicts have become armed conflicts, and so that has increased the kind of injuries, the sophistication of the kind of injuries we get. So there is more penetrating trauma. So I just took a quick look at some of the things I saw before when a few weeks ago when I was asked when I got information about this presentation. So enterocutaneous fistula, 2 bad cases that had been operated elsewhere. So they came as emergency, internal obstruction with gangrene and obstructed right inguinal hernia, 2 cases of appendicitis, a case of adhesive intestinal obstruction, appendix abscess, 2 perforated peptic ulcer disease cases, another case of perforated appendicitis, typhoid perforation, and a patient with necrotizing fasciitis of the thigh. Then I don't do trauma in my hospital, but I also looked at, on my call days, I looked at the trauma cases we had, and there were gunshot injuries mainly to the abdomen, chest, limbs, or a combination of them, and then fractures, injuries, spinal injuries. So I tried to get access to acute data. That was difficult because of the time constraint, but I just had a personal communication with the head of the emergency unit. What, in the past 1 month, what was the highest non-traumatic emergency for surgery? Intestinal obstruction, largely adhesive. Okay, how about for trauma? What was it? Gunshot injury, penetrating gunshot injury to different parts of the body. So some other data to see what we had. And generally, for this paper by Oyemechi, acute abdomen, acute appendicitis forming the major part of it was the major presentation for the non-surgical emergencies in Nigeria. For trauma, it was also soft tissue injuries, but largely from road traffic accidents. That was the major cause of injury of traumatic injury in Nigeria. Again, I looked at another part of the country, and I tried to outline the appendicitis in the paper by Onuaha. It's is the major thing. So when we look at this, it's not so much from what the global picture is from the data we have. But mind you, like I said before, I have doubts on how much the kind of data we have. What we do basically to these patients, for these patients, depend on how they present. But we try to take a simple, pragmatic approach that does not require a lot of resources. So our approach tends to be clinical. If a patient has generalized peritonitis, we want to resuscitate, we want to prepare the patient for surgery, and then we operate. Yeah, it has some advantages and also has some disadvantages. One of the key things to remember is that patients tend to present late. That's our usual. Late presentation is our usual. So the advantages of our approach is that it's cheaper, it's faster. We don't have access to too many sophisticated investigations. So we want to do what we can as quickly as possible for the patient who has presented late and see how we can get the best outcome. Of course, what that means is also that we'll have a few cases of negative, maybe laparotomies for acute abdomen, and then every now and then the patient may present with something like a pancreatitis, which we may have missed during the initial evaluation because we think it's an acute abdomen. So our management is clinically based, supported by investigations. We don't depend too much on investigations. So if I had a young patient with a right iliac fossa pain and tenderness, and she had features suggestive of appendicitis, then we will probably exclude the differential diagnosis through ultrasound and do a pregnancy test to ensure that she does not have an ectopic pregnancy. Then we'll do surgery. Do we do laparoscopic surgery? Yes, we do. Not as frequently as we want because the resources are more challenging, but we do that now. And for a female patient, if I was on call, I'll probably do that because it helped me to see more and get a better diagnosis, since the preoperative investigations are limited. For trauma, again, it depends on the type of injury. So as an example, if we had an penetrating abdominal injury, what will we do? It depends. Low energy, is the patient stable? Does the patient have peritonitis? If there's evisceration or there's blood from the GIT tract or it's an impairment injury, then that patient will have a laparotomy. If not, from a low energy injury like a stab, then we will probably do a wound exploration, a limited wound exploration. And once the fascia is breached, then the patient will have a laparotomy. For high energy injuries, especially gunshots, which we see more frequently now, for an abdominal injury that involves for a gunshot injury that involves the abdomen, the patient will have a laparotomy. I know in some places they could do some conservative management. We don't think we are well adapted and suited for that. This is an example of one of those kind of patients. The image by the left, it will be the entry wound here, or it was shot. And this was the exit wound. There was evisceration of the omentum. So at surgery, we noticed that the injury was a lot bigger than we thought. And this was the resected ball, which had about 8 perforations. So, of course, if we had tried to manage this conservatively, then we would have been in trouble. In these few minutes, I've just tried to highlight a few things. Surgical emergencies are a significant threat to life and limb in Nigeria. What we have in terms of common surgical emergencies seem to reflect the global picture. However, I believe that our data may have some inherent bias because of they come from higher centers, and we might be missing some of the simpler emergencies that we don't have data for. We have adopted a pragmatic, clinically based approach to managing these emergencies, these surgical emergencies, because it is faster and it's a lot cheaper for our population. Thank you very much.
Thanks a lot, sir. We are privileged to have an international speaker with us. And thanks a lot for coming online in spite of the time difference. Can you please stop? Yeah, can you please stop sharing the screen, sir?
Okay, I'll try to do that.
I request today's chairperson, Dr. Dobada, sir. He's a senior surgeon from Akluj, to thank you, sir, and felicitate him with an memento.
Thank you so much, Professor Ismailia, for your wonderful lecture.
Thank you.
Now I request Dr. Zamdar, sir, to felicitate today's chairperson, Dr. Dobada, sir, with a memento.
Thank you.
Thank you. With this, our first session is over, and with a short lunch break, we would proceed with the second session. Because we are lagging with the time, the lunch break has been cut off by 15 minutes. So see you all at 1:30 sharp to begin with ortho lecture, and after that we have ophthalm and 2 gynec lectures. Thank you.
Hello.
डॉक्टर राणे आवाज येत नाही. आवाज येत नाहीये.
गुड आफ्टरनून सर.
हा मॅडम
हाँ सर.
राणे मॅडम. डॉक्टर रेवती
यस सर.
आवाज घुमतोय तुमचा.
सर ते 1 मिनिट.
ओके ओके. गुड आफ्टरनून मेतन सर. स्लाइड दिसतात का? एक जस्ट चेक करू का 2 मिनिटात? करू शेअर स्क्रीन करू का?
हो सर, चेक करून घ्या.
कुठे आहे? कुठे आहे? इथं?
स्लाइड शो म्हणून ऑप्शन एकदा क्लिक करायचं. वरती जातो.
स्लाइड शो दाखवण्यासाठी काय करायचं मॅडम? राणे मॅडम. हा हा तू ये ना. निलेशला बोलवलं.
सर वरती स्लाइड शो म्हणून लिहिलं.
ते दिसत नाहीये.
वरती बघा ना.
तेच बघतोय मी.
होम इन्सर्ट डिझाईन ट्रान्झिशन्स ॲनिमेशन
न्यू शेअर.
त्याच्यावरती
न्यू शेअरला हे करू का?
हॅलो सर.
हा स्लाइड शो दिसलं मॅडम. होतं ना मग.
यस सर, स्लाइड्स आर विजिबल.
नाही आता परत गेलं.
खालती एक काम करा.
खाली घे. खाली घे. ते स्क्रीन खाली घे. नाही
सर मी सांगू का?
हा मेतन. नाही रेडी आहे, फक्त स्लाइड शो होत नाहीये. ओके. मला काय वाटतं की काही लोकांना सांगितलं 1:50 म्हणून म्हणतात. अशी गडबड आहे. चालेल बघू, 5 मिनिटं बघू आपण. हा बघू आपण. हा स्लाइड शो दिसत नाहीये मॅडम.
सर मी सांगतोय.
हा प्लीज सांगा सर.
खालती या पूर्ण खालच्या बॉटमला तुम्हाला तो बार दिसतोय स्लाइडर.
करेक्ट.
आता रीडिंग व्ह्यू आहे ना त्याच्या बाजूचं राईट साईडला. लेफ्टला चाललंय तुम्ही, राईटला बघा. हा ते बटन.
आता दिसतंय सर?
हो.
थँक यू व्हेरी मच सर.
Thank you, sir, for joining. Can we proceed with the session now?
Yes, ma'am, you can.
Yes. To conduct the next session, first is ortho lecture. For that, I would like to request Dr. Sanjay C to coordinate the session.
Good afternoon, all. This is now post-lunch session. For the next session, I would like to welcome our eminent dynamic personality of Akluj Orthopedic Society, Dr. Amol Shinde, practicing in Akluj for last 18 years. I would like him to come on the stage and introduce the next speaker, Dr. Metan, sir. Thank you.
Good afternoon all. Here I have pleasure to introduce our next speaker, Dr. Venkatesh Methan, who is a renowned orthopedic surgeon from Solapur and working presently at Methan Hospital, Solapur. He is an excellent educational career, and with distinction, he passed all the grades in schools as well as in his graduation, and he's performed his master's degree from Solapur. He has held many of the prestigious posts, like he was the president of Solapur Private Hospital Owner Association, then president of the Solapur Orthopedic Society. Here on this occasion, actually, he just would like to highlight all the emergencies which we tackle day to day in orthopedic practice. I welcome Dr. Venkatesh Methan.
Hello. Metan, sir. Hello. We'll just get back. Talk to sir and get back. Sir would be joining in just 2 minutes. Good afternoon, sir.
Good afternoon.
Yes, sir. Thank you for joining. We have already introduced you. You can start the lecture.
Oh,
Yes, sir.
am I audible?
You are audible, sir.
Yes, thank you. I will share my PPT.
Yes, yes.
Okay.
Yeah.
Yes. Yes. Good afternoon, everyone. After a nice lunch, I think everybody is refreshed. Today's my subject is emergencies in orthopedic. Before that, I thanks IMA Akluj for giving me this opportunity to express my few views about this very important topic, that is emergency in orthopedics.
Sir, we are not able to see your video. Can you please switch on the video?
Wait, just 1 minute. Yes.
Ma'am, from phone it is not possible. You cannot do both
Right.
things at the same time.
Okay. Actually, the screen is visible. Only the
But
video is not. You can proceed, sir. No issue.
yes, yes.
Okay.
So yes, my slides are visible to you. Anybody can just.
Yes, slides are visible. Slides are
Sure.
visible.
Thank you. Thank you very much. Yes. So today's my purpose of this speech is I want to have a general overview about the emergencies in orthopedics and what are the various emergencies in orthopedics. Your role as a primary doctor, as a first aid kind of things, your role when the patient comes to you first time, it is called as a primary management, and then awareness about the emergencies and importance of them. See, an orthopedic emergencies occur when you injure bone or soft tissue in a way that requires immediate treatment to avoid further trauma or harm to the body. And this is not only restricted to the bone, but it is connect with the entire body. Sort of the common orthopedic emergencies. These are the 5 most common orthopedic emergencies we are going to look for. First is open fracture, what we call as a compound fractures, dislocation of joints, then fracture of with a neurovascular injuries, compartment syndrome, and septic arthritis. Now, let us, to start only, I want to give you what are the your duties when patient comes first time to you. Whenever any emergency of orthopedic comes to you, you have to look for A, B, C, D, E. That is airway, breathing, circulation, disability, and exposure. Exposure means that wound. Then second is you have to diagnose it in very calm and with a calmly and investigate it properly. Then your first duty is to stabilize the patient general condition. Then look after the associated injuries which always are missed. This was, I mean to say, A, B, C, D, E. Then other duties are very important. That is usually these high velocity traumas, they are concerned with the MLCs, medico-legal case. So you have to consult the concerned police station. Then you have to do first aid and monitor the patient as what are the gadget you are at the primary center. Then if you have excellent setup at your own hospital, then treat by experts, that is orthopedic surgeon and concerned specialist. And if it is your primary center, then give a nice first aid, stabilize the patient, and refer to the higher center. And very important, you have to keep these all case paper record very meticulously. You never know when a court call comes to you, and at that time there should not be any problem with you. And be alert, as you know what I mean to say, be alert whenever a polytrauma case with a lot of mob comes to the hospital. So these are primary duties I want to highlight. And this is you have to stabilize. Your first duty is to stabilize the patient. That is a proper, bring all the norm parameters to the norm. Let us discuss in brief about these 5 important orthopedics emergencies. What means by open fracture? An open fracture occurs when the skin overlying a fracture is broken, allowing the communication between the fracture and the external environment. That is when this is a typical picture of an open fracture where the fracture bone is exposed to the environment and through the wound.
And next, these are the common X-rays when we took from the patient. Then there are two classifications. One is this open fracture classification, type 1, type 2, type 3. Type 1 is a small wound, usually less. The wound size is lesser than 1 centimeter, and usually it is a low velocity trauma, and the wound is usually clean. Type 2 is a moderate wound, where the wound is greater than 1 centimeter, but with a minimal soft tissue damage, with a loss of low energy. And type 3 is which are high velocity injuries with a severe wound. The wound size is more than 1 centimeter and with a lot of soft tissue damage. And everybody must know what is a classification wound as far as the open fractures are concerned. I told you the similar kind of, it goes parallel to what the classification for open fracture I already told you. The very important aspect about the emergencies, you have to do detailed examination. And that's a general examination, all parameters you have to look for. Then local examination is a very, very, very important. And we have to look for the wound, the complete examination of the wound, proper. If the bone is exposed, you have to take care of that. What are the various deformities? And does the patient has a distal neurovascular deficit? You have to palpate the distal concerned artery, as well as you have to ask the patient to move the concerned part of the limb. And very important, we always neglect some minor problems or minor diseases, minor injuries to the patients. So we highlight on the only major trauma. So the associated injuries should not be neglected. And these are the some do's in the management. Control the bleeding. We can call it the first aid kind of treatment. Control the bleeding, cover with the wound with the sterile dressing, give a proper plaster slab or splint available at your setup. Then give sufficient IV fluid to, as well as to correct the fluid, as well as analgesics and antibiotics. And as you know, tetanus prophylaxis you have to give and look for any signs of gas gangrene. And if it is there, you have to treat it. What are the things you are not supposed to do? One is do not replace the protruding bone to the normal, okay? And with the force kind of things. And do not explore the wound. We never know a major artery or vein can again burst open. And do not clamp the vessels if you are having a primary setup, okay? You can do it in the, you can do institute kind of things. What are and very important aspect is neurovascular injuries. I told you already, we have to look after the distal neurovascular deficit, which is very, very, very important. And again, sometimes there may be a skin might be too shiny and a lot of swelling, which gives a signal of acute compartment syndrome. What are the complications of these open fractures if not treated meticulously and immediately? There may be soft tissue infections, osteomyelitis, gas gangrene, tetanus, crush syndrome, skin loss, or if patient is treated delayed, the fracture may not unite. These are common complications. Again, I repeat, because this is very important, when a major trauma patient comes to you, so you have to first give a first aid management. As I already discussed, fluid resuscitation, control hemorrhage, splint dressing, antibiotic, analgesic, and tetanus, this one, prophylaxis and injection, TT. And this is the way actually we should stabilize the broken bones with a small plaster slab, which we use a lot of relief to the patient. And it is very important. And if you want to treat at your setup, it acts as a first aid treatment and you can post straight away to the surgery. And if you want to send the patient to the second higher center, patient is much relieved from the pain. Then if you go to higher center, I'll not go in detail because in higher center, what is the most important aspect is the 6 point, that is surgical debridement and fixation. And surgery immediate, the patient should be posted for the surgery, proper wound debridement under anesthesia, as well as fixation of the fracture. What kind of fixations? This patient can be treated by the wound debridement followed by external fixator. It's the usual line of treatment. The external fixator may be an outside tubular AO method or Elizarov method, whatever suits to the surgeon, they treat it. Now, second topic is juxtaarticular or intraarticular fractures. This is very common emergency, orthopedic emergency in the children's, and usually the fracture which occurs near or in the joint is a dial emergency as far as orthopedic is concerned. So, and you must be careful again to look after the neurovascular injuries nearby. These are the usually happens in the pediatric age when the patient falls on the outstretched hand or fall down from the higher height. These are the usual pictures. Very common problem is that is supracondylar fracture of the humerus, which is a deep displaced more than 1 centimeter. What it can cause is actually it made the displaced fracture the brachial artery as well as radial nerve as well as sometimes medial nerve get caught between the two fragments, and this becomes a dial emergency. So whenever any patient of supracondylar fracture humerus fracture around elbow comes to you, you have to palpate the radial artery and then ask the patient to move the fingers and watch for the wrist drop. This is very important as far as the examination of the patient is concerned. And what is your primary duty? Give the patient a proper splintage. We call it as a first aid. But while giving this slab, you must palpate the radial artery, or if you have a pulse oximeter, keep the pulse oximeter at the tip of the index finger and see there are nice pulses. If there is a pulse is dipping down, that means the fracture fragment is causing compression over the radial artery. And after a splintage, patient gets relief and you have to immediately post these patients for the subcutaneous K-wire fixation, or sometimes if may need an open reduction with a proper K-wire under the CR. And these are the very important emergencies, and they have to deal with at a higher speed. Second is in the juxtaarticular epiphyseal injuries, which happens in the children. This is a Salter-Harris classification where the epiphysis may be damaged or traumatized in 5 different ways. And as you know, if being a epiphysis is a growth plate, if something goes wrong in the management or if you treat it late or patient present late, then patient may get a bone arrest. What is the commonest epiphyseal injury, which is a slipped capitular femoral epiphysis. If you see carefully the X-ray, the epiphysis is slipped, okay, and the trochanter is shifted up. Even it happens with the lower end of the radius, where the epiphysis of the lower end is displaced. Sometimes it may fracture within the epiphysis. And these epiphysis, again, injury, they are emergencies and they will be treated immediately. Now, third component is of my topic is a dislocation. Okay, dislocation, as everybody knows, the dislocation is a condition that happens when the bone of a joint are knocked out of the place. A joint can be partially dislocated, it is called a subluxation, or completely dislocated. And this dislocation can cause by a trauma or fall or by accident or a weakness of muscle around the joint. And this the commonest cause is fall, and second is during the sports injury, and third is, as I already told you, weak muscles, which gives a repeated dislocation of the joint. What are the obvious symptoms of these patients? You can see the moment you examine it, you can see the deformed or shape of the joint. Then there is a swelling, there is intense, the condition is intensely painful. And if you ask the patient to move the limbs, it is a very painful. The commonest dislocation in the orthopedic emergencies are the fingers, shoulder. I want to highlight here shoulder, which is very common and major joint dislocation. And this is the typical picture where you can see the contour of shoulder is lost. You can't see the roundness of the shoulder here, that it itself indicates the shoulder is dislocated. And these are the two common different types of the dislocation. One is the anterior, where the head comes up, and the posterior, where head goes behind the scapula, glenoid cavity. And this is a typical X-ray of the shoulder dislocation. And this happens when the patient falls on the outstretched hand. One more is a dislocation elbow, which is again very common. You can see obvious displacement of the bones. And what is the management of the dislocation in general for all is you have to reduce it immediately. The moment patient comes, you have to reduce it. There are two types you can do reduction. Some few patients, they have a recurrent dislocation and they reduce themselves. Many times they come to hospital and suddenly after hour or half an hour to hour, patient comes to you, sir, ये तो हाथ बैठ गया है अच्छी तरह से. Why? Because it is a recurrent dislocation. The patient are habitual dislocation, so they keep dislocate themselves. But if the reduction is for the dislocation is for first time, you have to post it immediately, and then you reduce it under CR. See the stability of the reduction, and then immobilize. This is a typical. Then immobilize in the RJ strapping, so that it for the 3 weeks, minimum 3 weeks. Then you can give some rehabilitation and then physiotherapy, and patient recovers. The fourth is septic arthritis, which is again an emergency in orthopedic. And septic arthritis is an infection in the joint, proper synovial fluid, or a joint tissue or joint forming structures. This inflammation of the synovial membrane with a pleural diffusion into the joint capsule, usually it is a monoarticular, and population goes around 2 to 10 cases per lakh in general public affects. And these are the bacteria which commonly affect as a present as a septic arthritis. It comes as Staphylococcus, then Haemophilus, then E. coli, and sometimes virus also. And these bacteria can enter into the joint. They take an entry in the joint, proper joint, through either through the broken bone, or through the spread with the primary infection elsewhere in the body, through the infected wound, then foreign object that goes through the skin, or injury that breaks the skin. And the etiology of the septic arthritis is direct inoculation of this bacteria, then trauma, iatrogenic, hematogenous, then adjacent osteomyelitis, or soft tissue infection. And these are the signs and symptoms. There is a rapid onset of this problem, and the patient comes with a severe pain with a swollen joint, warmth, as well as erythema of the joint, with a high-grade fever, sometimes with the chills, then with a decreased range of motion. And the proper treatment is just monitor the patient, do the investigation, then give them proper rest, then IV fluid, and you have to aspirate the joint and send it for the culture sensitivity or synovial fluid examination. Then you have to do considerable lavage and drainage. If you are treating at the higher center, the patient should be posted immediately. If the pain doesn't subside for within 24 hours, the patient should be posted for arthrotomy. That is called as the take an incision of joint and do a proper lavage, take all the purulent pus through the joint and send the pus for the culture sensitivity. And if you not treat the septic arthritis properly within a stipulated time, there are a lot of complications we see. One is a rapid destruction of the joint, then degenerative joint disease, then soft tissue injuries, patient adjacent bone get infected, then joint fibrosis, septic, and sometimes it can complete in the mortality. Now coming to last points now, that is the last condition that is emergencies in orthopedic is acute compartment syndrome. I have kept it last because this is a very serious issue, and usually some neglection may lead to a disaster. So what is compartment syndrome? Is compartment syndrome, acute septic arthritis, is actually a pressure within the compartment get increased due to many reasons. Maybe because of the rapid blood collection, maybe because of the flow, rapid collection of blood, there is again compression within the compartment. An injury or condition that causes prolonged elevation of the interstitial tissue pressure. And this increased pressure within the enclosed facial compartment lead to impaired tissue perfusion. And this is, if you take a cross section of the tibia leg, you can see that there are various compartments within that leg portion, and it usually affects to the leg, feet, arms, and hands. And this is a typical compartment syndrome. Can you see here the tibia, and between tibia and fibula, there are various compartments, and the collection, fluid collection, blood collection within this compartment will cause such a disaster, such a deadly disease. What is a common etiology? What are the causes? First is a direct blow or contusion. A simple contusion may lead to this compartment syndrome. A crush injury, burns, snake bite, fractures, hematoma, and prolonged pressure. This causes the acute compartment syndrome. And this, why I'm saying this can go into disaster, because the limb is always threatening. If there is a increased pressure in the tight facial compartment, if the muscle necrosis starts once the pressure goes more than 30 mm of Hg, and if it the ischemic injury at 4 hour or irreversible injury, if you not treat within the 4 to 8 hours, and this rule of 5 P's, which plays as common findings: pain, paresthesia, paralysis. You have to observe for pulse and palpation of the proper area. And the symptoms already told you: intense pain, tenderness in the affected area, tightness in the muscle, tingling and burning sensation distal to the injury, and severe cases, numbness or weakness. This is a typical picture of a compartment on the right side. You can see the skin is shiny, and if you see down at the ankle, there is some petechial hemorrhage knee as well as the. So this is gives an alarming sign. And then you have to look for the very important aspect. Clinical examination is first distal neurovascular examination and see the proper pressure within the compartment. And the management is a diagnosis is by aspiration of Gram-stain culture you have to send. Then patient needs admission and proper investigations. Start immediately antibiotic analgesics, and you have to go for many times you have to go for emergency surgeries. And what is the surgeon choice here is surgeon will perform an operation. It is called as a fasciotomy. Can you see the image here? So what is a fasciotomy? It is a just to give open the compartment and relieve the pressure within the compartment, and all things comes in the this one. And this is typical post fasciotomy image. And don't hesitate to take a big incision, because here the limb is at threatening. So to save the limb or distal part of the affected area, you have to take a bold decisions. To come to my subjects review, entire review, first, your duty is to stabilize the patient, go for A, B, C, D, E, and then control the bleeding, give proper IV fluid and analgesic and antibiotics. Meticulous diagnosis with a calm mind is very necessary. Then investigation, do all possible investigation to come to a conclusion. And if you have an excellent setup, you have excellent setup at your hospital, immediately take expert's opinion and proceed to the immediate surgery needed, or give a proper first aid and shift to the higher center. And do not forget to keep your case paper record intact. It is very, very important. And let me know if I can help you in the future about this topic. And thank you very much, IMA Akluj, for giving me an opportunity to express my views with the intelligent audience. Thank you.
Thank you, sir. Thanks a lot for explaining all the emergencies in orthopedics in very simplified manner. I'm sure even non-orthopedic delegates must have understood it very well. Now I request Dr. Amol Shinde, sir, to felicitate you with e-memento. Sir, can you please stop sharing the screen, please? Yeah.
Yes, yes. Stopped.
Yeah.
Thank you very much, Dr. Mehtan, sir. Actually, you have very well covered all the topics, emergencies in orthopedics, because it is almost a nightmare for every non-orthopedic treating physician. You have covered the types of emergencies which they deal with, then the duties, particularly the ABC, then stabilization of the patient, maintaining the medical legal record, then first aid, and of course the IV line. And these are very certain important factors which are very much responsible in the golden hours of the treatment. But as the patient reaches the orthopedic surgeon, till then the patient do well. And certainly you have said good things about something do's and don'ts. We should not do it and we should do the things. And the entire perspective was very fantastic, sir. And I think it is said that if, your eyes cannot see those things what your brain does not know. But now with this information, actually every delegate has been enlightened with the knowledge, and their eyes will see now the things what has to be seen. I thank you very much on behalf of IMA Akluj as well as from all the delegates. Thank you, sir.
Thank you, sir. Thanks a lot for sharing the session.
Thank you very much.
And I request Dr. Sanjay Sheth, sir, to felicitate our chairperson, Dr. Amol. Thank you, sir, for chairing the session. Now we proceed with the next lecture. The lecture is Emergencies in Ophthalmology, and to conduct the lecture, I request upon Dr. Pradnya Gandhi to coordinate the session.
Good afternoon, everyone. Now we will have a talk on emergencies in ophthalmology. As a chairperson for today's session, we have Dr. Mahavir Gandhi, sir, a very well-renowned ophthalmologist and a first ophthalmic surgeon in Maharashtra Taluka. Sir has done his MBBS and post-graduation in ophthalmology at JJ Medical College, Bombay. So I request Mahavir Gandhi, sir, to chair the session.
Welcome, sir. I request you to please introduce today's speaker.
Hello, friends, everybody. Good afternoon. It's a great pleasure to announce or introduce Dr. Navneet Toshnial, who is a son of my friend, Dr. Shyam Agarwal. He is a renowned ophthalmologist from Solapur. He is practicing in Solapur since 1994. He did his UG, PG in Solapur VM Medical College, Solapur. And he also did general ophthalmology practice in Shankar Netralaya, Chennai. His interest is now at present is a senior consultant, ophthalmic consultant in Navneet Hospital, and his field of interest is basically a phaco emulsification and what you call as keratoplasty surgery. He he has attended a lot many international conferences, ESCRS, normally called as European Conference of Ophthalmic and Cornea Specialist. He has got many prizes in international conferences, and he is the first Indian to achieve live surgical demonstration in Amman, that is in Jordan, with the hospital name called as Arbid and King Hussein Bey Military Hospital, Amman. Actually, he has done a lot of phaco training centers he has developed in Solapur, and he has done almost 221 students from abroad also and India also. He has totally trained in a phaco surgery. Now he has done many instruction courses in medical and paramedical courses for paramedical staffs. Normally, he has got 10 instruction courses on the basic of phaco has been conducted by his staff. And the special achievement has received a gold medal from Indian Intraocular and Refractive Society India in 2009 as a best teacher in phaco surgery. An article on a phaco training titled as a teaching is the best learning process has been published in Ophthalmology Times, which is widely distributed worldwide. And basically, he has invented many ophthalmic instruments which are useful in a daily practices. Like he has invented an instrument named a Tosniwal pre-chopper, which is manufactured by ASICO, which is one of the leading instrument manufacturing company from USA. This instrument has been launched in American Academy of Ophthalmology in 2012. Again, already he had invented an instrument named a Tosniwal chopper that is manufactured by Epsilon India in October 2012. And he has invented also named a Tosniwal microcapsular axial forceps, which is recently launched in Jaipur 2017. Now, basically, he has written many books on ophthalmic phaco surgery. And here is Dr. Navneet Toshniwal.
Thank you, sir, for the introduction, and over to you, sir, for lecture. You can share your screen.
Is it visible? Slides
Yes,
are
sir.
visible?
Slides are visible, yeah.
Respected Mahavir sir, thank you for the nice introduction. Thank you for inviting me for this AMSCON 2021, hosted by the IMA Akluj, a great coordinator, Rane Madam, Pradnya Madam, respected Kishore Girme sir also. I will start with the topic in the sense that emergencies in ophthalmology, what everybody can see in a day-to-day practice. I'm not talking per se what is the treatment of these emergencies, but these emergencies, all the practitioners of the other faculties are seeing in day-to-day practice. To start with, first slide. This is the lens-induced glaucoma. A cataract becomes hypermature, started unilateral headache, pain, redness. Patient go to the general practitioner with the vomiting and diarrhea, treated for that. But one has to look for this condition so that after controlling unless and until you will give Diamox, patient will not get relief. So this is a very common condition in old age, especially from rural areas, that has to be still diagnosed. Everybody can see that, look into the eye and just see the condition, your treatment will go to the nice way. Next. Acute glaucoma is a purely ophthalmic condition. Again, but patient come with the headache, one-sided, pain, severe pain in the eye, vomiting. So these can be immediately referred to the ophthalmologist and we can treat it. Next. I will focus this slide, which is very important. Retinopathy means we see the fundus in diabetes, in any condition. I will give some significance of the fundus examination. Fundus examination, why it is important for all the pathies, all the faculties, all the contemporary. It is the examination where one can see the blood vessel of the body. Direct look into the blood vessel. It may be hypertension, it may be diabetes, it may be many other conditions. So there is always the significance of this fundus examination, which is very important. For example, I am showing one slide here is a diabetic retinopathy. What it means? There are some changes in the eyes and sudden loss of vision occur due to the vitreous hemorrhage, due to macular edema. Now, when you see these slides, you can see the many changes in the blood vessels. Now, what is the significance? Now, see, as per se, this condition is treated by the ophthalmologist, vitreoretinal person. They will do the laser, they will do the anti-VEGF injections to give the good vision to the patient. But what is the significance of this condition? Suppose my relative is having diabetic retinopathy. Of what state? What it means? Same structure of the blood vessel, same thing is related to brain. Same in the kidney, same in near the heart. So all the blood vessels of the body are going to be like this. So it's very important to have a same way our approach should be that what's the cardiac status and what treatment is needed. If such a type of picture, when there is a vitreous hemorrhage, the same thing, intracerebral hemorrhage can occur because blood vessels are already weak. So I think that at this platform, I wish to give you the idea about, as although already it is ophthalmic emergency, but ophthalmologists can guide, can put the file in such a way that patient should get perfect treatment from all other branches. Especially macular edema is the sign. It is not the picture here, but suppose a macular edema and other thing is normal. It's the renal cause has started. So we can guide the nephrologist. So this is the way diabetic retinopathy, any pathy, fundus examination is such a significant. Next. Central retinal artery occlusion. Now in this COVID area, we have seen so many patients of this that because of the thromboembolism, this thing is happened. It is within a few hours, patient will lose the vision. If patient will reach earliest to the ophthalmologist, then we can do some hypotony, oxygen therapy and all that to relieve it. Central retinal venous occlusion, central branch vein occlusion. These slides are important. When macular edema occurs, patient will rush to the ophthalmologist. And then again the same way, these are the thromboembolism which is happening. And we have to rule out the other status. Cardiac status is a very, very important. And this is important, that correlation of our ocular emergencies, which we can guide it. And all the other faculty people also should know that this condition, as when we mention in that, especially the physician is having the very big role, or general practitioners, they are having the very big role that this patient has developed thromboembolism. So they can guide the patient, they can in a better way. It's not just ophthalmologist, then the physician, then the diet, then the hypertension, diabetes. Accordingly, this patient has been treated and counseled by all other people. Optic neuritis, retrobulbar neuritis, neuroretinitis, sudden loss of vision. Then generally in retrobulbar neuritis, you don't see any big changes in the retina. It is behind the optic nerve. So it is mainly the multiple myeloma and all that. So we have to refer to the neurologist. Mucormycosis is a typical condition we have noticed, seen, started around the eyes, in the sinuses, then picture like this. This slide I have taken because this is definitely important emergency today's era in the COVID. So this has been treated by the ENT surgeon and ophthalmologist. You have to treat all the fungus, medical wise, surgical debridement at early stage to save the eye. Otherwise, patient land up in trouble. If it spreads to the brain, then directly it is a very big calamity. So important thing, early diagnosis and early treatment is very, very important in mucormycosis. So I think I have tried to put, I cannot take all the emergencies, but I have tried to take the emergencies which are important for ophthalmic, but very important for all the practitioners. Last. Corneal opacity. After the injury to the cornea, patient develop corneal opacity. And this corneal opacity at the end stage, we are treating with the keratoplasty. Mahavir sir has mentioned the two interest point for me, that phacoemulsification and keratoplasty. Already he has mentioned that I am a son of Dr. Sham Toshniwal, who has started this Mishribai Toshniwal Eye Bank in 88 in this part of the area. Many doctors are working under this, and this is the corneal transplantation. This is the purely done by ophthalmologist, a corneal surgeon. This corneal opacity we can treat as a keratoplasty. Why I am showing this slide at this platform, that this is possible due to eye donation. Organ donation, we listen all the time. Eye donation is after death. We remove the corneas in a 4 to 6 hours. We put them in a cortisol-like solution, so we can preserve this tissue for 7 to 8 days. We collect the proper eyes. Here I can take the name of Dr. Jamadar from Akluj, a very important person, and he is doing a wonderful job in Akluj for this eye donation work. He is calling me behind me for all these things. So this keratoplasty work, corneal opacity and keratoplasty, at this platform, our platform is always a medical platform, but it is always having a fantastic touch of a social point. So at this point, I just appeal all the doctors to promote this eye donation, which is very important to cure the corneal blindness. I stop here, and I once again thank you to the IMA Akluj, all the office bearers of the IMA Akluj, Dr. Mahavir sir, Pradnya, for giving this me wonderful opportunity, Rane madam, for giving me this wonderful opportunity to share my some views, and thank you. Last point I will appeal here, that I have written 3 books. I appeal here all the practitioners that start thinking on this aspect of writing a book. It is not easy, but it is still easy. And one can write your experiences, try to be in a teaching, automatically you will go in that. Thank you for allowing me this.
Thank you, sir. Thanks a lot. Ophthalmology is often considered as a daycare branch with less emergencies, but thank you for enlightening us with so many emergencies. And with the COVID era, with the mucormycosis, the ophthalm emergencies are on the verge of rising. And also thank you for the support of the eye donation, and also thank you for inspiring us for writing so many books. Now I request our today's chairperson to please thank sir and felicitate him with e-memento.
Hello. Many thanks for Navneet. It's a nice illustrative discussion. Many diseases which are not known for general ophthalmologists or general practitioners. One of them is acute sudden loss of vision. One of my patient, my son, has come to a 17-year-old girl had come to my son, and she has lost a sudden bilateral vision. But when she went to physician also, but he couldn't diagnose it. And when she came to my son, he diagnosed it, a BRAO, and he referred to a physician saying that you do this. Then the physician asked, whether is it necessary? Are you sure about the diagnosis? He said, yes, 100% sure, you can go. And luckily, last 15 days back, she regained a vision, 6/9, within 15. Once again, thanks a lot. Ours is a branch which is not related to general. They can say it's a paramedical branch. They don't, half the people doesn't know what is ophthalmo. In actually, my time, they say this is a neglected branch. Now it has gone up more importance rather than other branches. But luckily, people are aware of it, and the physicians also are aware of it. There is something like ophthalmology, and they are also liking us, our branch. Thanks a lot once again. Many thanks for this.
Thank you, sir.
Thank you, sir. Thank you for chairing the session. And I guess ophthalm is nowadays on the top list of all the toppers. They'll choose the ophthalm instead of medicine and gynec. So I request Dr. Pradnya Gandhi to felicitate our today's chairperson. Thank you. Now now the next session is obstetric. Obstetric is always an emergency, I feel. Either it is fetal distress, maternal distress, or doctor's distress. But there are so many emergencies. So to coordinate the session, I would like to request Dr. Priyakadam Madam to come on stage.
I'm audible. Good afternoon, everyone. Now, as it's a post-lunch session, it's a challenge for our speakers to keep the online, that is 400 plus Zoom candidates and 50 plus YouTube candidates and the offline delegates awake. Now, I will call Dr. Satish Doshi sir to chair this session. He is a past president AOGS and a senior most gynecologist of Akluj. Welcome, sir. I would request Dr. Satish Doshi sir to introduce Dr. Rahul Wani sir.
Dear friends, first I must congratulate IMA committee to have such a grateful conference in Akluj. They have arranged nicely so that everybody can enjoy this conference. Now, I will introduce Dr. Rahul Wani. He is one of the most eminent person. He is an honorable consultant in Maharashtra Hospital Trust. He is an assistant gynecologist, Archana Maternity. He is the president, Navi Mumbai Obstetric Gynecology Society. He is the associate medico-legal consultant, B&C Medico-Legal Consultancies. He is a member of Ethic and Medico-Legal Committee of the FOXI, and he is the lead assessor of the Manyata Project Foxy. Sir, I will give to the mic to you. You can start your lecture. Thank you.
Over to you, sir. You can share your slides.
Yeah, thank you, sir, for those kind words and the kind introduction. My topic today is maternal collapse. So before I begin my talk, I thank Akluj IMA branch for giving me this opportunity to talk on this very important subject of maternal collapse. Now, but what is maternal collapse? How do you define maternal collapse? The maternal collapse is an acute event involving the cardiorespiratory system and or brain, causing reduced or absent conscious level at any point during pregnancy and up to 6 weeks postpartum. So anytime from the pregnancy, as the pregnancy starts till 6 weeks of postpartum, if the mother develops any cardiorespiratory problem and there is a loss of consciousness level, then it is a maternal collapse. Now, physiological changes in pregnancy mask early warning signs and collapse may occur unpredictably. Now, in a non-pregnant patient, we might get some changes in the vital systems or vital parameters, and we could predict that this patient would go into complications. But in pregnancy, because of the physiological changes in pregnancy, this is quite often masked. There have been various scoring systems which have been predicted or which have been developed to predict if this patient is going to go into collapse or not. But none of them have been able to fulfill the criteria, or none of them have been able to predict very accurately. Now, cardiopulmonary arrest is the final pathway in many life-threatening diseases. Now, sudden cardiac death causes 6 lakh deaths annually in the United States. And cardiac arrest occurs in almost 1 in 30,000 pregnancies. Where death has occurred, poor resuscitation has been the major cause of losing the mother. Now, it is said that 50% of the patients suffering cardiac arrest can be revived or they can recover. And most of the times, if the death has occurred, poor resuscitation skills have been a major cause of losing the patient or losing the mother. So all clinicians should be skilled in techniques of cardiopulmonary resuscitation, basic life support, and advanced cardiac life support. Now, what are the causes in pregnancy which can cause maternal collapse? Now, amniotic fluid embolism is one of the major causes. Magnesium sulfate toxicity, which magnesium sulfate, which is used to treat severe preeclampsia or eclampsia. Preeclampsia, eclampsia, complications of preeclampsia, eclampsia itself can cause maternal collapse. Now, as we know, postpartum hemorrhage and antepartum. Postpartum hemorrhage is one of the leading causes which can cause maternal collapse during the pregnancy, during labor, or immediately after delivery, and antepartum hemorrhage during the pregnancy time. Now, causes which can occur in pregnancy, but they are not limited to pregnancy, which can occur in a non-pregnant patient also, like an acute coronary syndrome. Now, this is on the rise because we have a lot of patients with IVF treatment who get pregnant, they are elderly, and acute coronary syndromes can be seen in pregnancy itself in these elderly women. Cerebrovascular accidents, aortic dissection. A pregnant patient is more prone for aortic dissection, sudden aortic dissection, which can occur spontaneously. Pulmonary embolisms and trauma. All these causes can lead to maternal collapse during pregnancy. Now, we call when there is a cardiac arrest, we call for code blue. But there are certain changes which we need to do in this code blue. That is why we call this as pregnant code blue. And the common causes where a maternal collapse occurs in pregnancy, PIH of all the cardiac arrests which have been noted in pregnancy, PIH lands with the maximum causes of maternal collapse. 24% of PIH patients, when they develop complications like eclampsia, cerebral edema, when the hepatic or renal function is altered, or there is dysfunction in hepatic and renal function, abruption, DIC, HELP syndrome, and cerebrovascular accident in PIH can cause maternal collapse. The second leading cause causing cardiac arrest in pregnancies is embolism. 23% of the times it has been the cause has been found as embolism, and this occurs because of the embolus. There is hypoxemia, there is respiratory arrest leading to DIC, and there is maternal collapse. As we said, postpartum hemorrhage, which is commonly around 2% of normal deliveries encounter postpartum hemorrhage. 4 to 6% of patients landing with cesarean sections can develop postpartum hemorrhage, antepartum hemorrhage. All these causes hypovolemia, hypotension, finally leading to DIC and maternal collapse. Infection is one of the leading causes. Septicemia, septic shock causes respiratory arrest, acute respiratory distress syndrome leading to maternal collapse. Cardiomyopathies occurring in pregnancy can cause arrhythmias, impact cardiac output, leading to maternal collapse. Anesthesia complications in pregnancy because of failed intubation, because the intubation in pregnant patients could be a little difficult because of the laryngeal edema, the hypertrophic breast. So there can be a little difficulty in intubation. So failed intubation is one of the causes. Then aspiration in pregnancy is also common because of the pregnancy hormones. There is a relaxation of the esophageal sphincter, which can cause aspirations, leading to hypoxemia, arrhythmias, and maternal collapse. Prolonged tocolytic therapies. If we are giving tocolytics for a prolonged period of time, then that can cause arrhythmias, pulmonary edema, and hypoxia. So these are some of the common causes which can cause maternal collapse. Now the amniotic fluid embolism, which is the most dreaded complication we all fear. The incidence of amniotic fluid embolism is around 1 in 15,200 to 1 in 53,800. And this should be suspected when this occurs during the labor or immediately after birth and within 30 minutes of birth. So if a maternal collapse occurs during labor, just at the time of birth or within 30 minutes of delivery, then the strong suspicion of amniotic fluid embolism should be there. Initially, the maternal mortality rates were estimated to be 85%. Now, with advent of intensive care units, mortality rates of with amniotic fluid embolism have also reduced, and they have come down to as low as 13 to 30%. So all is not lost when you diagnose amniotic fluid embolism, and this is mainly a clinical diagnosis. And the definitive diagnosis is only in postmortem. The amniotic fluid embolism, what are the risk factors for amniotic fluid embolism? Advanced maternal age, placental abnormalities, operative deliveries, eclampsia, polyhydramnios, cervical lacerations, and uterine rupture. All these can lead to amniotic fluid embolism. Now, historically, it was thought that there is an hypersensitivity reaction to the amniotic or fetal antigen in maternal circulation. But the trigger is not certain. Amniotic fluid or some fetal substance enters the maternal circulation, and that now it is thought that it triggers a massive anaphylactic reaction and the activation of complement cascade. So there is initial pulmonary. So amniotic fluid embolism occurs in two phases. Initial phase, there is pulmonary artery vasospasm, which leads to pulmonary hypertension and elevated right ventricular pressure, causing right ventricular failure and hypoxia. Later on, this leads to myocardial and pulmonary injury and causes left heart failure and acute respiratory distress syndrome, leading to massive hemorrhage, uterine atonia, and DIC. So the initial phase, there is right ventricular failure. In the next phase, there is left ventricular failure and DIC. So clinical picture, the three signs of diagnosing amniotic fluid embolism is the timing, respiratory distress, hypovolemia, hypotension, and then finally DIC. So the patient can present with respiratory distress, restlessness, cyanosis, nausea, vomiting, sometimes seizures can occur. There is sudden cardiovascular collapse, and then DIC. So diagnosis, as said, is mainly clinical. Definitive diagnosis is only on postpartum. And if time permits, and you can get this investigations like arterial blood gases and coagulation profile. That would be helpful in the management of amniotic fluid resuscitation. Now, there is a difference in resuscitation of a non-pregnant patient or a patient other than pregnancy. Now, there are certain physiological changes which occur in pregnancy which affects resuscitation, or resuscitation needs to be changed a little. There is aortocaval compression in pregnancy. So aortocaval compression significantly reduces cardiac output from 20 weeks of pregnancy onwards to 20 weeks of gestation onwards. So reducing venous return, and as a consequence, cardiac output by up to 30 to 40%, causing supine hypotension. Aortocaval compression significantly reduces the efficacy of chest compressions during resuscitation. Now, in a non-pregnant woman, when effective chest compressions are given, we achieve around 30% of the normal cardiac output. But in pregnant patients, this is further reduced to 10%. So cardiopulmonary resuscitation may not be as effective in a case of pregnancy beyond 20 weeks of pregnancy. Now, pressure from the uterus will splint the diaphragm, depending upon the extent of the gestation, with subsequent increased pressure required for successful ventilation. So ventilation is also difficult in pregnancies because of the pressure of the diaphragm. There is pressure on the lungs, and ventilation can also be difficult. Now, changes in lung function, diaphragmatic splinting, and increased oxygen consumption make the pregnant woman become hypoxic more readily and make ventilation more difficult. A combination of changes in respiratory and metabolic functioning make acidosis more likely to develop, thereby meaning resuscitation needs to be more efficient than usual. Now, what are the changes in the circulation? The increased cardiac output and hyperdynamic circulation of pregnancy mean that large volumes of blood can be lost rapidly, especially from the uterus, which receives 10% of the cardiac output at term. So concealed bleeding and underestimation of blood loss means that intervention is often delayed. Now, because of these physiologic changes, the blood loss in pregnancy is often misleading, or it is often underdiagnosed. Now, these are some important points. The fetal hemoglobin circulating in the fetus and placenta has a higher affinity for oxygen than adult hemoglobin, which is an adaptation designed to ensure optimal fetal oxygenation. Now, because of this mechanism, in the setting of maternal resuscitation, this allows the fetus to steal oxygen from the mother, meaning oxygen delivery to the maternal brain and cardiac muscles is less efficient than in a non-pregnant patient. Now, intubation and aspiration. Now, because of the increased weight gain, a large breast inhibiting the working space, and laryngeal edema, intubation can be difficult. Pregnant women are at an increased risk of aspiration because of the progesterone hormone. There is relaxation of the esophageal sphincter, and there is delayed gastric emptying. There is increased intra-abdominal pressure. So all this leads to increased chances of aspiration in pregnancy. So prophylactic use of antacids is very important in pregnant patients. So what are the changes in resuscitation we should anticipate in pregnant women, or how the resuscitation should follow? Now, management of a collapsed pregnant woman should follow the standard ABCDE approach, that is airway, breathing, circulation, defibrillation, and proper exposure of the patient for complete examination of the patient. So this approach has to be followed in any case of maternal collapse. Initially, there has to be a primary survey. As soon as the patient has collapsed, the first thing we need to do is a primary survey to find out what is life-threatening. Diagnose immediate life-threatening situations, identify the problem, and deal with this problem as they are identified. So first, airway, stabilize the airway. The head has to be tilted. Then you have to lift the chin and upper thrust to the jaw. So as the anesthetists do, you have to, for maintaining the airway, you have to do this. If there are any secretions, you have to suck the secretions immediately. Breathing and ventilation has to be maintained. Circulation should be maintained with volume replacement and hemorrhage control. Disability, defibrillation. So a disability or neurological status has to be examined, and exposure and environmental control. Assess fetal well-being and viability and may require delivery. Now, secondary survey, you have to examine the patient from top to bottom and front to back and identify the cause of maternal collapse. Now, if there has been preeclampsia or eclampsia, if there is hemorrhage, you can identify this. But if the sudden maternal collapse has occurred, then identifying the cause might be difficult. Now, secondary survey is performed once the patient is stable. The secondary survey may not take place until after surgery if surgery is necessary as a part of the resuscitation phase. And continuous re-evaluation is very important to identify new life-threatening problems as they arise. Now, what are the essential adaptations in pregnancy while giving resuscitation? Now, since if the patient is pregnant more than 20 weeks, there is, and we know there is aortocaval compression. To release this aortocaval compression, a left lateral tilt of 15% has to be given on a firm surface, which will relieve the aortocaval compression. So, and a left lateral tilt of 15% can be achieved on an operation table. If the patient is on an operation table, you can give it by a 15% tilt. Or there is a hard surface. There is something called as a cardiac bench, which is available, which is a hard platform, which can be placed from the right side of the patient, behind her thorax and the shoulders and up to the hip. So against this hard portion, the cardiac compressions can be given easily. If you place like pillows or a bed sheet or something like this, since it is a soft thing, the cardiac compressions cannot be given effectively. So you need something which is hard. Or if there are enough people, then the assistant's knees can be placed below the thorax to give effective compressions, to give the tilt and to give compressions. But if nothing is available, then objects like the bed or pillows or blankets can be used. Something is better than nothing. So if nothing is available to relieve the aortocaval compression, you can utilize these things also. Now, as I said, airway could be or intubation could be difficult in a pregnant patient, and aspiration is more common. So at the earliest, you should secure the airway. The airway should be protected as soon as possible by intubation with a cupped endotracheal tube. A pregnant patient is more prone to hypoxia and more prone to acidosis. So supplemental oxygen should be administered as soon as possible because of the increased oxygen requirements and rapid onset of hypoxia in pregnancy. And it is important to ensure optimal oxygen delivery by adding high flow 100% oxygen. Bag and mask ventilation should be undertaken until intubation can be achieved. And as I already mentioned, ventilation may be more difficult because of the physiological changes in the pregnancy. Now, in the absence of breathing, despite a clear airway, chest compression should be commenced immediately and continued until cardiac rhythm can be checked and cardiac output monitored. Now, so when giving cardiac compressions, the cardiac compressions should be given a little higher than in a non-pregnant patient. So because of the pressure of the diaphragm from the uterus, the lungs and the heart are pushed a little up. So the compressions have to be given a little higher than the normal patients, and the compressions have to be perpendicular to the position of the patient. Now, if a tilt of 15 degree has been given, your compression has to be 15 exactly perpendicular, taking in account the tilt which has been given to the patient. Now, compression should be performed at a ratio of 30:2. That means 30 compressions and 2 rescue ventilations with the bag and mask. Now, if an intubation has been achieved, then the ventilation and cardiac compression can be asynchronized. So you have to give compressions at the beats of 100 per minute and ventilations at a rate of 10 per minute. And for maintaining the circulation, 2 wide bore cannula should be inserted as immediately as possible, and aggressive volume replacement has to be started. Now, defibrillation. When can defibrillation be given? Now, you have to find out what is the cardiac rhythm. Only ventricular tachycardias or ventricular arrhythmias are shockable rhythms. If there is asystole, your defibrillation will not work. There you have to start with giving adrenaline and epinephrine or vasopressin. Now, some settings, as in non-pregnant patients, the defibrillator has to be put on same settings as in a non-pregnant patient. And the important point is you have to disconnect all probes from the patient. All the fetal probes which are attached, whether it is intravaginal or abdominal, those have to be attached or they may cause burns if a defibrillation is given along with the probes on the maternal surface. Now, if there is no response to correctly performed cardiopulmonary resuscitation within 4 minutes of maternal collapse, or resuscitation has to be continued beyond 4 minutes in women beyond 20 weeks of gestation, now delivery should be undertaken to assist maternal resuscitation. So, because the mother is prone to hypoxia very early, so if the patient is pregnant more than 20 weeks, then you have to contemplate delivery of the patient. So what is perimortem cesarean section? Timing, it has to be done within 5 minutes of the collapse. The rationale for this time scale is pregnant woman becomes hypoxic more quickly and irreversible brain damage can occur within 4 to 6 minutes. Now, delivery of the fetus and placenta reduces oxygen consumption, improves venous return and cardiac output, and it facilitates chest compression and makes ventilation easier. Because you have opened the abdomen, you can give intra-abdominal compressions also. So along with the chest compressions, intra-abdominal help can also be taken. Now, before 20 weeks of gestation, there is no proven benefit from delivery of the fetus and placenta. Now, perimortem cesarean section should be considered a resuscitative procedure to be performed primarily in the interest of the maternal and not fetus. Mother is more important than the fetus and should be done even if the fetus is already dead. If resuscitation, perimortem cesarean section should not be delayed by moving the wherever the mother is, you should open it with transverse incision, deliver the fetus, deliver the placenta, pack the abdomen, and continue your resuscitative measures. No consent is required and it has to be carried out the rest of the mother. So a vertical incision would fastest, but if the operator is not areas where collapse may occur in the hospital. All that is required is a fixed blade and 2 clamps for the cord. Staff must be involved early. It is essential that woman is transferred to a high dependency unit critical care area with appropriate staff and monitoring facilities. Now, in hemorrhage, in the case of maternal collapse secondary to antepartum hemorrhage, the fetus and placenta should be delivered promptly to allow control of the hemorrhage. Now, in the case of massive placental abruption, cesarean section may be occasionally indicated even if the fetus is dead, to allow rapid control of the hemorrhage. As in amniotic fluid embolism, the management is mainly supportive rather than any specific. There should be early involvement of senior experienced staff, including obstetrician, anesthetist, hematologist, and intensivist. And coagulopathy develops very rapidly in amniotic fluid embolism. So aggressive treatment with replacement of volume and fresh frozen plasma is the key in management of amniotic fluid embolism. Now, drug overdose toxicity. In obstetric practice, the 2 main drugs.
Hello. So
Yes.
sorry to interrupt you. We are running little short of time.
Yeah.
Yeah.
So drug toxicity, magnesium sulfate. I'll end it in 2 minutes. The antidote to which is magnesium calcium carbonate, 10 ml in 10% given slowly. local anesthetic agents. Now, if you have given local anesthesia and suddenly the patient collapse, then the treatment is intralipid, 20% intralipid infusion, which can revive. Now, eclampsia, intracranial hemorrhage, you will require a neuroradiology and a neurologist to help you and to transfer the patient to an appropriate center where these cases can be facilitated, can be managed. Anaphylaxis, this is a very important thing. Now, anaphylaxis, if it occurs because of any drug, the patient can collapse suddenly. So anyone who is there besides the patient can directly inject 0.5 ml of 1 in 1000 adrenaline intramuscularly, or it can be given IV bolus. 1 ml of adrenaline can be diluted to 10 cc and slowly over a 1 cc can be given every 3 to 5 minutes till the cardiac rhythm comes back. And adjuvant therapy being hydrocot 200 milligrams and chlorpheniramine 10 milligrams can be given slowly. So what is important is documentation, because all these cases can lead to medico-legal problems, and documentation is very important. Training of your staff. So here I will give you the importance of Lakshya Manyata training, where it is FOXI accredited and Government of Maharashtra accredited, where we train the staff in resuscitative measures like management of postpartum hemorrhage, management of eclampsia, and basic cardiopulmonary resuscitation. Change in attitude is important. It is important that we should not blame each other in cases of maternal collapse. Try to find out what was the reason and to develop our resuscitative practices more important. Debriefing is important. You need to talk to the relatives after such incident is occurred. And the take-home messages I would like to give is constant training of your staff is important, and the changes in resuscitation practice for a maternal patient and perimortem cesarean section should be a consideration. Thank you. Thank you very much.
Thank you, sir. Thank you for an elaborate lecture on pregnancy code blue. And along with ABCD, we are fortunate here in Akluj to have support of all seniors, including senior physicians and gynecologist Satish sir himself. He is always there ready to help. And we are fortunate to have him as a chairperson today. So I request Dr. Satish sir to thank today's speaker and felicitate him with e-memento.
Hello. Dr. Rahul, your topic was maternal collapse. It is a huge topic, but you have covered it in short time and nicely. So we must thank you very much. You have covered in short time. Thank you very much.
Thank you, sir. Thank you.
Yeah, I request Dr. Priyakada madam to felicitate today's chairperson, Dr. Satish sir. Thank you, sir. Thank you. Now for the next lecture, I request Dr. Priyakada madam to invite next chairperson.
Now our next chairperson is Dr. Savita Gujar ma'am. She is the she was past president AOGS 2018-19. I will request her to come on the stage to chair the upcoming session. Now I will request ma'am to introduce Dr. Sudesh Doshi sir.
Good afternoon, all. It's my pleasure to introduce Dr. Sudesh Doshi. He is a friend and colleague. He's practicing in Pandharpur since last 25 years as a senior obstetrician. He was a past president of Pandharpur OBGYN and a chairperson Medico-Legal Committee AMOX and member of NIMC FOXI. This is his short CV, but beyond that, he is a great friend and he's a philosopher. He always helps us and advise us about all medical or legal problems we have or any suggestions if we have any problems. So I request Dr. Sudesh Doshi sir to take over, and he'll be speaking on convulsions in pregnancy.
Hello, over to you, sir.
Yeah. Am I audible?
Yes, yes.
Is my screen visible?
Yes.
Thank you. So at the outset, I thank Akluj IMA and all its members for inviting me and considering me as enough learned one to talk on this topic. Generally, I do talk on medical legal topics, but today my topic is convulsions in pregnancy. So without wasting time, I would go further. Convulsions in pregnancy, with all the blessings and greetings from Pandharpur, we all obstetricians and all medicos do require greetings and blessings from Pandharpur in case of mishap. So convulsions in pregnancy is going to be great mishap. So we always need blessings from God, Vithala and Rukmini. So what are convulsions in pregnancy? Convulsions in general term people use to describe are uncontrollable muscle contractions. Jhatke aale, hath pai wakde zale, akdi ali is the people what we describe in the local language. Some people may use it interchangeably with the word seizure, although seizure refers to an electrical disturbance in the brain, which may not always necessarily follow with a convulsion. Seizures may cause a person to have convulsions, but this is not always the case. Whereas epilepsy or convulsions, epilepsy is a chronic neurological disorder in person who has repeated seizures. Seizures are episodes of disturbed electrical activity in brain, which may manifest as convulsions. So today we will talk more about convulsions in pregnancy as related to eclampsia, because it is going to form a major chunk. 95% of convulsions in pregnancy are going to be eclampsia. Less than 5% of them are going to be the other convulsions. So convulsions in pregnancy. So what comes first to your mind when you see a pregnant patient convulsing? If she's more than 20 weeks, then the first thing which you should come to your mind logically is eclampsia. So how to differentiate eclampsia from epilepsy or eclamptic convulsion from a non-eclamptic convulsion? So in eclampsia, as we see, eclampsia is a feature of pregnancy. It may be either in pregnant patient, intrapartum or postpartum. Whereas epilepsy is a pre-existing illness with past history of seizures. 20 to 30% of people with epilepsy may have an increased frequency of seizures. In eclampsia, you always get tonic-clonic convulsions, which rapidly and promptly respond to magnesium sulfate and delivery of the baby. Hypertension and proteinuria are the main ingredients of eclampsia. Whereas in epilepsy, first episode may occur during pregnancy, but it is a very rare occurrence. You generally do get history of epilepsy, but what we expect or what we observe in day-to-day practice is that patient is a known epileptic patient, but the history of epilepsy is hidden from the in-laws. लग्न ठरायला अडचण येते म्हणून त्या पेशंटला झटके येत असतात, त्यांना एपिलेप्सी आहे हे सांगितलेलं नसतं लग्नामध्ये, आणि देन द मॅटर्नल पीपल, पेशंटची आई पण हळूच येऊन सांगते डॉक्टर तिला आधीपासून झटके येत होते, परंतु लग्न ठरताना अडचण येईल म्हणून आम्ही सासरच्या माणसांना सांगितलेलं नाही आणि तुम्ही पण आता सांगू नका. So this is nowhere written in the books, but this we have to learn from the experience that it may be epilepsy, but it is hidden fact from the in-laws. So you have to inquire about that history. And we have to look for other causes which may cause convulsions in pregnancy. The other causes which may not be directly related to pregnancy, but which may present as convulsions in pregnancy are infections like encephalitis, meningitis, cerebral abscess, cerebral malaria, tuberculosis. Here you will get a history of fever with rigors or long-standing fever and other things. Endemicity and epidemics also should be known. There could be history of trauma. Sometimes there could be an episode of domestic violence when the husband or the mother-in-law has hit the patient in the head or banged the head on the door. This I have seen one of such cases. Then there could be tetany. There could be drug withdrawal also. Few patients who may be on drugs, especially in metros, you may get such cases where the patients are on some medications or some drugs or some drug addicts, or they may be on long-term pain relief medications, and withdrawal can be the cause of convulsions. Metabolic things like hypoglycemia, hyperglycemia, as is seen in patients with diabetic mothers, insulin taken, but the main cause of hypoglycemia may be आज आता श्रावणी सोमवार आहे, आज भावाचा उपवास केलाय, पंचमीचा उपवास केलाय, शुक्रवारचा उपवास केलाय, and they take the insulin religiously because the doctors said that the insulin dose should not be skipped, but they forget to take a meal of their insulin because of fasting. उपवास केला की hypoglycemic convulsion मध्ये patient can come. Hyperglycemic patients who are diabetic but forget to take insulin, or there are rapid changes, patient in sepsis where the insulin requirements may increase, may have hyperglycemic convulsion. Patients with hyponatremia, hypocalcemia also present with convulsions. Some psychiatric disorders may present with convulsions. And secondly, cerebrovascular disaccharides like brain hemorrhage, infarcts, and thrombosis may present as a first convulsion in pregnancy. Tumors are also known to present as convulsions. Now, what you should do when you see a pregnant patient with convulsions? The RCOG guidelines say that if a pregnant woman presents with seizures in the second half of pregnancy, which cannot be clearly attributed to epilepsy, immediate treatment should be followed, existing protocols for eclampsia in that institute until a definitive diagnosis is made for a full neurologic assessment. Now, what is general management of a convulsion? Now, as we all are taught in MBBS and our various CPR managements and convulsion managements and various workshops, a general management of any tonic convulsion should be followed. What is that? That is, make the patient lay flat on the bed, especially on the rails, so that she should not fall down and injure herself. The basic management is to prevent the patient from hurting herself. So put a mouth gag to prevent a tongue bite. Oral suction should be done to prevent aspiration. Nasal suction should be avoided because it may cause again a trigger for a convulsion. IV access for medication should be done, and all our caution should be done to avoid injuries. Now, what is specific management of eclampsia? Now, we as obstetricians, we all know definitely eclampsia management, we know by heart. But since this is lecture for IMA people, and there may be many people who are working in PHCs, who are working in remote areas, who may be catering their needs as a general practitioner or as MBBS, once in a while, they may come across a patient who is eclamptic convulsion, and before referring that patient to another center or obstetrician or higher center, basic treatment of eclampsia should be given. Now, this eclampsia treatment is expected from non-obstetricians also. Not only non-obstetricians, but even the staff in obstetrician hospitals should know what is the basic treatment. Under telephonic guidance also it can be given. As Dr. Vani said, that we in Foxy Manyata are training our people, training our paramedics to treat eclampsia and to give the first aid for eclampsia. Now, in Manyata, there is a detailed program for training people for this. And I'm fortunate and I'm proud to tell that I myself have got Manyata certification, and a lot of facilities in Akluj, like Dr. Kadam's facility, Dr. Bharat Kaur from Maharashtra, and few others which I don't remember name, are getting Manyata accredited. And I would urge all the obstetric hospitals to get accredited for Foxy Manyata Lakshya certification. So the drug of choice for eclampsia is obviously magnesium sulfate. It comes as 50% ampules, 2 ml ampules. Now I'm going to little details because so we required 14 ampules, all are to be broken and kept there. Out of those 14 ampules, 5 grams of magnesium sulfate are to be taken in a 10 cc syringe, and it is diluted with a 2 ml of lignocaine and to be given intramuscularly on each buttock. So 5 grams in each buttock, that becomes 10 grams of 50% magnesium sulfate to be given as initial leading dose. And the IV dose is to be given slowly. Now, we do not give IV dose as 50%, but the 50% of magnesium sulfate is to be diluted with distilled water or normal saline to be made as 20%. So how to make this? Four ampules of magnesium sulfate, which is 8 grams. So that becomes 8 ml. Plus, it is to be diluted with 12 ml of normal saline or distilled water. And this is to be given as an infusion slowly over 20 minutes, looking for pulse and respiration. Now, after this initial loading dose, the repeat dose as given in Pritchard regimen is 5 grams to be given after every 4 hours intramuscularly. Now, there is a modification of this Pritchard regimen for our patients who are having a little lower weight. Dr. Sardesai Madam, respected Sardesai Madam from Solapur, who is a teacher of all of us, she's a teacher of teachers. She has given a modification, and a lower dose or Solapur regimen or Sardesai regimen also can be followed. Nowadays, where a lot of syringe pumps are available for continuous infusion, if you have your spouse as a medicine person, as Dr. Gujar has, MD Medicine Gujar sir with her, they do have a syringe pump with them. Then instead of giving 5 grams every 4 hourly. You can give Duzospan regimen where you give IV magnesium sulfate 1 gram per hour can be adjusted in the syringe pump, and slowly you can give it with monitoring to be done. If there is a repeated conversion in spite of the loading dose, then what is recommended is you give 2 grams of magnesium sulfate IV extra. Now, magnesium sulfate requires monitoring because magnesium sulfate toxicity can cause sudden collapse and respiratory depression. So, serum level monitoring, though theoretically possible and recommended, it is not possible in our setup where serum magnesium levels are not available. So what you can do is you have to clinically monitor the patient for magnesium sulfate toxicity. And for clinical monitoring, what you know, as we have been always taught in even undergraduate books, 3 things are to be monitored. We all have answered this question even in our UG and PG examinations. Patellar reflex is a thing which needs to be monitored. Patellar reflex, if it is present, then okay, you can go with the next dose of magnesium sulfate. If the patellar reflex is absent, then you will to wait till the magnesium sulfate is cleared by the kidneys, and you can repeat the dose after 2 hours. You have to wait for 2 hours more. If respiratory rate is also to be monitored. If respiratory rate, it is to be around maintained around 12 to 16 per minute. If the respiratory rate is going below 12, then the patient is going to magnesium toxicity, and you should withhold the next dose of magnesium sulfate for 2 hours more. Now, urine output should be measured and it should be 30 ml per hour. Now, urine output is not a direct indicator of magnesium sulfate toxicity, but if the urine output is more than 30 ml per hour, that means our kidneys are clearing of magnesium sulfate and magnesium sulfate levels are going low. And so you should have a urine output of 30 ml per hour. So every 4 hourly, before giving your next dose of magnesium sulfate, you need to monitor these things which are clinically always possible, which do not require very high end gadgets or something like that. Simple clinical examination, measuring the respiratory rate, measuring the seeing for the patellar reflex and urine output. And if all these 3 things are there, you can give a repeat dose of magnesium sulfate. Now, magnesium sulfate is to be continued for 24 hours after the delivery of the baby or the last convulsion, whichever occurs later. Now, for magnesium sulfate, giving magnesium sulfate, we need the training of the staff also. And for that, you need to have eclampsia drills. As Dr. Vani himself emphasized that as we have CPR drills, as we have PPH drills, similarly, you need to have an eclampsia drill to train your staff. So all obstetric facilities must have an eclampsia tray or eclampsia box or eclampsia kit, which contains 20 ampoules of magnesium sulfate ready there. We can say, nahi amcha त्या freeze मध्ये आहे, आमच्या तिकडे ओपीडी ठेवलेलं आहे, आमच्या दुकानात असतं. No, but when you require magnesium sulfate, then that delay also may be catastrophic. So you have to keep it ready in a eclampsia box. What you have to do so if your eclampsia drills are done, your staff is always ready. Like code blue, code pink, we have similarly. When we say it is eclampsia, your staff should be on the toes and your staff should coordinately and coherently work for eclampsia. One has to catheterize the patient, O2 mask is to be given. The eclampsia box will contain following things which will be required immediately for you: magnesium sulfate, approximately 20 ampoules, a Foley catheter, a urine bag, a knee hammer to look for knee jerks, catheter for oral suction. You require 120 cc syringe to give the loading dose. You require 10 cc 2 syringes to give the intramuscular loading dose. You require 5 cc syringe to inflate the Foley catheter. You may require injection labetalol to cut down the hypertension. You have to have tablet magnesium sulfate and other things also. Now, this is all about eclampsia. Now, going to epilepsy. Now, if you find a patient who is pregnant, but a non-eclamptic patient who doesn't have hypertension, who is less than 20 weeks, or who is a known case of epilepsy, then the patient is planning for epilepsy, then what is to be done? Now, a patient with epilepsy who is planning for pregnancy, few things need to be counseled with her. A detailed counseling with a neurophysician, with an obstetric care giving person should be done with the patient and her caretakers and her family, that if you are planning a pregnancy in a patient with epilepsy, you need to do all these things. It is not very difficult, or pregnancy in epileptic patients is not contraindicated, but she must know what all things must be done. She has to shift along with the neurophysician consulting. If she is on sodium valproate or she is on drugs which are more likely to be fetotoxic, which are going to cause teratogenicity in the babies, then she needs to shift herself from sodium valproate and other phenobarbital or other antiepileptic drugs to safer drugs like oxcarbazepine or carbamazepine or levetiracetam 3 months prior to the pregnancy. Patient should start with folic acid supplementation. Generally, all these antiepileptic drugs cause folic acid deprivation, and folic acid is generally given to them by neurophysicians also. But if the patient is not taking folic acid, then folic acid supplementation should be started 3 months prior to patient getting pregnant. If, and this happens many times with our patients, the patient is already on antiepileptic drugs and she gets pregnant while on antiepileptic drugs, then there are two schools of thought. Most of the times the patient comes to us at around 10 weeks, 12 weeks, 14 weeks. So by that time, the organogenesis is over. And if the patient is already on phenobarbital or other antiepileptic drugs, then whatever fetal toxicity has to be done is already the harm is done. So now if you try to change the antiepileptic drug, then while titrating the dose or changing the drug, the patient may land up in seizures. The frequency of seizures may be increased. So there is a school of thought that if the patient is already pregnant, she has taken antiepileptic drugs and she has come to you after around 12 to 12 weeks, where the organogenesis is complete. The cleft palate, if it is going to occur, it has already happened around 9 to 12 weeks. If cardiac anomalies, whatever are going to happen, have already occurred around 6 to 7 or weeks, then the change may not be very welcome and the patient may continue with counseling with the same antiepileptic drugs. So change may be less to the harmful antiepileptic drugs. Now this is a chart, this is taken from a textbook, which shows that in counseling the woman with epilepsy who plan to become pregnant, the practitioner should discuss the need for staying on anti-seizure medication, simplifying the medication regimen, attempting monotherapy. Monotherapy is you should not have more than one antiepileptic drug. The seizure should be considered as far as possible on a single drug, and selecting the medications with more favorable side effect profile. Dagadapeksha wheat move. You cannot have an antiepileptic drug which is not going to affect the baby. But obviously, antiepileptic drugs which have more favorable side effects on the baby should be offered. Now, as you can see in this chart, valproic acid is known to cause teratogenicity in almost 8 to 10% of people. So it is more toxic. So while sodium valproate needs to be cut down, whereas in order of favorability, phenobarbital has around 5 to 6% of toxicity. Pyramate, carbamazepine, phenytoin, clonazepam, lamotrigine, levetiracetam, and oxcarbazepine are the less fetotoxic patient drugs and are likely to cause less amount of teratogenicity. So risk of major congenital malformations in women taking antiepileptic drug as a monotherapy during pregnancy compared with women taking no antiepileptic drug based on data provided by North American Antiepileptic Drug Pregnancy Registry. This is a slide. So you, if the patient comes to you before she gets pregnant, you can, in consultation with the neurophysician, shift her to monotherapy, shift her to more safer drugs, and stabilize her, and then ask her to try for pregnancy. Start with folic acid. Now, this is again the drugs which are more safer. This is another chart showing this thing. Antiepileptic drugs with known teratogen effects exert the most serious side effects during the first 2.5 months of gestation. Changing the medication during first trimester to be maximally useful. The neural tube closes around 3 to 4 weeks. So neural tube defect is going to occur even before she knows that she is pregnant. Cleft lip and cleft palate may occur around 5 to 10 weeks. And whereas congenital heart disease due to anticonvulsant exposure occurs before 6 weeks of gestation. So if the patient is already on antiepileptic drugs, then you have to counsel them that teratogenicity may occur. Now, which are the safer antiepileptics? As discussed in the chart, oxcarbazepine, carbamazepine, levetiracetam, and lamotrigine are the safer antiepileptics. Now, in epilepsy, about 20 to 30% of women may experience increase in frequency of seizures during pregnancy, and the possible causes are low levels of circulating unbound antiepileptic drugs due to increased metabolism, sleep deprivation, and emotional factors. Now, pregnancy monitoring. Now, if you have a patient with a known case of patient with epilepsy, an antiepileptic drugs, what special precautions would you take in monitoring the pregnancy? Now, anomaly scans to look for neural tube defects, cleft lip and palate, and cardiac anomalies should be performed by a senior person, especially now we have a lot of fetal medicine person coming down who do a targeted scan should be done, or a senior radiologist who is available. Secondly, a serial growth scans to monitor fetal growth in patients with fetal growth retardation are required in the third trimester also. Now, during labor, an epileptic patient is more likely to throw a convulsion during labor because of more amount of stimulation, pain, sleep deprivation, hormonal changes. Now, if a patient is non-epileptic and she is not having preeclampsia and she throws a convulsion during labor, she may manage as an epileptic patient also. I will take a few clinical scenarios and then I will finish up my, I think I have doing in right amount of time.
Yes, sir.
Case 1, a known case of epilepsy gets pregnant, gets a seizure, which was well controlled till then now. There is no history of proteinuria. Then this is going to be neurophysician's domain. You will immediately give her urgent thing to control her convulsion, like midazolam or lorazepam can be given to control immediate arrest that convulsion. The initial management of convulsion can be done, and she should be referred to neurophysician for her change of dose of or change of medication of the anti-epileptic drug. You have to look for other causes, like maybe she's having other causes of other than epilepsy, like a trauma or metabolic cause or something like that. The dose may be increased, and it is preferred to keep the patient on monotherapy. Now, clinical scenario 2, a patient is around 30 weeks pregnant. As we say, a patient coming fully swollen, head is swollen, the nose is swollen, she has her edema on her feet, bilateral pededema, known case of pregnancy-induced hypertension, and she comes to you and she throws a convulsion in your OPD or your labor room. Now we know this is eclampsia, and you have to treat it as eclampsia. As we know, termination of pregnancy, the treatment of eclampsia, so you have to deliver her fast and give her magnesium sulfate. So she'll be treated on lines of eclampsia. Now, case 3, patient was on multi-drug regimen. She was shifted to monotherapy because she's planning a pregnancy. She gets pregnant, and now the seizures are not controlled with monotherapy. So we have to shift her to therapy with more than 2 drugs. Now, in these cases, those patients who are not controlled with monotherapy, who require more than 1 medication, then sometimes the patient may insist on getting a termination of pregnancy or medical termination of pregnancy. Now, in these cases, a thorough counseling is necessary to the patient. And if there is more likelihood of getting a cardiac anomaly or a neural tube defect or a cleft lip or cleft palate, medical termination of pregnancy may be considered on 2 grounds. First thing is injury to the physical health of woman, that she's not getting controlled with monotherapy. She's requiring more amount of drugs because her seizures are getting worsened by pregnancy. And on the second ground, that the baby may have an anomaly. On these 2 grounds, if the patient are insisting and if there is enough discussion with the neurophysician, then medical termination of pregnancy can be considered. So I think I have considered most of the time thing. Now it is to be epilepsy in pregnancy requires a combined approach, a neurophysician, the caregiving obstetrician, a pediatrician for the anomalies which may be suspected. So you may have to consult with a pediatric surgeon or a pediatrician who may be giving the newborn care, and thorough counseling about teratogenicity, worsening of surgeon, seizure is to be done, and it is to be a collective decision along with the family members, her in-laws, her people, her mother, father, her parents, all are to be taken, and after thorough counseling, a decision to continue the pregnancy or terminate the pregnancy may be done. So thank you very much for giving me this opportunity. Special thanks to Dr. Revati Rane for conducting this whole thing. I really admire her enthusiasm and the zeal which is conduct the program, and so much of enthusiasm taking all this task together. Thank you very much.
Thank you, sir. Thank you, sir. As usual, it was a wonderful presentation, very clear message and very practical presentation. And in spite of the post-lunch hyperglycemic session, we could, focus and pay attention to the whole lecture. Thank you. Now over to Gujar madam. I request madam to felicitate today's speaker with a momento. Sir, hello. So can you stop? Yeah. Share screen stop karta ka?
Yes.
Yes.
Yes, thank you.
Yes, thank you. I request Madam to felicitate our speaker.
Hello.
Yes.
Thank you, Dr. Sudesh. It was very nicely presented topic, convulsions in pregnancy. Though with good antenatal care and all support, we don't get so much of eclampsia because we control them at the stage of preeclampsia. And convulsions, other cause are you very well covered, and the treatment protocol also you clearly mentioned. So thank you very much. It was a nice lecture. Thank you.
Thank you.
Thank you, ma'am. Thanks a lot for chairing the session. And I request Priyakadam Madam to felicitate Gujar Madam.
संतोष खडतर नाच तिथे तर दिसतोय मी तुझीच लिंक देते दिसला ना
Lecture and very refreshing chairperson.
Thank
you. With this session, we'll take a break of 10 minutes. After that, we would begin with the sexology session. So I request all of you to join within 5 to 10 minutes. We are starting soon.
Madam, can you stop screen sharing so that I can start? Rani Madam. Am I audible?
Yes, sir.
Okay.
Sir, actually, yes, we would start. There was a break of 10 minutes.
Okay, it's okay. No.
So for sir, hello, sir, can you hear me?
Yes,
Yeah,
yes.
actually, sir, as per schedule, there is a break of 5 minutes. So is it okay that we join in 5 minutes? Need to change
Yes,
the
yes,
laptop.
sure. Yes, yes. Hello. दाखवून आता माझं लेक्चर सुरू आहे 15-20 मिनिटं मग मी लेक्चर मध्ये राहील ठीक आहे नाही आता मी नाही येऊ शकत तू मला त्यानंतर सांग काही ठीक आहे ना तू चालला ना डायरेक्ट मी देशपांडे म्हणून हा मी सांगून देतो तुझा तुझा नंबर आहे का त्याचा मी तुला नंबर पाठवतो आणि मी बोलून घेतो त्याच्याशी अभी अभी उसको सब चाहिए
Good afternoon, everybody. Good afternoon, Dr. Revati. You are muted. Dr. Revati is muted.
Yeah, good afternoon, everybody.
Good afternoon.
Good afternoon, madam.
Good afternoon, madam. Yes, sir. Yes, sir. Good afternoon, madam. Prasad, madam. Good afternoon.
Good afternoon, Sanjay. Everyone.
Yeah, how are you?
Yeah, like this. I will discuss continuously this week webinars. I said I will talk to you leisurely to know about that. Our conference. So unfortunately, same day the Foxy Managing Committee meeting they have kept.
Oh.
Good afternoon, Dr. Narayan Reddy. Muted. Dr. Reddy is muted.
Good afternoon, Dr. Padmini.
Good afternoon.
Sanjay.
Nice to see after a long time.
Yeah. It's good that due to webinars, we are seeing each other. So maybe not meeting personally, but
at least somewhat frequently we are seeing. Good
Post lunch, always sleepy.
Yeah, I was sitting and feeling drowsy. Suddenly, when I woke up, Sanjay had joined.
Actually, I took my lunch always at 1 o'clock. For me, 3 is good time.
Oh.
When is your next meet, Sanjay? 11 o'clock afterwards?
Pardon, sir?
You have 1 meet at 11 o'clock.
No, 1 minute, 1 o'clock.
Huh?
1 o'clock.
1 o'clock.
And next meal at 9 o'clock. So only 2 meals.
No breakfast?
No breakfast.
But now the latest fad is to prevent diabetes and weight loss. You must have what they known as restricted time eating. 16 hours you don't eat anything.
That's I am doing the intermittent fasting.
Intermittent fasting has been.
So from 9 o'clock in the night, I am actually fasting for 16 hours till 1 o'clock.
Yeah, same thing. I'm also doing the same thing, Dr. Sanjay.
And I have wonderful results. I lost 2 kg, 2 to 3 kg, and my blood sugars are absolutely normal. And my HbA1c is around 6 now.
Yeah, very nice.
You are not supposed to have even coffee or tea. You can have black coffee, black tea.
No, just
Not with milk.
It helps the metabolism quite a lot. Doesn't cause acidity actually. People think that it causes acidity, but I don't think it causes. Have you any time faced acidity problem?
No.
No.
Actually, my diabetes was because of overeating.
I just cut down on my eating quantity. I could reduce 6 kgs.
You are very
It is not a question of quantity of eating, amount of carbohydrates you consume.
Yes.
That's important. If you have 16-hour window, then whatever glycogen has been stored has been released into the body. The liver is stressed for further storage.
Yes.
The Jason Funk from Canada, a nephrologist, his latest theory is that you can go to YouTube and check that.
Okay.
He proved with statistics and research. In fact, my son, who is 40 years, he's got a very strong family history of diabetes because by himself and his mother, all of them are diabetics.
Okay.
He was put on metformin 800 SR. Now, after following this for 2 months, he is totally off any drug and his sugar is within normal levels.
Yes.
I am only scared to skip my breakfast.
No, once you are used to this medication, then hypoglycemia very easily get it.
13 hours I manage.
Yes.
But after that, I'm scared.
I have not yet stopped my medications. In the morning, I am taking teneligliptin, and in the night, metformin, 500 milligrams. How is COVID now in Bangalore?
I don't know whether just a fear or fear factor, but not much. Not so much. They are expecting another wave, but otherwise, right now, the incidence is not so much. Those who are coming from outside only, they are testing positive. That's the main problem.
Is it a new wave or the same thing continuing?
Same continuing. But only in Kerala, Bombay, so they're telling some.
They call it a long tail.
No,
anyway, Sanjay is well protected, wearing gloves.
Now also wearing gloves. No
My
mask.
practice, apart from gloves, I wear a face shield.
I'm still in the OPD. I'm using gloves, face shield, mask, 2 masks I use, and ask the patient to sit distant around 4 to 5 feet away. So lot of strain on voice also.
Hello.
Yes.
Hello. Good afternoon, everyone.
Yes.
Should we
Yes,
start
good
with the
afternoon.
session?
Yes, it's already 3:30, I think.
Yes, thank you all for joining. Now for the session of sexology, I would like to call upon today's coordinator, Dr. Shrikant Devdikar. I would like to call upon Dr. Shrikant Devdikar on stage. And today is also incidentally World Association of Sexual Health Day. So it's World Sexual Health Day. So we are very honored to have you as speakers today. to celebrate it on the IMA state level conference. Over to you, Shrikant.
Good evening, everybody, or good afternoon, whatever it is. Coming to the most important and most awaited session of the day, for which everyone must be interested. And surprisingly, as Dr. Veda also told, that today is the World Sexual Health Day. So the Sexual Health Day started by the World Health Sexual Association, was started in 2010 to create more awareness in sexual life. So basically the first slogan of it was, let's talk about it. And that's what we are doing today. We are talking about sex and sexology and trying to bring more light so that it can help our patients in a better way. So let me invite two chairpersons today on the stage who need no introduction. One, our president, our beloved president, Dr. Santosh Khattare, sir.
Big round of applause.
Who is a pathologist and more of an sexologist of the town. And secondly, Dr. Abhijit Gandhi, who is a neurosurgeon and an andrologist. So without making no delay, let us begin the topics. Thank you.
Shrikant, we also have Dr. Meenakshi Deshpande madam as a chairperson. She has joined virtually online.
Yeah, we have
joined.
Dr. Meenakshi Deshpande, who's the chairperson who's joined live. Let me welcome her also. And let us begin the session. Thank you.
Thank you, Dr. Shrikant. As our today is the World Sexual Health Day, and here we are starting our this sexology session here. The first speaker is Dr. Sanjay Deshpande sir. Dr. Sanjay Deshpande sir is the chairperson of Council of Sex Education and Parenthood International Society. He is the finance director of IMA Maharashtra State PPS scheme. He is the honorary secretary Indian Andropause Society. He is the past president of Indian Medical Association Nagpur. Sir is a recipient of Golden Lamp Award, which is given by Council of Sex Education and Parenthood International. He is the best honorary secretary by IMA state and national level. He is the best president of IMA at Maharashtra state and national level also. He is the receiver of Suresh Nadkarni Mitra Mandal Award for article on sexual medicine by IMA Maharashtra. So here over to Dr. Sanjay Deshpande sir for his elegant talk. Sir, please. Thank you, Santosh. I request the organizers to stop the screen sharing so that I can share my screen.
Yes, sir. Yes, sir. Stopped already. Yes, sir.
So I hope everybody is now able to see the screen.
Yes, sir.
Yes.
Yeah. So thank you very much. IMA Akluj branch as well as IMA Maharashtra State Academy of Medical Specialties for having this wonderful conference, AMSCON, which is very, very dear to me also, because I was also honorary secretary of IMA AMS, AMS, as well as chairman of IMA AMS. And it's very fortunate that on two organizations, myself and Dr. Santosh, we are working together. So thank you, Santosh, for this good opportunity of sharing our experiences with everybody of you all. And it's a very, very successful conference. I am seeing around 452 participants here. So very big successful conference. RTS, congratulations to IMA Akluj branch and Dr. Santosh Khadtare in person. Congratulations, Santosh. Today, yeah, मराठीत एक दोन वाक्य बोलतो की आज कसा हा दुग्ध शर्करा योग झालाय की सेक्शुअल मेडिसिन वरची कॉन्फरन्स किंवा आपण म्हणू एक वर्कशॉप आणि तो वर्ल्ड सेक्शुअल हेल्थ डे ला. सो थँक्यू व्हेरी मच संतोष फॉर ऑर्गनायझिंग दिस अँड हा योगायोग जुळवून आणल्याबद्दल धन्यवाद. So let us now come to our topic of today, erectile dysfunction in COVID survivors. Friends, all of us know that COVID from last say March 2020 to 1.5 years has gone, and in this 1.5 years, lot of turmoil took place. Because of COVID, we had many more problems than erectile dysfunction in our community, in our vicinity, in our patients, in our relatives, in our families. There are many more problems. People are suffering with the disease and many other complications also. As you know, erectile dysfunction is defined as inability to achieve erection for the successful sexual intercourse. It's either inability to achieve or inability to maintain the erection. And this is the most serious and mostly talked sexual dysfunction in males. In males as well as females, whenever there is a discussion, people usually talk more on erectile dysfunction because that is the most important thing to happen. Then and only then the sexual intercourse takes place. There are plenty of reasons for erectile dysfunctions, plenty of causes for that rather. The most importantly, psychogenic erectile dysfunction is much more talked about or make fun out of it. But erectile dysfunction can be both organic as well as psychogenic. And nowadays with the all pandemic or epidemic of all these non-communicable diseases like diabetes, hypertension, coronary artery diseases, or obesity, metabolic syndrome, erectile dysfunction has increased many folds in middle-aged men. And now coupled with COVID situation, we all know that the mortality of COVID is around 1.5 to 2% case fatality rate, we call it. Like in Maharashtra also it is 1.98, something like that. So rest 98% of the males or all the population, they survive. Now there are very few studies, I understand, but there are many preliminary reports about the impact of COVID infection in those COVID survivors, in those 98% of the COVID survivors. As we know, COVID is more fatal in men. So it was presumed or assumed or hypothesized that COVID may have some sexual problems also. Now, what are those realities? What are the little evidences which we have gathered? I've tried to collect those evidences and I'm putting forward to you. Now, as we know, the sexual activity is an integral part of living, and its success is increasingly recognized as an essential indicator of positive health and quality of life. Quality is more important. It's always said, I jokingly tell my wife, she's a physician, that you add years to life, but we add life to years, because sex is a quality of life. A person is living, but without sexual pleasure is not that happy. Because if you say what is the main important aim of having or observing sexual health day, World Sexual Health Day, or sexual health per se, is having sexual pleasure, free from coercion, free from sexually transmitted diseases, and free from any sexual myth. In together, then we can call it as a sexual health. So it's very important to feel the pleasures in life, and that too sexual pleasures. On the contrary, poor self-rated health and chronic medical conditions are associated with decreased sexual capability, which has a negative reflection on man, family, and community. I always tell my patients that there is only one disease which has impact on another person. If a man is suffering from some sexual problem, his partner will also suffer. Or if a partner or if a woman is suffering from some sexual problem, her partner will also suffer. So it's suffering in the couple. And that's why treating and recognizing sexual problems and sexual health in total is more important. The literature review revealed a significant number of clinical studies investigating the influence of COVID-19 on several body organs and application of many management protocols. However, the impact of the disease on male sexual functioning did not receive much attention because sex is not life-threatening. Sexual dysfunctions are not life-threatening. And that's why it's logical that people don't feel important to discuss this. But as the organizers of this conference, they recognize its importance, that it is a quality of life which is very important with the quantity of life. The studies reporting how this function is changing under COVID-19 are very minimal and many information is lacking. But still, this is my little attempt to highlight some important factors in post-COVID cases. Now, studies have shown that the ability of COVID-19, this virus, to enter cells relies heavily on the presence of ACE2 angiotensin converting enzyme 2. And before binding to ACE2 receptors, these viral spike proteins, they must be primed by cellular proteases and specifically transmembrane protein serine 2. Therefore, COVID-19 appears to affect cells and tissues that co-expresses ACE2 and TMPRSS2. Interestingly, both these ACE2 receptors and TMPRSS2 genes are expressed on the endothelial cells, and they likely explain why COVID-19 infection produces widespread endothelial dysfunction. There are many studies now that endothelial dysfunction or cardiac health is deteriorated. People have sudden cardiac deaths or myocardial infarction has increased in post-COVID survivors. So maybe it is because of this factor that leads to endothelial dysfunction. Even electron microscopy, the presence of COVID-19 viral elements in endothelial cells of affected organs such as lung, heart, and kidney were reported. Now, these findings raise the question as to whether erectile tissues in penis, which is very rich in endothelial line blood vessels, can also be subject to widespread endothelial dysfunction caused by COVID-19. Endothelial dysfunction and erectile dysfunction, these are very closely related. As we know this, the persons who are having endothelial dysfunction are more prone for erectile dysfunction, or vice versa. The persons who are having erectile dysfunction has endothelial dysfunction also. And that's why in after 40s of a man, it is documented now that when a person has erectile dysfunction, the chances of coronary artery disease or chances of MI is nearly 1.9 times more in those persons who are not having any erectile dysfunction. So this endothelial dysfunction and erectile dysfunction has been correlated in previous studies also. There is one very good study, very interesting study, which these people have carried out. They have carried this study on only 4 patients because it's a very difficult study. These 4 patients were those who were undergoing penile implant surgeries. So they took 2 COVID positive patients and 2 COVID negative patients, and then they saw the differences between them. The tissue from COVID-19 positive and COVID-19 negative specimens were imaged using transmission electron microscopy and stained with hematoxylin and eosin. The transmission electron microscopy revealed that extracellular viral particles more than around 100 nanometers in diameter with prominent spikes and electron dense dots of the nucleocapsid inside the particles near penile vascular endothelial cells of the COVID-19 patients. So the presence of this or infection up to the level of penile tissue was actually substantiated by this. Notably, viral particles were not detected in tissues obtained from COVID-19 negative patients. There are many other reports also. There were no significant difference between H and E staining in both these cases. COVID-19 RNA was detected in both the penis biopsy samples from men with history of COVID positive, but not in the samples from history of no COVID at all. Immunohistochemistry showed decreased endothelial nitric oxide synthesis, an enzyme expression in the corpus cavernosum of COVID-19 positive as compared to COVID-19 negative. And this is more consistent with endothelial dysfunction. COVID-19 spike protein positive cells would not be, however, detected in COVID-19 PSR. COVID-19 PSR positive also. But the EPCs, that is endothelial progenitor cells levels, were 0 in COVID positive, while it was 1.167 cell per well, respectively, compared to men from 34 men with severe ED. So endothelial progenitor cells are basically, they show how the re-endothelization is done, how the vascular, what you can say, recovery is there. That recovery was very less in COVID positive as compared to COVID negative patients. The endothelial dysfunction from COVID-19 infection can contribute to the resultant ED. This was the main conclusion of this study. However, the study sample was very less. Now, everybody of us know that vascular integrity is necessary for erectile dysfunction, and endothelial damage associated with COVID-19 is the most likely factor which is affecting the penile vascular flow, resulting in impaired erectile function. First, similar to other complications related to COVID-19 of ED can be the result of systemic infection resulting in widespread endothelial dysfunction. It may be possible that even direct orchitis or direct was any insult to these tissues also may be the risk factor or causative factor for erectile dysfunction in these COVID post-COVID survivors. And worsening of these patients' ED can be due to the virus presence within cavernosal endothelium itself. Now, this is the direct mechanism as well as indirect mechanisms also. Cytokine storm, we know. Direct mechanism can be direct orchitis, or hypoxia also can cause the direct tissue damage, and because of that, then there can be increased temperature, increased vascularization, increased interstitial space. Organ mass can be then therefore reduced. Lipid contents of Sertoli cells can increase. Lipid peroxidation can increase. Oxidative stress can increase. And many indirect mechanisms like inflammation, RASS, renin, angiotensin, this axis, that can be dysregulated. Hypoxia, fever, brain alterations, or even medical therapy, most importantly steroid, which also can result in less testosterone or androgen secretion, thereby causing erectile dysfunction. We'll go one by one with all these mechanisms. So direct mechanism can be this, because we know that these receptors, ACE2 receptors, are also common in the testes also. And therefore, presence of this ACE2 inhibitor on cell surface increases the risk of local infection. So there can be direct local infection of COVID, because we know that ACE2 inhibitor is existing on spermatogenia, Leydig cells, Sertoli cells. So direct dysfunction of these cells also can hamper, which can either reduce the testosterone secretion as well as reduce the spermatogenesis also. So it can even lead to fertility or infertility problems also. It may release, rather, because these are the earlier evidences. The existence of angiotensin II receptor on Leydig cell has been proven. Angiotensin II inhibits the production of both basal and LS stimulated testosterone synthesis by Leydig cell. And because of that also, erectile dysfunction may be common in post-COVID survivors. And the presence of ACE2 inhibitor in testes may increase the risk of orchitis among the COVID-19 patients. This was previously was the direct mechanism. This is an indirect mechanism. The severity of the disease, these are all inflammatory markers as we are seeing, and their presence is high in COVID survivors, interleukins, interferon Y, monocyte chemoattractant proteins, granulocyte colony stimulating factors, macrophage inflammatory proteins, high levels of all these IP10 and these granulocyte colony stimulating factors, monocyte chemoattractant proteins and all. They have started, they were found increased during these patients in their ICU admissions also. So maybe because, and it has been proven that these inflammatory markers also has a direct role on endothelial dysfunction. So because of this also endothelial dysfunction can take place, and because of endothelial dysfunction, erectile dysfunction can take place. Then this RAS, renin-angiotensin-aldosterone system, the increased levels of serum LH and decreased testosterone LH ratio are often clinical signs of primary hypochondroplasia, confirming Leydig cell dysfunction. This altered level of sex hormone can explain how testicular impairment is induced by Leydig cell dysfunction due to lower ACE2 activity and angiotensin 2 or ATIR pathway imbalance. The presence of RAS components, that is angiotensin converting enzyme, on several cell types and testes confirm that these components play a critical role in the regulation of steroidogenesis, testosterone secretion, spermatogenesis, epididymal contractility, and sperm function in the testes and epidermis. There can be hypoxia also, which can directly lead to the reduced level of fertility because of increased oxidative stress in testicular tissue. Because hypoxia is not only limited to any one part of the organ, but it is a general hypoxia, and that also can explain the direct effect on these genital cells. Fever itself also can be because of high and sustained elevation in body temperatures has been reported to impact spermatogenesis and leads to reduced quality of sperms in viral infections. High fever can affect chromatin structure infertility in humans and animals. Hypothermia increases the intratesticular temperature and causes vascular disturbances, which itself triggers the inflammation in testicular functions. It has suppressive effect on the steroidogenesis and spermatogenesis both. So these are the various mechanisms which may explain the increased rates of erectile dysfunction in post-COVID survivors. There may be brain alterations also. Altered levels of gonadotropins and testosterone in males. Subject might be due to dysregulation of hypothalamic pituitary testicular axis. Well, there is an association between impaired HPT axis and Leydig cell dysfunction. Increasing evidence shows that hypothalamus abnormalities can be responsible for dysregulated secretion of testis-derived sex steroid hormones. Hypothalamic lesions in patients with COVID-19 have been recorded, increasing the risk of HPT axis. In addition, high expression of ACE2 in hypothalamus makes this region a hub of SARS-CoV infection. Moreover, dysregulation of HPT axis can be a psychological impact of COVID-19 pandemic also. Fear and stress in patients with COVID-19 can include several mental problems, including anxiety, depression, post-traumatic stress disorders, and sleep disturbances. These also can add up, causing increased erectile dysfunction in COVID survivors. Recently, it was reported that survivors of COVID-19 shows more anxiety, more psychotic disorders. Increased activity of these sexes due to stressors has a direct inhibitory effect on gonadotropic releasing hormones.
Hello, sir.
Therefore, yes, I will finish within last 2 minutes.
Yes, sir. Yes.
Therefore, the mental and pathological impacts of COVID-19 on hypothalamus should be highly considered in patients or recovered cases with abnormal gonadotropic hormones. Even medical therapy also can directly lead. High levels of corticosteroids used can also affect that. Chronic administration of non-steroidal anti-inflammatory drugs also can affect sperm quantity, quality, and many other things. Antiviral drugs also can reduce testosterone levels. And as I told in my first part of the lecture, that erectile dysfunction or erectile function is a surrogate marker of cardiovascular or pulmonary health. And that's why it is very important. We should not neglect erectile dysfunction, at least in today's scenario, in post-COVID survivors or COVID survivors. Now, apart from COVID, we have to look into many other aspects also. Post-COVID survivors having these issues like comorbidities like diabetes, hypertension, coronary artery disease, previous coronary artery disease, obesity are more vulnerable for getting erectile dysfunction as well as worsening of their cardiac health. Age, if age is more are the chances of endothelial dysfunction and erectile dysfunction. Earlier sexual dysfunctions make them more prone for having more difficult sexual dysfunction to treat. Marital status, more of divorcee or separated or unmarried people, they may have more chances of sexual problems with these organic problems also. If marital issues, not having good marital relationship also can put them at more risk of sexual problems. And lastly, but provision of privacy, comfort and security in cases of these lockdowns and this isolation and quarantine also are playing very important roles, and which are very important whenever we treat a person case by case. The management, we have to investigate the patient for testosterone, evaluation of cardiac functions, blood glucose, HbA1c for the level of diabetes control. The treatment can be testosterone replacement therapy or PDE5 inhibitors, which are in the range of sildenafil, tadalafil, vardenafil, udenafil, and the recent one is avanafil. Lifestyle modifications are also very important. A good exercise, good diet, good glycemic control, and last but not the least, a sex counseling is very important for individuals as well as for the couples, because we have to make them understand why this has happened to them. I think this is all about what is the causes of erectile dysfunction in COVID survivors, how we should start investigating them, and how should we proceed for the treatment and counseling. I rest my case here. I stop my discussion. Once again, thank you very much for calling me here. And on this auspicious day of World Sexual Health Day, this year's theme, as you know, is that turn it on, sexual health in digital world. So because now we have started doing a lot of consultation, online consultation, people are on digital platform, and because of this digital platform also, they are more vulnerable for having sexual dysfunctions because of their sedentary lifestyles. So every physician who are treating these COVID survivors for in any discipline, for any disease, should definitely consider the sexual health of these patients. So thank you all. Once again, I thank Dr. Santosh Khadtare, IMA Akluj, and IMA Maharashtra AMS. Thank you. Thank you very much.
Thank you, sir. Thank you, sir, for an elaborate talk on erectile dysfunction and covering it on molecular level, and also creating an awareness in specifically in COVID era. Now I request Dr. Khadtare, sir, to thank today's speaker. Deshpande, sir, with
Thank
an
you,
e-memento.
Dr. Sanjay Deshpande, sir, for giving an elaborative talk on erectile dysfunction in COVID survivors. Thank you, sir.
Thank you. Thank you. Thank you, Santosh, for this wonderful memento.
Yeah. Now we proceed with the next lecture. To introduce next speaker, I request Dr. Abhijit Gandhi, sir, to come on stage and introduce Dr.
Good evening, everyone.
Dr. Narayan Reddy, sir. Yeah.
I invite Dr. D. Narayan Reddy, sir, from Chennai, to give a next lecture. Dr. D. Narayan Reddy, sir, is a well-known speaker. He is not only national speaker, but also a renowned international speaker. He is a certified supervisor of sex therapy of American Association of Sexuality Education and Counselor. He is also course conductor and faculty of College of General Practitioner, IMA. He is also president of AOFS. chairman of CSEPI Society. He is patron of Indian Anthropology Society. He is also associate editor of Journal of Sexual Relation and Sex Relation Therapy. He is also awarded with many prestigious awards. Over to Dr. D. Narayan Reddy, sir, for his lecture.
Thank you, sir, for your kind words of introduction.
Yes, sir. We would share your presentation. Just a minute.
Please. Friends, at the outset, I would like to thank Dr. Santosh Kadatare, who thought about me. And I am also grateful to the Akluj branch of IMA for giving me a chance to be with you on this World Sexual Health Day. My previous speaker, Dr. Sanjay Deshpande, clearly told the theme of today's World Sexual Health Day theme is Turn It On, Sexual Health in a Digital World. That is what we are precisely doing. We are trying to promote sexual health through the webinars, and that's very important for us. And what is that we can do for promoting sexual health and rights in India? Next slide, please.
Yes, sir.
Now let us see what the definition of sexual health. Next slide. I don't want to repeat what all of you know. That is basically, it is not this, not this absence. All of us know physical, emotional, mental, social well-being. But most important, next click, please. I have marked that in pink color, pleasure. And today, you'll be surprised. In 2002 itself, WHO included the word pleasure in the definition of sexual health. And at the coming conference, the 25th Congress of the World Association for Sexual Health, which is being held virtually, but supposed to be held in Cape Town, South Africa, they'll be releasing a declaration for sexual pleasure. Earlier, they declared sexual health rights. Now they are focusing on declaring sexual pleasure itself. Now, for sexual health to be attained and maintained, sexual rights of all persons must be respected, protected, and fulfilled. Next slide, please. Yeah. As I mentioned earlier, the WHO document in 2002 used the word pleasure, but unfortunately, subsequent working definitions never bother about pleasure. It is being reintroduced now. Next slide, please. Now, sexual rights imply individual and societal responsibility. This is very important. You must understand that with every right, you also have to have a responsibility, your share of duty, what you have to do. Next slide, please. Now, when we use the word sexuality, it is not just about sex. The dictionary meaning of sex, as all of you know, is gender. Whereas sexuality encompasses a very broad range of activities and feelings. Besides the physical act of sex, it includes gender identity, sexual orientation, eroticism, importantly, pleasure, intimacy, and reproduction. Now, sexuality is experienced and expressed in thoughts, fantasies, desires, beliefs, attitudes, values, behavior, practices, and relationships. Why I am stressing this? When some of you are going to practice sexual medicine or sexology, you must clearly understand how each of your client thinks, what is his value or her value, what are the attitudes, what do they believe. For example, they all believe that masturbation is harmful. Thanks to our quacks which are burning. I am glad Akluj IMA has taken up this subject now. Earlier, since we qualified medical practitioners were not available, clients were going to unqualified people because they advertise in billboards. You and I cannot advertise because it's against MCI and now NMC regulations. Now that's very important. And most important is you cannot have comprehensive health without attention to sexual health. And what is important for us to understand, there is no normal sexuality. People always come and ask you, doctor, is it normal? Journalists will ask you. Most clients will have, doctor, I have a 2.5 inch long penis. Is it, you think it's normal or not? Or I have sex 2 times in a week. Is it normal or not? We must understand there is no normality, holistically speaking. If you have to talk about normality, you have to talk from the following dimensions. 1, statistical normality, socio-cultural normality, medical or biological normality, and legal normality. Finally, phylogenetic normality. Unfortunately, none of this agree or coordinate with each other. For example, according to Kinsey, 95% of the respondents confess they have at least masturbated once in their lifetime. So statistically, it is normal. But which religion agrees with that? Which society agrees with that? And how many of our own doctors agree with that? You'll understand now. So do not fall into the trap of trying to define normality in a single unity of a particular thing. The quality of person's sexual experience is affected by individual differences, life situations, as you know, hormonal levels, and by overall health and well-being. Next slide, please. Now, the question will come, Dr. Reddy, but why should we have sexual rights if you're talking about sexual health? Next slide, please. Because sexual rights or sexual health rights enable the availability and accessibility of sexual health care. That is why we definitely do require the sexual health rights. That's why we are observing the World Sexual Health Day. I don't know why they chosen September 4th. Probably the only day which is available for them. Like we have December 1st for AIDS. Let us not with the word we celebrate and wish everybody happy Sexual Health Day. No, we have to observe sexual health and try to promote it. Next slide, please. Now, sexual rights usually embrace human rights. And these human rights are already recognized by national laws, international human rights documents, and other consensus statements. They include the rights of all persons, free of coercion, discrimination, and violence to the following: the highest attainable standard of sexual health, including access to sexual and reproductive health care services. Seek, receive, and impart information related to sexuality. Provide sexuality education. Respect bodily integrity. Choose their partner, the right to choose a partner. Parents cannot decide. Society cannot decide. No moral policing can decide. Policing. Individual has the right to choose their partner. Interreligious, intercaste marriages, all are fine as long as both of them are agreeable to it. Decide to be sexually active or not, they can decide. They can have consensual sexual relationship, consensual marriage. They can decide whether or not and when to have children. Pursue a satisfying, safe, and most important, pleasurable sexual life. This is where we healthcare professionals come into the picture. A responsible exercise of human rights requires that all persons respect the rights of the others. Next slide, please. Now, what exactly you mean by sexual health promotion? Next slide. The objective of sexual health promotion is to facilitate individuals and communities and population groups to enhance control over the determinants of health and thus increase people's capacity to obtain optimal sexual and reproductive health over the period of course. It is very important. The promotion of sexual health system. The key point is sexual health promotion is the delivery of strategies to promote sexual health. Promotion of sexual health behaviors can involve complex intervention that address issues related to empowerment, negotiation skills, self-esteem, health, knowledge. Now, the word empowerment must be able to be understood. Empowerment is saying, no, we are passing this law. No. Empowerment is making the persons become aware, accept, and make a decision to do what they want with their lives and with their bodies. The day when they can do it without coercion, that means you are really empowered them. Next slide, please. As we know, it is influenced by a complex number of factors, biological, genetic, etc., etc. Now, addressing these needs, integrative interventions by trained health providers and a functional referral system. It also requires a legal and policy regulatory environment where the sexual rights of people are upheld. This is where our governments and the courts come into the picture to enforce these rights and make sure that we follow the sexual rights. Next slide, please. Now, to promote this, what do we need? We healthcare professionals must understand and appreciate sexuality, gender roles, and population designing and providing services. Understanding sexuality and its impact on practicing, that's important. Now, it produces a lot of challenges as well as opportunities for improving all these healthcare services. Next slide, please. Now, you have to think in terms of changing the behavior. Behavioral approach of sexual health promotion has to involve to motivate individuals and groups to change their behavior. How? Through a range of educational, motivational, peer group, skills, and community normative approaches. Dr. Sanjay Deshpande, being a community services man, be able to appreciate it much better. Now we have to do all these things. For example, let us take HIV. The behavioral strategies reduce the transmission of HIV to attempt to delay the onset of intercourse, decrease the number of sexual partners, and to correct consistent use of condoms. This is an example I'm giving. So we have to make such attempts to promote sexual health. Next slide. Now, friends, please understand, behavioral change will not come overnight. Even in the practice of sexology or sexual medicine. We say, doctor, we are counsel, but person has not changed. This is the question posed by many youngsters to me who come and undergo training under me. Sir, as you told, I counseled them, but still they have the same beliefs, their behavior is not changed. That is because we have not understood that a change in behavior cannot come overnight. There are steps. The following steps are, first, the person is unaware. And then we have to create information, give it to them to make them aware. Only when we make them aware, they start becoming concerned. All the information we go through our media, television channels, professional organizations. That's what they try to do, to make people understand, become aware, and become concerned. Only they will try to read and learn more about that and become knowledgeable. And because of that, they become skilled. Please go back to my slides. Please go back to my slides.
Yes, sir, doing it.
Yeah, that's right. No, go back to the previous one. The previous one. Yes. Now, only when they become knowledgeable and skilled, then they have motivation to change. Once they are motivated, they are ready to listen to you and to change. And once they are ready to undergo change, they will do a trial assessment of the new behavior, whether it is going to be useful to them or not. Once they are happy with that, then they maintain or adopt the new behavior. So many steps have to be gone through. Today, unfortunately, we are at the stage where we are trying to make people concerned by observing the World Sexual Health Day. Next slide, please. Now, the recommendations for promoting sexual health are highly consistent in all documents. They include the following. You must create better climate for discussion of sexuality. This is why I'm worried about our extreme right-wing fundamentalists. Today we are talking about Taliban, but in our own country, we have moral police who interfere with Valentine's Day. Not that I support Valentine's Day, but when they are doing something, why should this interfere? That is why we have to create a good climate for discussion. Increase access to information and education about sexuality. And that is what our professional medical association can do through our association website, including community-based interventions, enhance access to care for sexual concerns, increase research in human sexuality, and evaluation of program design promotes sexual health. What Dr. Sanjay Deshpande is done is to increase research in human sexuality. We need such research in future also. Next slide, please. Now, what are these promotional strategies? They include public education, telephone helplines, and targeted risk reduction. Next slide, please. Okay, public aids. How do you do that? Through the media. Media campaigns can be a valuable way. If you remember when HIV/AIDS came, I don't know what the advertisement did in the north, but in south, they created a Puli Raja. and for your tobacco advertisement, cancer, prevention of cancer, you have a person, no? Satish or somebody, who they all Mukesh. So media companies are very useful in creating, but they have their own limitations. They cannot convey complex information. They cannot teach you social skills. That we only have to do it. At the same time, let us not dismiss social media campaign. They are useful in their own way. Okay, while they are trying to restart the screen, let me talk about World Sexual Health Day. Now, to start with, we have World Association for Sexology. After the advent of HIV/AIDS, then we realized when we talk about only management of sexual dysfunction, we are not addressing the issues like HIV/AIDS, other things. So they changed the nomenclature of the organization into World Association for Sexual Health. Having started that, we realized that unless we fight for this right, the governments are not going to really listen to us. So many people there, especially Dr. Esther Cano from Mexico, she is the United Nations body and WHO. She is trying to include sexual health into the documents of United Nations, UNESCO, and WHO. Will you please go back to my slides?
Yeah, just a second. There has been some error in the laptop.
Okay.
Yeah.
So having decided on that, they started talking about World Sexual Health Day, as I mentioned, on September 4th. Most likely, nothing else is clashing on that day. And each year, they coin a new theme. And as you know, this year theme is Turn It On. It's not being turned on by sex, but you turn your computer or digital platform on. And then the tag goes that sexual health in a digital world. As all of you agree, since April 2020, the corona has really shook our lives and made us homebound, stay at home. We've been interacting with each other, joining with each other only through webinars. And we found that more and more people are attending the webinars than the physical conferences. The physical conferences is definitely they are good in their own way because you can interact with the colleagues face to face. But many people are unable to travel, especially practicing doctors, from their hometowns, leaving their practice and go to a conference venue. But the digital platform sharing has overcome that, and they, without leaving the safety and convenience of their own hometowns and homes, they are able to really attend to most of the scientific information and knowledge through these webinars. Now, slightly digressing, I also belong to IMA. Once I was the president of IMA Apollo 1008 branch, and we all have what is known as quackery eradication cell. Now, by arresting by lodging a complaint, you cannot eradicate quackery. Yes, we are doing our bit. But why do people go to quacks? Because we qualified people are not available. That is why they go to quacks. And number two, unfortunately, television screens. I am sure in Marathi also something happened. In Tamil Nadu, after 10 o'clock, every half an hour, you have somebody, gemologist, an astrologer, a so-called Siddha fellow, a naturopath, etc., talking about sexuality. And they are misleading people.
Hello, sir. Sir, your
Yes.
slides are back. Slides are back. Do you want me
Yeah,
to continue slide?
yeah, this is the slide.
Last two?
No, this one, right. No. What you showed earlier. Yeah, before that.
Before that.
Yeah, this is the one, right. As I mentioned earlier, mass media campaign will be successful when you combine that with community-based initiatives. They do much more great service and are effective in promoting health promotion campaigns. Next slide, please. Yeah. Now, thankfully, we have telephone helplines available. And today, we have in India more than so many millions of people possessing a smartphone. I was told the density of mobile population in India highest in the world. So it becomes very useful to have a telephone helpline. Advantage being it is confidential and easily accessible source of information and advice. Other benefits include immediacy of response, a personalized response. Why personalized? I have been writing sexual health queries and columns for the past 35 years in many magazines, television channels, online portals, etc. I am also on YouTube. But when a question appears in a magazine like The Week, still somebody else asks the same question next issue. Why? Because they think the particular answer is too applicable to somebody else, not to themselves. Whereas in telephone helpline, they are happy, it's personalized to them. The cost is minimal, and they can get reference source to concern. Now, today, with the availability of www or the internet, the access becomes easy. But I am a little skeptical about the internet because most of the correct information is available only on professional organization websites. To access that, you have to become a member of that society by subscribing to the society. Outsider cannot access. But the quacks are making use of it. Now, you have more misinformation coming through internet because the advertisement like grow your penis by 2 inches by 4 Japanese method, etc. You know all that. So I am a little skeptical about that unless we are making sure that the professional websites are available free of cost to many people and promote that. Next
Hello,
slide,
sir.
please.
Yeah.
Next slide. Yes. The final one is the targeted risk reduction. This involves face-to-face small group work with peer support. Those of you who are familiar with the Family Planning Association of India work, there we do small group meetings with the peers. That's very, very effective. They are based on theories of behavior change. They are sensitive to a particular local culture and context. They address cognitive and attitudinal factors. They help in building motivation. They address gender issues. Focus on development of risk reduction skills, negotiating, condom use. I'll give you an example. Maybe a year ago or 2 years ago, there are a lot of children dying in Uttar Pradesh. It became big. Please go back to the previous slide. It became a big media sensation. So one of the English language television channels organized a debate. There we have the chairperson of a corporate hospital, I don't want to mention names, a very renowned cardiologist and reputed doctors. The only exception being Dr. Sujata was former Director of Health Services on the Pradesh government, now Telangana, and Director of NACO. Every doctor said, we must build more hospitals, we must have this one. Somebody said more corporatization, all that. It is
Hello,
Dr. Sujata who clearly told that more than that, how we manage malaria eradication and tuberculosis eradication by involving community level workers. Unfortunately, today we are short of this resource. We don't have sufficiently well-qualified, well-trained community workers who can do this targeted risk reduction, which is very effective in bringing out a behavior change. Unless we do that, I'm sure IMA will take the initiative, train many of the community workers.
hello, sir. Sorry to disturb you. Can we move on to sir? Sir, hello. Hello.
Now, WHO and other organizations have given practice guidelines on promoting sexual health for young people. It should be an integral part of the learning process. It should be for all children and young people, including those with physical, learning, or emotional difficulties. Don't neglect them. They also need that.
Hello. Thank
I
you.
forgot that key Cochrane acted.
Hello, sir.
1 minute, please. 1 minute. The last time, 1 minute. Kalki Cochrane acted because a disabled person talking about her sexual needs. Encourage exploration of values and moral issues of sexuality in personal relationship. Develop communication and decision-making skills. You must empower our youngsters. You must foster self-esteem, self-awareness, a sense of moral responsibility, and the skills to avoid and resist unwanted sexual experience. Today, everywhere we are talking about teenage pregnancies and
Hello, sir. There is some issue with the network. Hello. Hello. Thank you, sir. Thank you for the wonderful talk. Now I request Dr. Abhijit Gandhi, sir. Thank you. Hello. To felicitate Dr. Narayan Reddy, sir.
Thank you, Reddy sir, for your informative lecture.
Bouquet.
Now moving on to the next picture.
We'll felicitate the chairpersons.
No, at the end of the session, we'll felicitate. Hello. For the next lecture in the sexology, the chairperson is Dr. Meenakshi Deshpande, madam. So I request Dr. Shrikant Devdikar to introduce Dr. Meenakshi ma'am as a chairperson.
Good evening, everybody. So moving on to the next lecture, Dr. Meenakshi Deshpande. She is from BJGMC and SGH. She's a senior obstetrician and gynecologist practicing since last 28 years as a high-risk pregnancy consultant at Pune. She is the president-elect of IMA Pune, chairperson IMA Pune, treasurer for IMA MS, IMA National Standing Committee member for Initiative for Safe Motherhood, and IMA Delhi headquarters. She has been a recipient for many awards. To name a few, she has received the IMA Dr. Kanak Goyal Award for exemplary work in women's health and planning, Apulki Award for Women's Social Issues for 2 consecutive years, IMA National and MS President's Appreciation Award for last 2 consecutive years. She is a master trainer for FOGSI and WASL, member of FOGSI representative, NIMC National Inspection and Monitoring Committee for PCP, NDT and GUI. So we welcome Dr. Meenakshi Deshpande for the session. Thank you.
Hello ma'am. I request you to now introduce Dr. Padmini Prasad ma'am.
Yeah, thank you so much. I am Akluj and Dr. Santosh Khadtare for inviting me, and a very well organized and a very nicely attended conference of AMSCON 2021. It's a great pleasure to introduce Dr. Padmini Prasad. She is a consultant obstetrician and gynecologist, a sexologist and marriage counselor from Bangalore. I think she is the first woman qualified sexologist from Karnataka. She is a gold medalist in MD, and she's also the sitting president of Bangalore Obstetrics and Gynec Society 21-22. The theme, I think, is Women's Wellness and Illness. She's a chairperson of the Sexual Medicine and STD Committee, Karnataka State. She's a member of the World Association for Sexual Health. She's a secretary for Council of Sex Education, Parenthood in International CSEPI 20-23. She's a national coordinator of the Sexual Medicine Committee, FOGSI 20-22. She's recipient of numerous awards and felicitations. She's also featured on television and radio shows. And I'm very happy to present her to today's audience. And regarding her talk, I'd invite her to give her talk. Dr. Padmini Prasad, madam, the stage is yours.
Hello, welcome ma'am.
Yes. I'll share screen.
Yeah.
Namaste to you all. A very good evening to you all. At the outset, I would like to thank the organizers for giving me this wonderful opportunity to be with you all for such a nice knowledge sharing session. And wish you all a very happy Sexual Health Day. Thanks for the kind introduction. Thank you, chairpersons. I salute all COVID warriors. Condolences to all those who have lost their lives. And my today's topic is sex and relationship during lockdown. Yes. So there is a general panic and despair. The whole world is grieving. Day in and day out, we are all reading, watching, discussing about COVID patients, mild, moderate, severe cases, recovery rate, death rate, colorful fungi, isolation, quarantine, seal down, lockdown, and now vaccination. Yes, COVID lockdown. Let us stop talking about these patients for some time. Let us see what happens to the great majority of people who are caught in lockdown. How is lockdown affecting the great majority of people? Let us see the other side of coin. There are both positive side and negative side of lockdown. I call it before Corona and after Corona, BC and AC. Life is really very different after Corona. But we have to see how best we can improve the quality of life. So as the theme for this year, 2021, the digital turn it on, sexual health in a digital world. It means why this theme was introduced is because more and more usage of the digital world technology in all fields, and especially it is creating, in addition to helping, it is also creating sexual harassment, cyberbullying, and so many others. To bring it into the notice and do something and to create awareness. So this the theme was coined. So now, as I was talking, I don't want to talk about the negative things first. Let us go to the positive things. I came across a beautiful quote here, which really caught my attention, which depicts human emotions. A true relationship has tears, fights, trust, faith, pain, arguments, patience, jealousy, and most importantly, love. So Corona lockdown has taught us many new things, both positive and negative. The positive aspects, if you look into that, redefining, reinventing of relationships. Is it love lockdown or Corona lockdown? Is it home honeymoon because of the change in the rules for the marriage, honeymoon, traveling, especially for the newlyweds and the young couple? Is there a sex boom or a baby boom with healthy sexuality or unhealthy sexuality? There can be love, romance, passionate reunions, especially for these young people and the newly married. Highly stressful job employees can save some time for togetherness by saving on commuting, long hours of working. Touch, talk, time, together, and trust will really matter in this time of stress. So the relationships, as I told you, there has been a redefining, reinventing of relationships. The relationships can be exceptional, extraordinary, very uncommon, unique, remarkable, or outstanding. The relationship, when you take it as individual relationships are changing, the couple relationship equations are changing, the relationship with children, relationship with the family, and relationship with friends. So if you talk about the sex, what are the health benefits of healthy sexual relationship? The procreation and the recreation for excitement, enjoyment, and happiness. The relationship, building healthy relationships. Sex exercise, which is equivalent to a moderate exercise, which is good for heart, and it is an immunity booster. Endorphin and dopamine release, which are positive hormones. The genital organ health by a healthy sexual relationship, the prevention of prostatic problems, and relief of congestion, pelvic organ congestion. It improves self-esteem and also causes happiness and intimacy. If you look at the relationship in the family equations, never ever possibly you had looked into such themes, because now with the crumbling of joint families and the increase of nuclear families, only husband and wife, both working, and the children left alone at home from morning till evening, and they are catering to themselves, taking food for themselves, eating and playing. Now see that happy family, how you can see with the grandparents and the grandchildren enjoying, the children, they are teaching their own, the earlier, whatever the education in the forum, we can call it as family sexuality education. They were observing young children, their growth, their changes, their moods, which we are missing it nowadays. And you can see how the relationship has changed for so many, spending time with the family, grandparents and children, everyone, you can see the happiness in their face. Is it a home honeymoon for newlyweds and very minimum number can attend a marriage? The marriage they cannot go to exotic places, they cannot go to honeymoon places. So now they can create a honeymoon place within their home itself. they're having a romantic relationships within the home, whether it is in the bedroom, bathroom, or the hall, or wherever, they can create it and they enjoy their presence and enjoy with each other. So that is how the relationships have changed for even the newlyweds. And children playing so happily. They're so happy that parents are at home, enjoying and playing and learning, and also the socializing skills with playing together at home. And the online classes for children. So even though there are no schools, you can see even the positive thing, how it has developed, the digital world, how it has developed into even for small children, because they are not having the opportunity to play with the other children, learn with the other children. At least there is some amount of socialization and meeting of people, teachers, learning new skills through the online classes itself. And traditional games have come out. So only those places, it is only the video games and the games in their mobiles, and out of that, so all these traditional games have come to open and they are learning new things. All these, many people, many of you will love to come back to these games, but still, though we don't have time or don't have opportunity to play with all these things. And you can see the snake and ladder, chess, carom, and so many indoor games they can enjoy and then bring it back to our homes to play these things. And family time. We never had time to sit and eat, at least have one, either a lunch or a dinner, to sit together, enjoy the food and eat it. Now, many people, many practitioners were complaining. We don't have the GP, especially, we don't have ordinary diseases, and we don't have some of this vomiting, diarrhea, gastroenteritis, and respiratory infections because of the healthy food which is cooked at home and varieties, and with the grandma recipes and the traditional food that is cooked at home, which is keeping them healthy. And the work from home. So even for the work from home, nowadays, they say that when they are working from home, they're getting more time. The husband and wife are getting, at least they get to see each other. Even though there are negative side for the work from home, people complain that even from the work from home, our time, we cannot give time to each other. And the one husband was complaining, at least when my wife was going to office, I could see her dressed up and they're looking beautiful. Now, because we are working at home, she's not even taking bath late and then not dressing up. And the lipstick and cosmetic industries are crying that their sales are not there because of the mask. They cannot even use lipsticks. So these are the other things which are happening from work from home. So at least they can sit together. You can see the child coming and disturbing and someone running there. And then they are in the casual dresses. All these new things which have come from work from home. But at least earlier there were restricted hours. Now with so much of burden on the back for the work from home, because of the globalization, all odd hours from morning till midnight, they have to work. These are the other things about work from home. But at least they have, some of the couples are getting some time to get to know each other and stay together and do some things together. And you can see this digital, how nicely we are connected to each other. I am sitting at Bangalore, I am reaching to people from Maharashtra and all other places. In the similar way, we can get to meet, to build up relationship and share the knowledge with all these things. And even sitting at my home, I am giving a program through the television. I regularly give programs in the television. You can see how the digital world has helped. Our eSexCon, you can see how Dr. Venkatramana from CSCPI, he has done this eSexCon in the digital world, and that is digitally created our inaugural function. And we are meeting so many people. We are exchanging knowledge. And that is another aspect of the digital world. And you can see the philanthropy during COVID lockdown, how the human emotions, how the helping hand, how they care for each other. And so never ever you had seen such things. And you can see that they're distributing food packets or the medicines or looking after them. And so many NGOs, so many people who are helping people. So this is another side of human emotions and help given to them. So if you come to all this after this positive side, let us also look into what are the negative side of this COVID lockdown. There can be social problems, family problems, economic problems, which can reduce the desire and happiness of sexual contact and also the relationship. There can be sexual dysfunctions in both male and female. There can be sexually transmitted diseases, unwanted pregnancies and abortions. There can be sexual abuse, perverted sex, child sex abuse. The helpline number of calls from the child sexual helpline has increased about the sexual abuse at home and also the sexual abuse. Even for the Vanita Sahayvani or these calls for women's helpline, they say that the calls have increased because of the sexual abuse. There can be sexual experimentations, pornography, and quarreling because the husbands, if they are perverted and alcoholic and drunkards, forcing the wife because they get to have more time with the spouse. And this is the other side of it. Disturbed interpersonal relationship, divorce. They also say that during this lockdown, because of so many differences, and they are staying together from morning till night, and the relationships are spoiling, and also increased divorce rate. The stress, anxiety, fear of losing the job. This is uppermost in everyone's. So many people have lost jobs, and that is causing severe anxiety in them. You can see how the domestic violence, there is an increased incidence of domestic violence, especially those women who are suffering from those husbands or due to various reasons, that is increasing, but they cannot come out, cannot tell anybody, and they have become the silent sufferers. And the disturbed interpersonal relationship, arguments, quarreling, and not staying together, not looking at each other. So ultimately ending up with the divorce. And the child sexual abuse, especially in some of the joint families within the house, there can be incestual problems and they can be abused. And alcohol smoking, you can see there is a big queue in front of the bars rather than in front of the hospital or other places. So even whether it is a man or even so many women and ladies, they are also drinking. So much of sales have gone up about the alcohol when they gave permission. So this is increasing again the addiction, abuses, and then the problems associated with smoking and alcohol. The pornography, the online dating, this is what the World Sexual Health was focusing at because of this cyberbullying, utilizing of the pornography, which is creating a lot of problems in the relationships, dating, and using of the smartphones and all the other gadgets which are easily available. And these are the problems. See, you cannot prevent children from looking into porn nowadays because of the online classes. All the smartphones will be with the children. So they cannot even prevent them, that they cannot even monitor what they are watching, what they are not watching, which is also creating so much of problem in them. And the economic problems, you can see how they have lost jobs, and then what to do next is the biggest the problem because of the recession, no new jobs and laying down, and also reducing the salaries, which is creating so much of problems to so many people. So the various questions you can get into in this lockdown can be about the hygiene. So now everyone has by-hearted what to do, what hand washing, sanitization and all that, repeated washing. So how to maintain the hygiene? Is sex okay during lockdown? So if the sex is okay, only if there are no infections, they are not affected by this, and there is a good relationship, definitely it can improve the relationship, it can have positive benefits. But the sex should be avoided if there is an infection, lockdown, quarantine, depending on that. They also said that the virus can, now you can listen to Dr. Sanjay Deshpande's lecture, how the virus can affect the genital organs, how it can be there in the testes. So that is also there in the lockdown period. So lifestyle changes, they have to make some lifestyle changes, because sitting at home for a long period and binge eating and also spending time without any doing exercises, so that can lead to obesity and other health problems, is called COVID-19 and STD. Initially, when they said it is not an STD, but now with the lecture, you could listen to that. The virus can also be there. So it definitely it is found in the feces, and even after at the end of 1 month, it is found in feces. So it can be some other oral sex, anal sex can be dangerous. It can be transmitted. So that is one thing. Effect of sex on immunity as exercise, I told you. The contraindication for sex whenever there is an infection, or when they are in a high risk job, or when there is the quarantine period, that time it is better to avoid the physical contact and to know the benefits of sex. So the psychological aspects of lockdown are fear, anxiety, depression, crying spells, and disturbance in the mental disturbance because of so many tensions within the house and economic breakdown. So effect of social and economic aspects of lockdown and sexual functioning, definitely it can affect it and lead to various male sexual dysfunction and female sexual dysfunction. So how to enhance performance? So just by maintaining the good relationship and then healthy food, lifestyles, they can enhance the performance. If partner is in a high risk job, certainly that they have to, because depending on how much of a period they have to be in quarantine and other things. So they also have to take care, especially the high risk job people like doctors, nurses, police people and other people. So how they have to take the care and also take care of the families. The sexual perversions, there can be child sexual abuse, paraphilias and abuses can happen. Problems of staying together, too much togetherness, is it a problem? Definitely, because people are not used to staying together from morning till night, husband and wife. They also want their own space, a me time for that, because if there are too much of familiarity like that, it happens. Ultimately, that also can create problem between husband and wife, especially if there is some perversion, if there is alcoholic and drunkards and also abusive types of husbands. It creates more problem for the women. So privacy in so many places in homes, privacy can be a problem if it is a small house and not separate bedrooms. Now that they are all there at home, they have to have a place for grandparents, space for their husband, wife, space for children. So if the husband and wife are staying away, what are the sexual activities? Now the digital world has come into that. So they can have this the video calls and other, they can use the smartphones and their laptops and whatever it is. So they're at least exchange some pleasantries and the romance, online romance, whatever that is possible, that they can do. The sexuality of unmarried also, that because of the usage of pornography and other things, the masturbation, that also has increased. What sexual activities are safe? That so many times it has been stressed. Complications of irresponsible sex, like unwanted pregnancies, abortions, and then also sexual abuse, sexually transmitted infections. Effect on libido, erections, and ejaculation can be there. The stress itself, the disease itself, the lack of privacy, and the lack of a good relationship can have its effect on all these things. Types of abuse which can happen has already been told to you. The comment on use of condoms, sex toys, OCPs, morning after pills, they say that the sales have increased, and that because one factory of condom was closed and there was a short supply and people were not getting the condoms at the right time, there was also short supply and increase in the sales of sex toys and OCPs, morning after pills, and the role of Viagra, the sales have increased. And many people are using Viagra to improve their erectile dysfunction. Is there a sex boom or baby boom? It must be an experience of many gynecologists. So those who are on treatment for infertility, they have not been able to come to the doctor for so many months. And when they have come, the lockdown is open, they are already pregnant. So the relief of stress and then they being together, having more time to be with them, with husband, wife staying together, there can be a baby boom, there will be a sex boom. Using use of technology, use and misuse, that is the theme this year, how we can use it to the betterment of our purpose, or it can be misused by cyberbullying and online dating and misusing children, leading to child sex abuse. These are the comment on relationship, making or breaking So there can be making or breaking of the relationship. Is divorce on the rise during lockdown? Yes, they say it is, the incidence is more. And the sex in elderly, that is also an important thing, that because usually the sexuality of the youngsters is glorified, and the elderly, they also need their time, the space, love, affection, and their companionship. So that also has to be looked into when there are elderly people. So the male sexual dysfunction, especially ED, whether there is an increase in the all over the place, whether it is because of the disease itself, virus or endothelial dysfunction, that you heard from Dr. Sanjay Deshpande. So female sexual dysfunction, there can be lack of privacy, stress, overwork because of this office work, housework, and the children coming and playing, and the work for women also will increase with the lockdown, and the domestic violence increase. The contraception advice during lockdown is very important to prevent so many of the consequences of unwanted pregnancies and other things. And reproductive issues, as I told you, infertility, so many have positive effects, and usage of, because many could not come to the ART centers to have their pregnancies, those who were planned for that. Now, of course, people are doing this, all these test tube baby IVF procedures. So during pregnancy or abortion, how they have to reach the hospital, how they have to be in touch with the doctor, and the digital world has come into help so that they can reach the doctor and the doctors can be in touch with them. And sex and pregnancy, the various questions to be answered during pregnancy, whether they can have sexual relationship or whether they have to avoid it, also becomes important. And sexuality of the after 40, the space, relationship, intimacy. And the important thing about this diet and immunity boosters, and whatever they usually we use for traditional cooking with the spices and other things, they themselves are immunity boosters. And good home cooked food, a balanced diet will definitely improve physical, mental, and sexual health. And the exercise at home, because they are staying for more time, they should find time to exercise and improve their health. So ultimately, so what are the guidelines for happy married life during lockdown? Do the 5. These are very important that everyone knows. Good physical and mental health, hygiene, quality time, touch, talk, together, trust, temperament, love, romance. All these things, if you inculcate, a positive thing can be created to improve the quality of life of our people. Thank you very much. Stay safe, stay healthy. Thanks for the opportunity. Thanks for the patient listening.
Thank you, ma'am. A very pictorial presentation and very nice presentation, I must say. Now I request the chairperson to thank you, the speaker, and present the memento.
Yeah, thank you very much, Dr. Padmini Prasad, for a very elaborate lecture. Yeah, and even we are finding, I mean, not even the baby boom is there. Many MTPs have been coming, but there has also been a non-consummation of marriage because of severe lockdowns. And even after 2 years of marriage, we see couples not consummating marriage, and then they come for infertility workup and checkup in the recent months. Thank you very much for a very elaborate lecture. I request the organizers to felicitate her and give her a memento, digital memento. Hello.
Yes. Hello. Yeah, we are facing some technical difficulties here, ma'am.
Okay.
Because during the lecture, there has been too much lag and we have been facing some difficulties. Your lecture was uninterrupted, but there has been issues with connectivity with the laptop also. Just a second.
Yeah.
Thank you, Dr. Santosh Kartare, sir, and Dr. Abhijit Gandhi, sir, for chairing the session. I would like to felicitate them with the memento.
Yeah, that's your memento, madam.
Thank you very much for that.
And yeah, thank you for a very good, nice speech.
Thank you very much. I hope I was in time because I did not want to.
Yeah. Thank you so much.
Thank you very much.
Thank you all the chairperson and the coordinators. Next on, we will move on with the IMA lectures. So for the IMA session, I would like to call upon coordinators for the IMA lecture, that is Dr. Santosh Kartore sir and Dr. Sunil Narute sir.
Chairperson. Thank you, Revati madam. For the IMA lectures, as a chairperson, I will call upon Dr. Rajiv Rane sir, senior most pediatrician in Akluj, as a chairperson. I request today's chairperson for this lecture. Lecture's name is Know Your Council and speaker is Dr. Shiv Kumar Utture sir. I request Rajiv Rane sir to introduce Dr. Utture sir.
Dear friends, our next topic is to know our council. And the speaker is Dr. Shiv Kumar Utture. He is a member of, I will give his introduction in brief. He is a member of National Medical Commission, President of Maharashtra Medical Council, member of Medical Advisory Council. He is a general surgeon and laparoscopic surgeon practicing in Mumbai. He holds the following degrees: MS from Mumbai University, FICS from USA, FMAS. He was a professor of surgery in unit of head of unit at Grand Medical College, JJ Hospital. He is a fellow of International College of Surgeons. He is fellow of Minimum Access Surgeon. He is undergraduate and postgraduate teacher and examiner for MUHS. He has so many achievements. I can't cover all this. With this brief introduction, I request Dr. Shiv Kumar Utture to proceed for his talk.
Hello. I request Dr. Dilip Siddhapura sir, Dr. Satish Doshi sir, Dr. Vidyut Shah sir on the dais. There are 4 chairpersons for this whole session. Dr. Satish Doshi sir also. Dr. Utture sir, please.
Yeah, thank you, Santosh. Thank you, Chairperson, for the introduction. And I must thank Dr. Santosh, Madam Dr. Rane, and the whole team of IMA Akluj conference team, plus, of course, the IMA Maharashtra State team for having invited me today over here. So I think after having heard a beautiful session on different speakers on sexology, know your counsel would bring you back to the ground level. And in this short span which I've been given, I will try my best to let everybody know, because what you have been hearing today the whole day, you can get that information maybe from the other lectures, from YouTube, from the net, whatever. But what I'll be talking today, unfortunately, has never been taught to us in any of our formative days, nor we were taught when we were practicing. And suddenly, when there is some problem, we have to come in front of the council. And I hope to
try to bring to you different aspects of the council which you must know if you have to practice in the state of Maharashtra very comfortably. So basically, all of you must know this emblem. Unfortunately, now a huge majority of us, when we show them this emblem, they do not know this emblem. IMA has become so popular that everybody knows the emblem of IMA, but unfortunately, your council emblem in Maharashtra, you do not know. So better know this, because this is what is going to help you in the future also. And just a brief history, way back, the Bombay Medical Council was formed in 1912. And then, of course, I'm not going to go into the detail, where the council, way back in 1913, there were hardly 1,137 members. And today, if you see, we have got, now this is 2020 figure, we have got more than 1.5 lakh members who are registered with the council as of today. So now what are the powers which have been given to the council under an act of 1965? So if you see, these powers are basically to maintain a register of all the members who can legally practice in the state of Maharashtra. Let me tell you, I'm using very, very specific words, legally practice in the state of Maharashtra, because if you are not registered with the council, you cannot legally practice in the state of Maharashtra. This is an absolute statement which I am making over here, because I'm finding many a time doctors who have been brought in front of us by their patients on some complaints. The first complaint is that this person is not registered with the council. Unfortunately, what has been happening is, since the council has not been in the past working very actively, our members have not renewed the registration, which you are supposed to renew every 5 years. So I again tell all my members, all my colleagues, please see to it that your renewal is done every 5 years, so that you can practice safely in Maharashtra. Then, of course, the code of ethics, which is regulating the profession, and we hear cases, and after we hear cases, if we find that yes, something which has been done by that RMP, which is not as per what a doctor should be doing in his practice, then of course we reprimand that practitioner, and there are different levels at which this reprimand can take place. So as I've said, that we are the successors of the Bombay Medical Council right up to 1965, when the act was brought into place, and the rules in 1967. The details of all these act and rules are there in the Maharashtra Medical Council website also, and you will also find it on the website of the Maharashtra IMA state website also. So please go through all the details. Just to tell you how many members are there, total 18 members, of which 9 members are elected by every member or RMP who is registered with the council. 5 are nominated by the government. 1 comes from MUHS, 1 comes from CPS Mumbai, and that is because CPS was one of the first postgraduate institution way back. And then 2 ex officio members, that is the DHS, Director of Health Services, and the DMER, that is Director of Medical Education and Research. Then, as I said, that not only we do the primary registration, that is your MBBS registration, but we also do what is known as your additional qualification. So if you have got a qualification like MD, MS, MCH, DM, whatever it is, please see to it that you are registered with the council, because again, as I said, you will legally very soundly practice your profession if once you are registered, because when the council gives you registration, it gives you the legal status that you have got the qualification to practice in that field of medicine. These are the different things that the council does, right from provisional registration to up to registration, which are renewed every 5 years. We have change of name, additional qualification, permanent registration, good standing. All these things are the job that the council is doing as of today. Then what we have done is to help every member. In the last few years, since we have taken over the council, we have seen to it that we completely go digitalized. So almost 100% digitalization has taken place in the council, and that really helps our members whenever they are, whenever they want to go for any of their renewal or name change or whatever it is that they want to do from the council. So, and after having done that, to prove that the council, what it has done is right, we have also gone for certification, ISO certification, And today we are an ISO certified council, and this is one of the only councils in the whole of India which has got ISO certifications. Not only have we gone digital, but we have also started what is known as e-pay services with the State Bank of India. Now, what this has done basically is that at first we used to see a lot of line in the Maharashtra Medical Council office to make payments or whatever it is. Many a times, if there was the large sum involved, they had to go down and get a demand draft in the name of the council and do it. So we have started this e-payment. Today, you can make any of your payments for any reason for which you want, to have some certificate or renewal of certificate, whatever you want to do, or you want to do online CMEs, you can directly pay to the council without having to come to the council at all. So this has basically been a boon to all our members especially from the interior of Maharashtra, because now they do not have to travel all the way to Mumbai to get any of their certificates. Because if they come to Mumbai, you can understand the amount of money, time that they have to spend, and then even the patients suffer because for that couple of days, the doctor is not available in that small town or village. So all these things, we have delays and administrative blocks which were there experienced by the RMPs are a thing of the past now, because everything has been digitalized. As we see everything happening in India all over, digitalization is the word of the future. So in short, if you go on the website of web page of Maharashtra Medical Council, this is the page that you will see if you want to get any of these registrations. All you have to do is just click on one of these. It directly, the link takes you to that particular form. You fill up that form, you pay the money, and you send it to the council, and then the council will do its job of getting your certificate done. And this can be done by all 150,000 members who are registered as of now. And how we have achieved this? Because for this you require a big space. So the council has gone, and today we have got a cloud server of our own, so that we can have enough of space so that each member who logs onto the council does not find it difficult to go through all the different pages of the council. Not only that, the council has seen to it that every member has got his own individual web page. So this is just a sample of my web page which is there. And if you see over here, I think it's difficult for you to see on this slide, but name, the details, my address, where I have passed from, when I have passed, what are the degrees that I have got. All these details automatically, as soon as you fill your number or your name with your photograph, everything is there. So you can please go and see individual members who are registered with the council have got their individual pages. So we have got almost about 150,000 pages, which is there for individual members. And the next page after this will also tell you of how many credit points you have done, which is required for your renewal of registration. I'll come to that afterwards. So documentation of everything has been done digital, and we have received the ISO certificate. Not only that, what we have done is we used to find that after students, and I have done that in the past also, once I pass, I had to go for my temporary registration and my permanent registration all the way to the council office in Mumbai and stand in line over there and may fill the form and make the payments. What we have done is now to help all these students who are ultimately our children, we have empowered the deans of all medical colleges to collectively collect all the forms of all the students together, give the dean's endorsement on that form and send it to the council so that the students don't have to travel all the way to the MMC office. Even additional qualification certificates is very simple, and all you have to do is you have to log on and send your additional qualification. Remember, what you basically initially register with the council is with your MBBS certificate. So that is your basic registration. Any postgraduate degree you have done in which you are going to practice, see to it that this additional qualification is done. And the certificates that we give, we were finding in between that a lot of false certificates were roaming about, where we used to get a lot of complaints even from the police stations. So now what we have done, the certificates, if you see what we have given you today, they have got at least 6 different security features so that your certificate cannot be copied by someone. We used to find that people used to copy your certificate, put up their photograph over there, and use that certificate. And these quacks were practicing all over Maharashtra. So now it has become very easy for us and very easy for the police also to catch these quacks. So as per the Digital India Mission project, today we have also launched what is known as the MMC mobile, which is there on your mobile, just like everybody has now stopped using laptops and desktops because everything is available on the smartphone. So we have also done the same thing. We have launched the MMC mobile app for both Android users and for ISO users. And if you find it is very easy to get that because it is available on the Google Store and it is free of cost. Anybody can download that, and what it basically helps you is do the same thing that otherwise you would do on your laptop or on your desktop. Everything today you can do on your smartphone, like applying for your certificates, getting your renewals done. Everything has to be done from not only that, it is very easy to find the name of a doctor and his qualification on this app, and this empowers even the required registration, because it is so easy for him to catch these quacks by this just on their mobile phones. So basically all what I have said to you is everything is there in this slide. How to apply, everything is there. Then of course credit points, you can also see the credit points, as I said, on your individual web page, where all the details of the credit points which you have done in the last 5 years comes over there. And everything this is done free of cost for our registered medical practitioners by the council. And here if you see the renewal of registrations, we more than 1 lakh we have already done. Since it is every year renewal, that's why you will not find the 1,50,000 figure over here. Number of PGs, that is the additional qualification registration which we have done, is 62,000. And what we have done is the old records which were there in the physical format, today they are completely digitalized, and the council over the last 1 year has digitalized more than 19.5 lakh records over there. So today if the council wants to know all the details, or for that matter, if your some elderly person has lost his certificates, he can just inform the council and your digital certificate is there, maybe your degree certificate, maybe your internship completion certificate, whatever it is, everything is available at a click of a button in the council. So we have achieved this 100% digitalization as of 2020. And this is also going to help you tomorrow in renewal of registration from 2020 onwards. And if you see that the council has said that you require 30 credit points for you to renew after every 5 years. Now we have converted this CMEs into what is known as continuing professional development, because we believe it should not be just the theory that you should know, but even those who write books, those who give lectures in foreign countries, those who have in journals, they have got their papers which are presenting. Not only that, but even any education programs with the council feels that you are doing for the public, all this will be given credit points by the public. To give you an example, during this COVID phase, the council has already last year in 2021 has allotted 10 credit points for every member who has worked in these COVID hospitals or fever clinics or whatever. Automatically, once you get the certificate from that local authority, 10 credit points are given to you. And recently in the council meeting, it was passed that even for the year 21-22, this would be increased. So you will be having 20 credit points, which you can get if you have worked for this COVID during this phase. As far as the CMEs are concerned, this is just a slide to tell you how many organizers are accredited with us. And if you see over here, we have totally accredited 8,500 speakers which are accredited with Maharashtra Medical Council as of today. The next step was, of course, going digital online CMEs, and this the council has already done. So you can today sit anywhere in any part of the world, not only Maharashtra or India, and you can do these CMEs, online CMEs, and you can also get your credit points. So it becomes very easy. You don't have to travel physically to go and do CMEs, waste your time, your money and everything, and try to get these points. And this is the page that you can register for doing your online CMEs. This is not webinars. This is online CMEs which are already loaded onto the council website. So you register for the CMEs, and then if you see all these organizations are accredited. Unfortunately, I would like to say that IMA is not still accredited with us. I don't know why, even after being them, but you see, these are the organizations who are already accredited, and I hope sometime to see the emblem of IMA over here. And as soon as you have done this online CMEs, your certificate is also immediately you get it online, and at the same time even the council gets the certificate, so your credit point is automatically there in the council. So if you see, we have done a lot of changes even during this COVID period, so that it becomes easy for you. And this is what this slide is showing, that your credit points, 10 credit points plus 10, that means 20 credit points you can get if you have worked in any of the fever clinics, community clinics, Rakshak clinics, mobile clinics, or anything for that matter to do as far as treating patients of COVID is concerned. Then of course, what we have done is we have passed in the council this webinars also, which are there today, that you are seeing the webinar that has also been, I hope it has been accredited by the Maharashtra Medical Council. But webinars, because you cannot do physical CMEs today, that also gets accreditation and you can get your credit points. And this is the page that I was telling you, which every member has got. If you open your personal web page, where all your credit hours is automatically filled in, you do not have to do it in the future. It is filled in by the council and we have all the details. So tomorrow, when you go for renewal of registration, once you open that form and you fill up your number, that whole form will, because we have got digitalized, the home form will automatically fill up. All the columns will be filled up. You don't have to physically fill up any form. And if you have got all your credit points, that is the 30 credit points, all you have to do is upload your latest photograph and make the payment. So it is going to be hardly 2 or 3 minutes you will have to spend. If you know what has happened in the past, we had to upload every certificate. That used to take time and everything. But now that job has become very, very easy, because the council has gone in for 100% digitalization. Then let me come to an important aspect, or the second aspect that the council does, is the hearing. I'm going a little fast because of the paucity of time, so please excuse me. So basically, the code of ethics has been written down. Unfortunately, I believe more than 2/3 of our members have still not read what is the code of ethics. This is in black and white written, what you can do and what you cannot do when you are practicing, and what are the problems that you can face tomorrow if you're hauled up or the complaint is made by the patient with the council. So the code of ethics, if you see, is there both in the MCI code of ethics. Not only that, it is there even in the Maharashtra Medical Council. And of course, how the inquiries are conducted, you should all know. Remember, in the future, it is going to become a norm where patients complain against a doctor. So please be ready. Don't get scared. If you have not done anything wrong, if you have treated the patient properly, there's absolutely nothing to get scared. All you have to know is how the council hears all these cases, and you give your say, and nothing will happen to you as far as the council is concerned. So we have been given, and please go on to the rules and the Act, MMC Act also, and read these rules 62 to 65 of MMC rules 1967. You will come to know how the council hears these cases and what are the powers that the council has. There are huge powers that the council has, equivalent to what a civil court has. And when we say that, we have got the powers to call upon any governing body or any authorities which deals with the health of modern medicine in Maharashtra. We can call them to the council. We can send them a summons, and they are supposed, as per the courts, they are also supposed to follow these summons. So basically, what is the Code of Medical Ethics 2002 8.1? I'll only a few points I will enumerate over here. That if there is any professional misconduct which is done by you, it can be hauled up. But though before this is 8.1, there are 7 points or 7 paras before this which talks about what are the code of ethics that you are supposed to do. But beyond that also the powers are there with the state council and now with the National Medical Commission, because it says that instances and offenses of professional misconduct which are given above, that means 1 to 7, do not constitute and are not intended to constitute a complete list of the infamous acts. So the powers of the council are that we can go even beyond what is written down in the code of ethics. And if we find that something you have done which is not professionally misconduct, definitely we can hold an hearing. And you have to understand that this code is not to be violated, not only in the letter, but also in the spirit. And that is why there are no judges sitting in the council, though we have been given the powers of a civil court, but there are medical people, medical professionals who understand the do's and don'ts in medicine, who are there sitting over here hearing your cases. And if we find you guilty, basically what we do is, if the act that you have done is not of a repeat this act. But if we find that that act is gross, then of course, depending on how gross it is, either you can be suspended for a short period or you can be suspended permanently. Of course, permanent registration, I think I have been in the council for last more than 8 years. There have been hardly 2 or 3 cases, and all have been in those cases which are in the PCPNDT, that infamous cases of PCPNDT, which were there in the reported in the papers also, where we have suspended them permanently. So these are the basic powers that are given by to the council. And what can the council do? Council can enforce the attendance of any person and examining him on oath. Now let me just give you an example, short example of this. Many a times the patients come to us and tell us, we ask them, why do you feel your doctor who has treated you has done wrong? They say, no, after this I went to so and so doctor, and then the doctor said that what treatment you have got from that doctor before this is not proper, and because of that you have suffered, and therefore we have complaint against it, doctor. Remember one thing, this is called medical jousting. Please avoid that, because if what you have said is not right, the council has got a right to make you attend the council and examine you under oath if you have said this or not to the patient. And if you have said it, what was the criteria there for you to say such a thing? Then compelling the production of documents. So tomorrow you cannot say that, especially in a medical legal case, you cannot say that the documents are not available with me or the documents are with the hospital. We can compel not only the RMPs, but we can even compel the hospitals to give all these documents. Then of course, issuing of commissions for the examination of witnesses, where the witness cannot come to Mumbai in front of the council. We can always have a commission, just like a court, and then the examination of that witness can take place by any of the council members or someone who has been appointed by the council at their residence or whatever it is. And all these proceedings are judicial proceedings within the meaning of sections 193, 219, 288 of the Indian Penal Code. So this is the powers that the council has. So what happens when a complaint comes to you, to the council? If a patient complains against any doctor, of course, that complaint has to be very specific. Not only that, it has to be accompanied with a declaration. That means an oath that what I'm saying is to the best of my knowledge is right by the patient. Only then we entertain such complaints. It goes to the registrar. The registrar immediately sends this complaint to the concerned doctor. So if you receive a complaint from the MMC where the registrar has sent you, all that the council wants is your answer to that complaint. That is all. That does not mean that you are found guilty or the council feels you are guilty or anything. So see to it that you properly write down para-wise answer to whatever the complaint is. Many a times we find our doctors are so casual that they do not write to the council whatever they say is, or they write it very casually that whatever I have done has been is not negligent. That you cannot write. You'll have to give evidence. Then it comes in front of the president. The president puts it in front of the ethical committees which are there. We have 4 ethical committees which are formed. They examine the papers, and if required, they call the patients, that is the complainant and the doctor. And if we find that if this is called as a preliminary hearing, just like in a court of law, how they have a preliminary hearing to see if charge sheet has to be filed or not to be filed. Same way, this ethical committee will decide if a charge sheet has to be filed against you. And if we feel that yes, there is something wrong, then the charge sheet is filed, and then you have the regular process where you come, your witnesses come, your lawyers come, and then a regular hearing like how it happens in a court of law, we hold that over there. And here I will tell you what is, again, I would like to tell you the powers of the council. See, it is a council which gives you the license, and nobody else other than the council has got a right to take away your license. Why I am saying this is, it happened in this famous case where the High Court had suspended the license of the doctor, but then it was very well argued by the lawyer in the court, and that same judge referred the case to the council, saying that even the High Court does not have the right to suspend the doctor, and since the council is the one which gives you the registration, it was resent to the council to hear this and decide on that case. Why I am specifically telling you these cases, especially during in local areas, the local authorities, high-handedness of the local authorities, they catch our doctors and they tell them that if you don't do such a thing, or you don't follow what I tell you, I will suspend your license. Let me again reiterate, nobody has the right, even the High Court does not have a right to take away your license. So don't get bowed down or cowed down by what these people tell you. They do not have the right to touch your license, because the license is given to you by the council, and it is only the council, after proper hearings as per what is laid down in the act, only then the council can take action against you, not before that. Okay, so then as I said, that it goes to the ethical committees, and which we had almost more than 800 1500 cases before we took over the council. Therefore we have formed 4 ethical committees, and these ethical committees in the last 3 years have more than 800 cases they have heard. Now what is the importance of this? Let me tell you, because when there is a case against you in the council, you cannot get a no objection certificate, you cannot get a good a good standing certificate. If you want to go for any higher studies, or you want to go to present any papers, or go to do a fellowship, you require this good standing certificate and no objection certificate, which cannot be given. So I hope I have, it's a very short time, I understand this lecture, I think we can have for a whole day, talking about in details about individual powers and what the council does. But given the time factor, I have tried to hurry through that. So once more, thank you very much. And I hope some doubts which are there in the minds of all our members have been cleared today. Thank you very much.
Thank you, sir. Thank you, sir, for the talk. And I request Dr. Rajiv Rane, sir, to thank you, Uttare, sir, and felicitate him with e-memento.
Hello. Thanks, Dr. Shivakumar Uttare, for giving detailed information about the Medical Council of Maharashtra, the power of the function, structure, each and everything you have explained in such a good manner that every IMA members can member, and he will be benefited definitely in the future. Thank you.
Now I request Dr. Santosh Khattare, sir, to felicitate today's chairperson, Dr. Rajiv Rane, sir. And after that, thank you, sir. Hello. Yeah, now for the remaining lectures, I request Dr. Sunil Narute to coordinate the session.
Hello. Now I request Dr. Dilip Sudhapara sir to introduce Dr. Jayant Naurange sir.
Okay, hello, good evening. And first of all, I am thankful to Akluj IMA for giving me this credit to introduce Dr. Naurange Jayant for the topic of the landmark judgments for reshaping medical practice. Dr. Naurange Jayant is gold medalist for MBBS, DCH, MD, and also for LLB. He is honorary pediatrician
Srivastav, Srivatsa Sasun Chandra Hospitals, Bharatiya Samaj Seva Kendra, Dinanath Hospital, and Sahyadri Hospitals. He is past president of IMA Pune, IIP Pune, and IIP Maharashtra. He is vice president of Medico-Legal Cell, IMA headquarters. Helped 2,340 doctors so far, designated and conducted first medical legal course for IMA. He is visiting faculty of ILS Law College, Pune. He is competitive 26 marathons, half and full, and cycling. He donated blood 65 times. He is recipient of Bertha Holt International Award for rehabilitation of 10,000 family deprived children in last 40 years in USA 2002. Recipient of Best India Doctor Award by Indian Medical Association 2015. This award was installed in 2015 only. He is chairman of IMA MS Social Security Scheme from 2018 to 2023. Now I request Dr. Naurange to conduct the session. Thank you.
Thank you, sir. Good evening, everyone. Right at the outset, I would thank IMA Akluj branch, IMA AMSCON organizers for giving me this opportunity to talk to you and have a dialogue to you. And I'm lucky that I am present over here. Thanks to Dr. Marathi, who has accompanied and escorted me. And where is Dr. Khartare? He is the Dr. Khartare and Dr. Revati. So they are the people who are very close to me. I know them very well and for years together, and I cannot deny their invitation in the least. How can I see my slides? Can I have them? Today we will be talking about then covering this huge topic, as what Dr. Uttarev has said, I am really sandwiched between two great stalwarts, Dr. Uttare on one side and Dr. Vyas Deshpande on the other side. And then there is a very attractive and very, very nice speaker, Dr. Jubani. So I won't be taking more time than what is allotted to me. Coming to this point, that what are the landmark judgments? And when I talk about landmark judgments, sir, these are the ones which cannot be changed unless the law is changed by Lok Sabha and Rajya Sabha, because these are uttered, pronounced by the Supreme Court. So they are the law of the land. So we have to be very careful about what the judiciary is thinking at that level. And these are the judgments which are selected and comparatively recent ones, but some of them can be very old ones also, because landmark judgments are there to stay for years together. In the beginning, we would just differentiate between the two sides. One is criminal negligence and what is meant by civil negligence. So just to give you the glimpse, everybody is afraid of the police action, everybody is afraid of the arrest, and everybody is afraid of the criminal law. So to differentiate between the two and to understand this particular point is very important. Whenever the criminal machinery comes into action against anybody, not only medical practitioners, we feel that we have not done anything wrong. We have not done anything criminal with an intention. But then, with an intention. But when it comes to medical personnel, it is not the wrong intention which is punishable. Nobody wants the person, your patient, to be harmed. Nobody wants your patient to be killed by you. That is certain. But then it is the reasonable foreseeability that this particular surgery or this particular procedure Okay. this particular case I am tackling is likely to result in terrible bad end result which is not intended, but then if you don't take the care, this will certainly happen. So we have to prove that we have taken care. That is what is reasonable foreseeability. So without intention also, otherwise criminal law always says that there has to be a malintention. So even without intention, the criminal procedure comes into action in medical persons. Police is a necessary party, but not necessarily so, because there can be a private party. And on the civil side, it is between private party and other private party, or it could be government party also. But more important than that, criminal cases cannot be covered by insurance. So all of us take the indemnity insurance, we take the hospital indemnity insurance also, but insurance coverage is only for the civil side, which includes the Consumer Act also. There is no period of limitation for the criminal side, because once a crime, always a crime. Whereas period of limitation is 2 years for consumer cases, but 3 years for civil cases. But when we say of limitation period, this limitation period is what is, I will come to that in a judgment. So it is the discovery rule. That means whenever the patient has discovered that doctor's wrong action has led to this particular wrong result, they can file a case. Of course, that condonation of delay of 2 or 3 years is the judge's prerogative, but there is no such limitation in the criminal side. The aim of criminal action is deterrent. That means the person should not do it again. Neither anybody from that profession would venture into doing such mistake again. Whereas the aim of civil side, including the consumer, whenever I say civil, it is including, it is a part of consumer. I mean, other way around, consumer is a special law of civil side. So compensation is the aim. Paise mala milale pahiye. Establishes the wrongdoer, whereas here it establishes the rights. This is very important. 6th point, section 304A2 of Indian Penal Code. Table death झालं, काहीतरी wrong action झाली, gross चुकीचं amputation झालं, whatever. All these lead to a section application, section 304A2. That means rash and negligent act, killing a person, but not a murder. That is 304A2. Whereas police officers intentionally put 304. या दोनात फरक लक्षात घेण्यासारखा आहे. 304A2 means you have the right to bail. थोडक्यात म्हणजे पोलीस येतानाच ते म्हणतात की तुम्हाला बेल आम्ही देतो, तुम्हाला अटक करून घ्यायची का बेल वरती सोडायचंय. कोणी म्हणणार मला बेल पाहिजे. Whereas 304 is non-bailable. So he goes into the jail, and we have several experiences, including in Pune, that we had to intervene, go up to Commissioner of Police, threaten them that if you do not apply the proper rule, people have been in the jail for 3 days, 4 days, that we will take action against the police officers. Then they get released, change the law to change the application of section to 304A. So this you must know by heart. Strictest proof is required for the criminal side, whereas it is not so for the civil side, because civil side is probability of that particular negligence is enough to prove. Now coming to the consumer law, there is a completely new law. I would say it is not just amendment, it is a completely new law formulated in 2019, just 1.5 years back. And there is one major difference, two major differences. One, that all cases where the bills of the doctor are less than 1 crore have to be filed in the district forum. So whatever happens is Akluj will have to be filed in Solapur district forum. Previously it was more than 1 crore, you have to go to National Forum in Delhi. Now they have changed that whenever so whatever compensation was asked, now it is depending on the amount of bill charged by the patient and hospital, by the doctor and the hospital. So if the bill is less than 1 crore, and usually they will be less than 1 crore, the case will be naturally fought in the district level, which is a relief to us. However, there is a misconception whether doctors are included in Consumer Act in the new act. Answer is 1000% yes. Doctor is very much included. Please don't be under the wrong impression. I know what certain IMA officials are also under misconception, and they are fighting in the courts also. But as of today, doctors, profession, hospital, nurses, everything is under Consumer Act. So don't be under the wrong impression that it is not applicable to you. Number 3, one more change, that out of the 3 people on the bench, there used to be 1 judge compulsorily. Now it is not required. And that is a horrible thing. That is a horrible thing. The president of the forum, now it is called commission, पण नाव बदललं म्हणून काही फरक पडत नाही, ते तसंच आहे. So that particular commission, the presiding officer used to be a retired judge. Now it is not required. Anybody can be a judge, and this is most dangerous. I can just mention here. So these three are important differences in the old law and new law, but don't be under a wrong impression that it is not applicable to the doctors. I think IMC and MMC and now NMC Act is adequately covered by Dr. Uttre. And we come to, instead of going through various acts, PCPNDT, MTP, and POXO Act. Are you aware about POXO Act? POXO is Prevention of Child Sexual Abuse. Now, this particular law, the first case has unfortunately occurred from your nearby area in Maharashtra. Unfortunately, it was wrongly applied to one of the senior pediatricians in your neighboring town. So I won't take the name, he's my very close colleague, and he was in jail for 7 days, and we had to intervene to relieve him. So we are very proud that we could help him. So anyway, these are the laws, what are called as procedural laws, where you have to follow the laws by strictly by words. त्याच्या आशयाला महत्व नाही, त्याच्या शब्दांना महत्व आहे. So MTP, PCPNDT, tuberculomy, and POXO Act usually related to gynecologists. These are, समजा 9-10 वर्षाची मुलगा माझ्याकडे आला, मुलगी आली, जेनिटल वरती काहीतरी इंजुरी आहे, वी हॅव टू सस्पेक्ट, आपल्या मनात सुद्धा येत नाही, recurrent urinary infection, suspect it could be a child sexual abuse, and you have to inform the police. Not informing the police and information of police काय करायचंय, प्लीज लक्षात घ्या, हा ऍक्ट बऱ्याचशा पोलीस लोकांना माहित नाही. You have to just inform on telephone. You are not to send that child, not to send that family. Not, you are not supposed to send your servants की जाऊन तिथे नोंदवून या. It is just a telephonic information. Write down at this and this time the act has, I have informed the police. परंतु आजकाल पोलीस ऑफिसर ते लिहून पण घेत नाही. मग काय करायचं? ईमेल, आणि प्रत्येक डिस्ट्रिक्टचा कमिशनर ऑफ पोलीसचा ईमेल आयडी दिलेला आहे. You have to you just send an email intimation ki I am suspecting this particular child sexual abuse, please take a note. काही डोक्याला तक्त करून घेऊ नका, your work is done. So we will rush to some of the important, whether SHOP Act is applicable to the individual clinic. It is applicable wherever the number of employees is more than 10. That is in short the rule. More than 10 employees, SHOP Act is applicable. Less than 10, there is a facility called as facilitator appointed by government. To him only we have to send the information on email. Otherwise, and the government has not appointed this facilitator, so you are not to register. But beyond 10, you have to register, whether it is a clinic, diagnostic center, or hospital. The anti-cut law has not come. Bond completion मध्ये काय आहे की those who have passed up to 2010 for renewal of registration, MMC is now demanding, in my opinion, illegally, that bond completion certificate. Supreme Court in 2018 त्यांच्या मनात काय चाललंय हे सांगण्यासाठी ही केस देतोय. It reminds us of the ethics, what Dr. Uttre was referring to as section rule number 65 to 75. That is the rules of ethics. And here it says, Supreme Court, it has reminded the doctors that follow your ethics. In a writ petition by Delhi government versus Delhi High Court, Delhi High Court ने निर्णय दिला होता की तुम्ही तुमचे चार्जेस ठरवू शकता. Whereas the government of Delhi had said that we are capping the charges. I am coming to that case again later on. But at that time, the fine was imposed की trust hospital ने concession दिलं नाही, 10% charity केली नाही, 20% लोकांना काय ते half concession दिलं नाही. In that case, the government went into the court against the High Court decision. And that was शब्द लक्षात घ्या, माझा इथला एकही शब्द नाहीये. The doctor cannot refuse the treatment to the poor in dire need of any medicine, modality of treatment, or any expert. There has to be balancing between human rights and commercial gains. Constitutional obligations to treat the poor by any hospital or doctor are there. Dark side of such hospitals can be eliminated only by sharing obligation towards the economically weaker section. So Delhi government directives were upheld. Hey, this is not very old, 2018, so that prevails. What is new is Karnataka's CEA Act, which is temporarily gone in suspension because the doctors successfully agitated for 4 consecutive days. आमरण उपोषण त्यांनी केलं बेंगलोर मध्ये, आणि त्याच्यामुळे हा तिथे कायदा तात्पुरता सस्पेंड झाला. त्याच्यात काय म्हटलं होतं लक्षात घ्या, कंपल्सरी फ्री सर्व्हिस इफ द डेथ ऑकर्स. हॉस्पिटल बिलच घ्यायचं नाही. फी किती घ्यायची? 150 rupees फॉर फर्स्ट कन्सल्टेशन, 100 rupees for second consultation, and then only 50 rupees per subsequent consultation. Government to pay for the first 2 days in the case of road traffic accident. This capping, however, is now brought by backdoors by our government, saying that capping of treatment in COVID. They tried to cap other services also. And this has been categorically denied by Supreme Court, that Dr. Pradeep Arora's case in Nagpur, which was ultimately upheld in Supreme Court, I think on 30th of August this year, that the government cannot put capping of charges on the hospital bills except in pandemic situations. So only for COVID it is applicable, not for other cases. So this is the complete story about the capping of charges. This is one more judgment which I would bring your attention to this particular slide. If you don't have an ICU, no surgery should be done. They have not put it in these words, but the meaning is this. This is in the year Supreme Court gave this judgment in September 2017 in West Bengal case of 1993. लक्षात घ्या, 1993 ची केस आहे. Hysterectomy was done. Patient didn't come out of general anesthesia, so the needed ICU shifted to another ICU center. They were not happy over there. Within 5 hours, the patient went to another hospital. They proved that the doctors were not negligent. They proved. High Court, Supreme Court, everybody agreed the doctors are not negligent, hospital is not negligent. But just to meet the two ends of so-called justice, they said the doctors are not negligent, but 5 lakhs are awarded. घेऊन टाका, अंदन दिले, तुळशी हलवायच्या घरावर तुळशीपत्र. 5 lakhs are awarded. ICU was not within the hospital where the surgery was performed. So how many hospitals, this is my open question, in 1993, how many hospitals had ICU? Was the concept of surgical ICU there? Was the concept of gynec ICU there? And that time the case has occurred. They are giving the judgment sitting in an ivory tower in 2017. Sorry, I'm critical of Supreme Court, but this is what happens. 2017 साली ते निर्णय देतात. 93 सालची केस 24 वर्षामध्ये गेलेली आहे. त्यावेळी आयसीयू कन्सेप्ट सुद्धा नवीन होती, परंतु शेवटी तो जो असतो ना त्याच्या विरुद्ध निकाल लागतो. नाउ ही हॅज नथिंग लेफ्ट. इट्स अल्टिमेट डिसिजन. सुप्रीम कोर्ट 5 लाख देऊन टाका, आहेत ना तुमच्याकडे पैसे. सो थोडक्यात आपापसात मिटवलेलं बरं. थोडक्यात आपापसात मिटवलेलं बरं. सो दिस इज व्हॉट इज देअर इन द माइंड ऑफ द ज्युडिशरी. Now another point we have to learn, be generous about investigations. Be generous. आपण जे काही बीजे मेडिकलला शिकलो, मी तर 72 साली शिकलोय, की कमीत कमी पैशात जास्तीत जास्त करेक्ट डायग्नोसिस, उत्तमातलं उत्तम रोग निदान आणि बेस्ट पॉसिबल ट्रीटमेंट, याला आता महत्व नाही. You come to a working diagnosis, try to prove it with the investigations. Why you are not doing the investigations in time? Why are you looking at a patient's pocket? These are the questions asked by judiciary. आता ही केस बघा, backache lasting for more than 1 month. Sir, आपल्याला बदलायला पाहिजे. I am also 72. A radiological examination could have been done if the patient did not get relief in a month's time. The forum concluded an MRI test was required. Therefore, the doctor has committed medical negligence. 5 लाख. आणि 5 लाखात सुटला म्हणजे नशीब म्हणायचं. So don't go strictly by clinical. You have to have that acumen to order a particular investigation. But थोडं liberal राहा. पेशंटच्या पॉकेटचा विचार करू नका. दिवस बदलले, we have to change. Now this is the landmark judgment which came unfortunately from Pune, and this is the famous Pune Joshi Hospital, Maharashtra Medical Foundation Joshi Hospital, and he is my classmate's father, Dr. LB Joshi versus Trambak Bapu Godbole. Both are not surviving. And त्याच्यामध्ये असं दिलेलं आहे की what is meant by medical negligence, and this is this case is quoted in every case of medical negligence. Every case, part district forum पासून सुप्रीम कोर्ट, प्रत्येक केस मध्ये हे रेफरन्स असणारच. इतकं ते महत्वाचं आहे. डॉक्टरच्या 3 ड्युटीज आहेत. एक म्हणजे whether you will like to undertake the treatment of this case, म्हणजे थोडक्यात you can refuse a patient. You can refuse a patient, but not in an emergency. You have to choose the patient. Then if once you decide you are going to take the treatment of this person, then decide of the line of treatment into bracket after diagnosis. After diagnosis शब्द माझे आहेत, कारण आपल्याला ॲलोपॅथिक लोकांना ट्रीटमेंट देताच येत नाही unless you come to a diagnosis. And to implement the decided treatment. तिसरा पार्ट आहे implement the decided treatment. म्हणजे थोडक्यात म्हणजे मी हॉस्पिटलमध्ये काम करतो, माझं 100 बेडचं हॉस्पिटल आहे, म्हणतो राणे मॅडमचं 100 बेडचं हॉस्पिटल आहे. त्या ठिकाणी आय हॅव टू डिपेंड ऑन माय स्टाफ, आय हॅव टू डिपेंड ऑन नर्सेस, आयाज, असिस्टंट्स, लोकम्स एक्सेट्रा. त्यांची जर काही चूक झाली तर ती पण माझी चूक धरली जाते. दॅट इज व्हॉट इज कॉल्ड एज विकरियस लायबिलिटी. अनेक केसेस आहेत याच्यावरती. तेव्हा डिसाइड इफ यू वॉन्ट्स टू अंडरटेक द ट्रीटमेंट. एकदा तुम्ही आत घेतला त्याला, मग तुमची कमिटमेंट त्या आजारापुरती आली. नंबर 2, डिसाइड द लाईन ऑफ ट्रीटमेंट. And number 3, implement the decided treatment. Anyone ready to give the treatment is supposed to have, this is important, necessary skill. म्हणजे त्याच्याकडे योग्य ती डिग्री पाहिजे. Knowledge, that means he has to be registered with the medical council and renewed it. Third is qualification, मी बोललो, and follow the volumes. And this is a very important slide. If my time is short, I can stop after this slide. If the time is short, otherwise I can continue. Now this Bohlam's principle is to be well understood. What is this Bohlam's principle? The cases we are talking about, judiciary, law and all those, they are nothing else but a comparison of what management you are given to that particular disease in that particular case and what others would have given in that community at that time. Community means doctor community. थोडक्यात म्हणजे तुम्ही जे केलंय ते इतर डॉक्टरांनी तसंच केलं असतं का, आणि तुम्ही जे करायचं टाळलंय किंवा अवॉइड केलंय ते इतरांनी पण टाळलं असतं का, ही कंपॅरिझन होते. This is a test of comparison. So this is Bohlam's principle, uttered in 1957 in UK, and it is based on the comparison of actions and inactions of a doctor with that of average prudent doctor in that area in that era. म्हणजे आज 2021 ची ट्रीटमेंट मी 1990 साली नाही म्हणू शकत की दॅट इज, म्हणजे म्हणून मी म्हणतो 1993 ची ती केस होती, हिस्टेरेक्टॉमी ICU. तुम्ही 17 साली निर्णय त्याचे निकष लावू शकत नाही, पण त्यांनी लावले. But this is what is Bohlam's principle. So this is followed by Indian courts and all across the world, that whether you were wrong or not is decided. Judges are not doctors. आणि जजेस डॉक्टर्स असावेत असं म्हणू नका. जिथे कुठे त्या फोरम वरती डॉक्टर्स झाले तिथे घोटाळा झालेला आहे, तेव्हा डॉक्टर्स नाही हेच बरोबर आहे. तेव्हा जजेस शुड नॉट बी डॉक्टर्स. डोंट से की मला डॉक्टर तिथे पाहिजे तर फोरमवर. इट इज रॉंग कन्सेप्ट. इट हॅज टू बी ज्युडिशियरी ओनली. आणि त्या ठिकाणी प्रूव्ह काय करायला लागतं की मी जे ट्रीटमेंट दिली ते सर्वसाधारणपणे 4 चौघ देतील त्या पद्धतीची आहे. त्याच्या मला टेक्स्टबुक मध्ये रेफरन्सेस आहेत. सो आय कॅन प्रूव्ह दॅट आय हॅव डन व्हॉट एव्हर इज रिक्वायर्ड टू बी डन. दॅट इज व्हॉट इज एक्सपेक्टेड. Whereas we go to the last line, Bolito principle. What does it say? आता बघा, Bohlam's principle म्हणजे they were depending upon the expert opinions of the doctors. The things have changed from 1997, and it says the decision of negligence or non-negligence has to be taken after reading the medical expert opinion and check it that it is logical opinion. Check that this opinion is a logical opinion. थोडक्यात म्हणजे ज्युडिशरी ठरवणार की हे तुमचं एक्सपर्ट ओपिनियन तरी खरं आहे का, आणि हे जास्तीत जास्त आता फॉलो होत आहे. सो दिस चेंज luckily has not much occurred in India, but it is on the cards, and our courts have started using this principle. Ki they will not go only by textbook references and expert opinions, but also by, they will arrive at their own conclusion whether the opinion given was a logical opinion. And the next point is in between, Montgomery's case. ती येलो मध्ये दिलंय बघा की आतापर्यंत हे सगळं आपण मॅनेजमेंट बद्दल चाललं होतं. व्हॉट, हाऊ यू वुड ट्रीट दिस केस. नाउ इट हॅज कम टू the law. See, this is much more encompassing. This came in 2014. माझ्या वाचनामध्ये ते नुकतंच आलं, परंतु 2016 पासून आपल्याकडे इंग्लंडमध्ये इम्प्लिमेंट झालं आणि आपण इंग्लंडला फॉलो करतो. Now it is getting applied right from the point of diagnosis, investigations, choice of drugs, treatment selection, implementation, facilities in the hospital. And the law on the consent has progressed from doctor focused to patient focused, and the practice of medicine has moved significantly away from the idea of paternalistic approach. म्हणजे काय, पूर्वीचे डॉक्टर आम्ही ऐकलेलं आहे, डॉक्टरला कळतं का तुला कळतं, म्हणजे त्यांनी काही बोलायचं नाही, पेशंटनी मुकाटपणे सगळं मान्य करायचं. दो डेज आर गॉन. It is the patient who decides about his own body. He will give you treatment. You charge for his consultation, and the doctor will guide. In my opinion, this is the best one. पण त्यांनी समजा लाईफ सेव्हिंग ट्रीटमेंट आहे, पण ही सेज नाही मला नाहीच करायची. यू कॅनॉट फोर्स. परस्युएड करा. काउन्सिलिंग हा आता परवलीचा शब्द आहे. Who tells the patient that what to do? So patient tells what to do, even if this was thought to be in the patient's best interest. The patient is autonomous, आणि हा शब्द MMC's आहे. हा शब्द NMC's आहे. Autonomous. So patient's choice is the ultimate. So a patient is autonomous and should be supported to make the decisions about their own health and to take ownership of the fact that sometimes success is uncertain and complications can occur despite the best treatment. थोडक्यात म्हणजे बोलाम्सवरनं बोलिथोवरनं मॉन्टगोमरी म्हणजे आपल्याला कंप्लीट बदलायला पाहिजे हे सांगायचा उद्देश. किती 5 मिनिटं टाइम इज अप. ओके. So no 100% guarantee is possible. So don't give guarantees and warranties. आणि VP शांताची केस मी बोललो. अश्विन पटेल म्हणजे क्रॉस पॅथीची केस आहे की त्याच्यामध्ये होमिओपॅथ कॅनॉट गिव्ह ॲलोपॅथी कॅनॉट गिव्ह होमिओपॅथी. ही कॅनॉट प्रिस्क्राइब LIV52. वी कॅनॉट राइट आयुर्वेदिक एक्सेट्रा. दॅट लॉ स्टील रिमेन्स दो NMC इज इन फेवर ऑफ क्रॉसपॅथी. मार्टिन डिसूजा ही केस खूप महत्वाची आहे आणि त्याला तुम्हाला ही टेबलावर तुमच्या लॅपटॉपवर पाहिजे की जेव्हा केव्हा पोलीस तुम्हाला अटक करायला येतील तेव्हा त्यांना हे दाखवायला लागतं की ह्या केस प्रमाणे तुम्ही माझ्या विरुद्ध ऍक्शन घेऊ शकत नाही unless there is an expert opinion. So this particular case, I would say that should be on the laptop of each and every person. Vicarious liability I already mentioned. Whatever is done by your staff, etc., is your, and this is another judgment that it has to be on your laptop. So I can arrange to send these judgments to the president and secretaries and keep them on your laptop, ready referred as a ready reference for your use anytime in future. Because once you throw these judgments, I will underline them also. Usually no action is taken. Thank you very much. I'm sorry if I exceeded my time.
No, actually we would have also liked to listen. There is so
Thank you so
much to share, but yeah. So I request Dr. Siddhapura sir to thank you, Naurange sir. Yeah.
Thank you very much, Dr. Naurange sir, for giving very informative lecture, which could have been extended, but because short of time, we have cut down.
Yes,
Thank you very much once again. And we would like to listen his lectures always.
Yes, sir. And he is physically present, so there is no need of e-memento. And I request Dr. Narute to felicitate our chairperson, Dr. Siddhapura sir. After this, I request Dr. Narute to coordinate the next session. Next speaker is Dr. Y.S. Deshpande sir.
I request Dr. Satish Doshi sir to introduce Dr. Y.S. Deshpande sir for next lecture.
Now we'll move to the next session. Dr. Y. Deshpande. He is eminent surgeon from Nagpur. He at present is a partner Viva, Central Working Committee member, IMA headquarter, Vice President, Vidarbha Sanshothan Mandal, Executive member of the Swami Vivekanand Medical Mission. He is Joint Secretary and he is Honorary Professor of Surgery, ABH and MC Nagpur. He is past President of IMA Maharashtra State, Director KNE Shinna Institute, Ambassador against Sex Selection, IMA headquarter New Delhi. He is past President Indian Medical Association Nagpur. He is past President Rotary Association of Surgeon and Indian Nagpur. Executive member of ASI Maharashtra State. He is the chairman, past chairman of Scientific Committee, AMSCON. He has awarded National Award as the best state president during National Conference at Bengaluru. He has invited by NOGS Critical Care Society IMA headquarters, Association Maharashtra State as a guest speakers. He is also communication skill to prevent assault and avoid litigation in medical practice at AMSCON State Conference at Pune. He has conducted number of organizations as a master of ceremony. He has good contribution in local articles in his subjects. He has visited number of countries just such as USA, China, Malaysia, Bangkok, UAE, and Nagpur. And he has organized various medical and surgical camps. Now, sir, the ball is in your court. Now start your speak. Thank you very much.
If you want to hold and see.
Thank you so much for the wonderful introduction. I was thinking whether it is me or somebody else. Can you see my slides and can you hear me? Can you hear
Sir,
me?
we can hear you. Actually, there is problem in the connection. I think in the delegate link, you must be visible. I'll just check.
And is my screen available, visible?
Sir, are you? Yes, yes. Yes, sir.
Okay.
You can start the lecture.
Yeah. So at the outset, I thank Dr. Santosh, my friend, and Madam Rane from Akluj. I had been to Akluj several times and I would have loved to come to Akluj to attend it actually. But because of some problems, I couldn't attend that, and I envy Dr. Naurange for attending the conference actually. Doesn't matter. I am attending it virtually, and yeah, I am a Maharashtra president, Dr. Ramkrishna Londe, Secretary Dr. Pankaj, and Chairperson of AMS Dr. Rajiv Agrawal, and Chairperson of this session Dr. Dilip, Dr. Satish, and Dr. Rajiv. After sexual medicine, which is always entertaining, interesting, and curiosity based, it is difficult to listen to the practical topics, which are extremely vital for each and everyone. Maybe those who are in private practice, in colleges, or in health services, it is very important. I am honored to share dais with Dr. Shivkumar, Dr. Naurange sir, who are close friends of mine. And at the end of our session, again it will be Dr. Jumani, who would speak on novel management of ED, and that would be a last nail on the coffin. So with this introduction, I start this thing. Though the time allotted is very short, the topic is very interesting and very large. But still, as Santosh, I have promised Santosh, I would finish it in 15 minutes, whatever time is allotted, maybe even less than that. So to start with, there is a law against assault on doctors, Prevention of Violence and Damage of the Property Act 2010. And I would quickly go through it, that whereas acts of violence of causing injury or to the life of medical service persons and damage to the loss of property of Medicare services, they were increased in the state and creating a lot of problems to the medical personnel. And to tell you, with all our efforts of IMA, we thought that the problem is getting over. But every day we are facing some or other problem, and we feel that the problem is continued. And hence we need to work on it very actively. Any offender, though the people know that any offender who commits or attempts to commit violence in contravention of provision of the section is fined with rupees 50,000, and any offense committed under this act shall be cognizable, non-cognizable, non-bailable. And in addition to that, the punishment specified in section offender shall be liable to pay the compensation twice the amount of damage or loss caused to the property. But in spite of that, the problems continue, and that is the reason why we need to address this issue very seriously. There was a Supreme Court verdict also that what Supreme Court has said, that we direct that whenever there is a complaint against a doctor or hospital by the consumer forum, whom then before issuing the notice to the hospital against whom the complaint was made, it should be first referred to, matter should be referred to the competent doctor to decide as to whether really the doctor was negligent. This was a verdict of Supreme Court. But in spite of that, the we think that all this law and everything would be deterrent for those hooligans and those who would create a problem. Now see the next slide, that there is always a law. Now look at this slide, that law is no spitting and fine up to ₹50. But see the condition of the board there. So it is always a mentality of an individual that law is not for me, but for others to follow. Law is only not sufficient. As I said in the beginning, police, media, social activists, everyone is important. And I would also say that doctors also need to introspect and find out solutions to prevent the attacks. And all of us, like police, media, social activists and doctors, we need to work comprehensively to solve the problems. Now we have to analyze the reasons for the assault. What society feels, that doctors are minting money. They exploit patients. Patients' relatives are agitated due to arrogant behavior of the hospital and clinic staff. Let me tell you, in our absence, how staff behaves with the relatives, that is also very important. Unreasonable charges being levied for the treatment, and unfortunately, which is a reality at many places, it is due to the kickbacks and false claims made by the doctors. Doctors, they don't want to leave the patient. Whether the facilities are available or not, they would not leave the patient and would try to treat each and every patient in their own nursing homes. And false claims are made by doctors that, well, your patient will be all right and all that. And that creates a problem. And of course, improper communication, particularly during the medical accidents, unnecessary admissions and operations for the want of money. That is a hard fact which is there. Facilities like MRI, CT scan, X-rays, they are declared to be out of order to refer the patient to the private hospital. Particularly this happens in government setup. Person attached to government hospital and also private nursing home, patients are diverted to his own nursing home. In ICU, patients are kept on ventilator for more time to enhance the bill. This is what society feels. But society needs to know that patients and relatives should understand that this profession is here, we are service provider, but at the same time, our aim is to earn also. Because we are private practitioners and we are not getting anything from the government. Doctors were never gods and never will be. Relatives of the patients have started demanding tests without willing to pay the cost. It is jokingly said that doctor is God before the treatment. During the treatment, he is insan, and when the bill is being paid, then he becomes a shaitan. So that society needs to understand that. Patients and company have started demanding better medical services. Medical profession is full of intricacies and uncertainties. We need to understand that. And that's why we say that we guarantee the efforts and not the outcome. Like any other profession, there are black sheeps that also cannot be denied. But at the same time, doctors are human beings. They also need to look after their family. So when should you sense trouble? When relatives ask for case papers. When patients' relatives suggest for the second opinion. Repeated inquiries from the mediator doctors. When they doubt necessity of the investigations. If you advise particular investigation, they would ask whether that is really necessary. Because what is there in their mind is that you are benefited by advising that investigation. So doctors, please ask yourself, are we reasonable while charging the patient? You put yourself in the place of patients and then analyze that, whatever you are charging, whether it is reasonable. Do we keep the transparency? Do we communicate with the relatives? Are we neglecting the patient during our course of treatment? Do we monitor the patient when he complains of the same trouble repeatedly? And whether the hospital staff behave cordially and sympathetically with the patients in your absence? How to avoid trouble? Doctors need to be ethical and must not fall prey to the commercialization. Doctors need to bridge the communication gap between themselves and the relatives. If doctor is extremely busy, perhaps he can keep the public relation officer or that kind of a person who would perhaps communicate with the relatives. Doctor should not unnecessarily stick to the case for the sake of money. Do not admit serious patients if you don't have the critical care facilities. So this we are facing a lot of time that we operate without anticipating the problems, and then the patients are to be referred to the critical care unit, and then patients' relatives are reluctant to take the patient. Patient's condition is becoming serious, and then we face problems. We need to keep proper record and details about the case, as rightly said by Dr. Naurange and Dr. Utture, that record keeping is extremely important. What ultimately speaks in the court is our record. Give full idea of charges patient is likely to incur during the course of treatment and charges to be levied. While shifting the patient to the better care, give proper summary of the patient. Otherwise, you know what happens, there is a lot of a communication gap, somebody makes a loose comment, and then we have to face the problems. Return the remaining medicines and material to the relatives while shifting the patient. Do not insist for hospital bill at the time of giving death certificate. Following unexpected death of young patient and the breadwinner of the family. Suggestion box should be kept in the hospital or clinic, and cognizance should be taken immediately. We forget this, because of our busy schedule, but this is very important. Inform police in medical legal case and when you sense the trouble from the relatives. Inform your friends of Rapid Action Force of IMA. See, IMA is doing extremely wonderful job as a Rapid Action Force, and during my presidentship as a president of IMA Maharashtra state, we had been to several places when our colleagues faced the problem. I remember distinctly we had even gone to a peripheral place like Kopargaon during my presidentship when there was a problem there. So emergency alert on WhatsApp of Rapid Action Force. Inform your colleagues from nearby locality to rush at the site to give support, not to quarrel with the relatives, but to pacify the relatives. Need to inform Rapid Action Force in the nearby in your IMA and the other hospitals. The Rapid Action Force should comprise of security, police, doctors, social activists, members of hospital advisory committee. Inform colleagues and co-residents as soon as you sense the trouble. Particularly, I would talk about the Dhule incident. When there were hundreds of residents, they were available in the nearby vicinity. Still, that resident had to face the problem and he had to lose his eye, which is very unfortunate. Closed circuit TV should be installed everywhere. Hoarding to be prominently displayed in the hospital premises, and people should be made aware of law against the assault on doctors and hospital staff. That would cause some effect. During admission of the patient, photo ID of the patient and two relatives should be obtained to be attached to the case paper. In charge of all police stations of the nearby vicinity should be made aware of the law against the assault on doctors. See, I would not be exaggerating. There are many police stations who are not aware about this medical act. So we have to make them aware by by going there, having a dialogue with the inspector in charge and making them aware of this. Copy of the circular to be sent to every station. It is difficult to practice in the hostile atmosphere. See, nobody is immune. Seniors, they feel that during our time there was no problem, but we cannot say that even now they can face problem at that age. There are a lot of examples wherein even senior doctors have faced the problem. In Assam, we know that one of the doctors was actually killed by the mob, and there was problem also in Indapur, if I remember it correctly. If some antisocial elements pressurize for admission and treatment and creating ruckus, and if you find trouble, we should tactfully refuse the admission to admit that patient, and other practitioners should be made aware of such nuisance creating people through WhatsApp. 24 emergency services, if they are not available, then boards should not be displayed if there are no services available. If patient is to be shifted in an emergency, first aid without wasting time should be given, and patient should be immediately shifted to the proper center. Friends, we all need to come out of the prejudices things look different from different angles, and we have to change our view to suit the ideas. Work in media should take a balanced stand without keeping in mind the news value. Police and law protectors should not take law in their hands and should not succumb to the pressure. Doctors should remain united and fight against the injustice. They should not quarrel with each other. Dr. Utture mentioned about medical jostling. That is very important. We make loose comments when the patient comes to our center that "Arey, thode der se aate the, to perhaps I would not have saved you, or I would not have saved your limb, or the limb is lost because you have come late." So this type of comments are made. So don't try to emerge as hero by criticizing your colleague, by making loose comments against your colleague. Santosh would not leave me if I don't, mention about one. He was expecting one share from me. Now at this juncture, I would say that as far as medical jostling is concerned, हमें तो अपनों ने लूटा, गैरों में कहाँ दम था, हमारी कश्ती वहां डूबी जहां पानी कम था. So this we have to definitely remember. Social activists should handle the situation well without exploiting the situation for their own interest. Many political parties nowadays, they don't have any work, and that's why they rush to the hospital and they go against the doctor and you try to create their image in order to have a political mileage. Doctors should abide by law, should practice ethically and morally. Then only they would be able to render the services fearlessly, and medical profession would able to gain the lost glory. Nobody is immune, as I said. Seniority in the practice does not give you immunity. Any doctor, senior, young, reputed, they have faced problems, and there are n number of examples for this. It is advisable to become the member of Professional Protection Scheme of IMA Maharashtra. We have been all the time insisting our members of IMA to become a member of Professional Protection Scheme. Never criticize your colleagues to emerge as hero. As I said, we are all staying in glass house, and you never know, you may be the next victim. So we need to inculcate the brotherhood and harmony and helping attitude amongst us. IMA's action committee should come in action. Members of action committee should coordinate with each other and should reach the doctor in trouble. Try to pacify the situation. Do not quarrel with the relatives. Try to explain about the medical accidents to a sensible person. Arrange meeting with the concerned police official. Inform and involve respected social personality. Action committee should have a rapport with the police officers and the society. We should organize symposia and panel discussion on the various issues, health related problems, and how to improve the doctor-society relationship. I congratulate IMA Akluj for including this topic in this conference, which is a very important topic. We should write the articles in newspapers, magazines, mentioning intricacies and difficulties about the medical accidents and possibility of negative outcome in spite of all our efforts. That's why I said that what we can guarantee is we can guarantee the efforts and not the outcome. Positive step by IMA has been already taken in spite of law passed by various states, countries. In the country, assaults continue. Every day now also we are getting some or other news from somewhere that the doctor was assaulted, the hospital was vandalized. This continues. And it is encouraging to know the introduction of violence registry that was initiated by Dr. Dinesh Thakre from IMA Maharashtra, and this will definitely make a difference. And day is not far. We should abide by rules and regulations. We should practice ethically, and the image would definitely improve. We should render our services fearlessly, and our profession, we should work morally. And the day is not far when when again it will be considered as the most noble profession, and the lost glory of the profession will be gained. I would say that you cannot change the tides, but you can definitely learn to swim. Thank you very much, Dr. Santosh and team IMA Akluj, for giving me opportunity, and I hope that I could finish that in a specified time. And thank you so much.
Thank you, sir. Thank you. I request Dr. Sati Doshi, sir, to felicitate, sir. with e-memento. Sir, can you please stop the share?
Yeah.
Hello. Sir, so you have narrated nice thing in a short time. This topic was very big, but compared to the topic you have completed in time, so all are happy. So thank you very much. आपण आपल्याला आम्हाला काही सल्ले दिलेले आहेत त्याचं आम्ही निश्चितच पालन करू आणि आपला आभारी आहे. थँक्यू व्हेरी मच.
सर कम्युनिकेशन स्किलला तुम्ही चेअरपर्सन मला चांगलं वाटलं एकदम सॉफ्ट स्पोकन गोड बोलायला.
With a good communication.
Now with the last lecture, I request Dr. Narute to felicitate sir. And for the last lecture, we have the speaker here, Dr. Deepak Jumani sir. And I request Dr. Vidisha sir to introduce Jumani sir.
Good evening, friends. Looking tired and exhausted, but don't worry. With some intention, Dr. Deepak's lecture has been kept as a last because those who have attended his lecture previously, in fact, don't need any introduction. Professor Deepak Jumani is a senior sexual health physician and counselor. To give few lines about him, literally few lines, because he cannot be contained in few boxes. He is a diplomat, American board certified clinical sexologist. He is a fellow of American College of Sexology. He is ASEC certified sex therapist. He is attached to JJ Group of Hospitals and Grand Medical College. He is a course director and mentor, fellowship in clinical sexology. He is editor of International Journal of Psychology and Counseling. He is co-chairman of IMA's Initiative for Sexual Health. He is cybercrime intervention officer to the government of India. He has authored a book also. Name of the book being Sex Has No Expiry Date, and the book has been a bestseller. Dear friends, no further obstacle between you and the audience. I hand over the mic to Dr. Deepak. All yours, Deepak. Start.
I'm very happy to announce that we have had more than 1,000 registrations. Till today, the registrations were going on in the morning, and still we have more than 300 people who are still logged in. So I think it is creditable after the whole long day conference. And I'm sure with sir's lecture, everyone would be happy that they're still online and I'm still attending.
Thank you very much, sir, for that sexy introduction. अच्छा वक्त जरूर आता है. पहिले करायचं ना रे सगळं. बंदच आहे. लॅपटॉपचं बंद आहे ना. अच्छा वक्त जरूर आता है. Men do get erections, पर कमबख्त वक्त पे नहीं आता. वो पल भी आया तो कुछ पल के लिए. सोचा उस पल को रोक लूं और पल के लिए, पर वो पल न रुका एक और पल के लिए. This is the state of affairs we see. Around the world, people love. They sing for love. They dance for love. They write stories. They build monuments. They build buildings, build structures. They kill for love. They die for love. In fact, we all are victims of love. And love and sex are same coins, sides of the same coin. And love really has no expiry date. So how sex can have an expiry date? And what we are seeing today is a lot of sexual dysfunctions, which are mainly due to aging and due to urbanizations and some diseases of civilizations like diabetes, hypertension, dyslipidemia. And one thing which has to be blamed is our own lifestyle, basically the diet. With pranams to God and thanks to my teachers, Dr. O.P. Kapoor, Dr. Prakash Kothari, and Dr. Sashank Joshi, I beseech them to bless me always. Prime Minister Modi was very sad. Look at his hands are down when he gave us lockdown and GST. So he told me, Deepak, now you do something. So look, my hands are up and I tell my patients, look down and I'll give you my GST. And my GST to you all is great sex therapy. I have some breaking news. Do you know that most common cause of mortality in men is due to cardiovascular disease globally, and men live 5 years younger than women? 62% of women across the globe admitted that they were not satisfied with their sex lives. A beautiful study called Female Study, which was the experiences of females of men having erectile dysfunction. The results were women felt that they can obtain sexual gratification even without a man's good erection if they had deep level of non-sexual intimacy. Some women questioned their attractiveness. They felt they were not attractive enough. Some women felt the partners had some lafda. Some questioned the worth of relationship to be sustained. They wanted to take divorce. And some women felt that sex was but all agreed that quality of life was affected and there was frustration, sense of inadequacy, self-blame and insecurity. Divorces in India are on the rise and the main causes importance. 45% men also are dissatisfied across the sex lives. 50% of couples in the most developed country like Japan are staying sexless. Erectile dysfunction affects 50% of male population across the globe over the age of 40. When I Googled, I found Viagra had 196 million web pages and aspirin had only 53 million web pages. Erectile dysfunction, friends, is caused because of endothelial dysfunction, which leads to emotional dysfunctions. But this is not triple ED. I call it sextuple ED, sextuple ED. Why? Because once you get erectile dysfunction and if you diagnose early, you can prevent early death, and education is the key. Men having erectile dysfunction, they avoid having sex. They start giving excuses. They don't take treatment, be it psychogenic, but they don't take treatment. They don't open up and they avoid and they deprive their partners of having a good quality of life. Friends, unless we love and are loved, each one of us is alone. Each one of us is deeply lonely. And according to American Heart Association and American Urologist Association, sex is the best prescription of longevity and good health. And it improves every system of our body. And it is also said, use it or lose it. Sex is God-made. Restrictions are man-made. It affects these disorders, these dysfunctions affects the individual, affects the partner and also the relationship. Leo Tolstoy 110 years back said, men survives earthquakes, epidemics, the horrors of disease and all the agonies of the soul. But for all time, his tormenting tragedy is and shall be forever the tragedy of the bedroom. The flaccid truth is, though endothelial dysfunction causes erectile dysfunction and emotional dysfunction, but the bitter truth is, all these are the manifestations of aging and are the complications which even include diabetes. So is what happens in aging? Aging is nothing but activation of antioxidative system, producing inflammatory markers and depletion of endothelial nitric oxide synthetase, leading to reactive oxygen species, leading to nitric oxide inactivation or less production of nitric oxide, leading to endothelial dysfunction. And this manifests as vasomotor smooth muscle cell growth, inflammation, remodeling, apoptosis, and altered vasomotion. All these are nothing but vascular system complications. So if aging is a disease, are we not living Are we all diseased people? No, it's not so. The main feature of aging process is a chronic progression of the pro-inflammatory status we are all in. And this is controlled by a cellular and molecular defense mechanism. And when these mechanisms decrease or reduce, which is called as immunosenescence, this is nothing but an adaptive net result of our body's defense mechanism, which is a dynamic process. And immunosenescence is our choice. We can develop that immunosense. So I call we are living in an inflammaging state. And the causes of inflammaging are stress, oxidative stress, cytokines, DNA damage, autophagy, stem cell aging, all due to various signaling pathway produce inflammaging, which we are all living in. And today we all understand that youngsters want muscles. They want to look manly. They want to look machos. You know, this is what, and even women prefer testosterone honed men. This is a sad thing. This needs to be changed. And due to increased urbanizations, we are seeing diabetes, obesity, dyslipidemia, hypertension on the rise. And one patient, if is dying of diabetes in 6 seconds, there are 2 developing diabetes. That is the scenario today. What is erectile dysfunction? Is nothing but attaining or sustaining erection for a satisfying intercourse. You label a patient of ED only if he has this symptom almost every time, at least 75 to 100 times. And there has to be at least 6 months of duration. And there has to be clinically significant distress. This is a schematic diagram of the physiology of erections. That's the vascular endothelium produces endothelial nitric oxide synthetase, which stimulates or diffuses the nitric oxide. Friends, remember, nitric oxide is the main chemical signaling molecule, is the currency of each cell, which enters into the corpora cavernosa smooth muscle cell, converts GTP into cyclic GMP. This cyclic GMP relaxes the smooth muscles of the penis and allows the blood to flow inside. But sadly, this cyclic GMP hydrolyzes into 5-GMP with the help of an enzyme called phosphodiesterase 5. So if at all you want to give a therapy, or if at all a man wants a good erection, what he needs a normal endothelium. Hence, erectile dysfunction is endothelial dysfunction. He needs good quantity of endothelial nitric oxide synthetase. He needs nitric oxide. He needs cyclic GMP to be there in more bioavailable form. He needs something to block PDE5, which we have in the form of sildenafil, tadalafil, vardenafil, udinafil, and now new kid in the block, which is avanafil. So erectile dysfunction and endothelial dysfunction, they have a possible link, 100% possible link. And this is very, very much seen in diabetic patients. If I take you to the history of erectile dysfunction, way back in the Egyptian time, 2000 BC, they found that this could be because of natural thing or something evil happening to the man. Hippocrates reported this to be due to horse riding. Aristotle found that it was something nerves, influx of the air. But it was Leonardo da Vinci, when he found men who were hanged, their testes and their penis were draining blood. And so he realized that there is something to do with the vascular system. And he debunked Aristotle's theory, which was kept for 1,000 years. And it was Ambrose Parr who wrote a book on surgery. And he said that when a man gets inflamed, look at the language he uses. He didn't want to write erection. He didn't want to write penis. So he wrote, when a man becomes inflamed with lust and desire, blood rushes into the male member. He didn't want to write penis, male member, and cause it to become erect. So that was the breakthrough. And today, even in Japan, this is a festival which they celebrate. This is a photograph taken by me. I see images or sculptures of Lord Shiva with erect penis in the temples of Bhubaneswar. Why they're there? Now, let me give you a newer perspective. Erectile dysfunction is nothing but penile attack. Look at the artery sizes. The penile artery is 1 to 2 millimeters, coronary artery is 3 to 4 millimeters, internal carotid is 5 to 7, and femoral artery is 6 to 8. When atherosclerosis sets in, and if 50% of the artery gets blocked, the penile artery being the smallest, if this gets blocked, this patient gets erectile dysfunction. But the same amount of atherosclerosis does not occlude 50% of the coronary artery or internal carotid or femoral artery. But atherosclerosis is progressive. Sooner or later, even the coronaries will get 50% block and they'll start getting symptoms of angina, myocardial infarctions. So what does this hypothesis tell us? It tells us that erectile dysfunction comes first and then the coronary artery disease comes. So erectile dysfunction is the earliest marker of coronary artery disease. And our friend Kumar Bhatia proved it with his patients that onset of erectile dysfunction precedes the symptoms of coronary artery disease by a mean of 2.5 years in most of these patients. So we have 2.5 years of time, window period to change his lifestyle, to control his hypertension, dyslipidemia, diabetes, ask him to quit smoking, give him a good talk on food or diet, on exercise, and retard the onset of critical events in his life. So erectile dysfunction is the first sign of cardiovascular disease. Penile attack almost equates heart attack. This has been proven beyond doubt. And erectile dysfunction is nothing but subclinical cardiovascular disease. So when we look at the penis and the endothelium, so endothelium or the penis has become the barometer of men's health or the endothelial health. Now, endothelium is nothing but the innermost layer of the vascular system and the lymphatic system, and very, very important system of our body. It's a monolayer. It contains sensors and mediators. Friends, a man is as old as his arteries. And if the endothelium is normal, it will produce vasodilatation, thrombolysis, platelet disaggregation, anti-proliferation, and lipolysis. If the same endothelium gets dysfunctional, it will produce vasoconstriction, thrombosis, adhesion molecules come into play, growth factors set in, and inflammation cascade sets in. So nitric oxide, friends, is the molecule of life, is the miraculous molecule of life. And the science behind nitric oxide is that it expands all the blood vessels by 26% of most of the vital organs. It also decreases as we age. At the age of 60, it will be only 15% nitric oxide which is remaining, and it reduces earlier in men than in women. So why it's molecule of life? Because you can live for 3 to 7 minutes without oxygen. But without nitric oxide, you can live for not even more than 5 to 10 seconds. So the bottom line is no nitric oxide, no sex. And nitric oxide, we get it from L-arginine, which is a metabolic amino acid, very potent. And L-arginine, besides producing nitric oxide, has got multiple other beneficial values. And the discoverer of L-arginine producing nitric oxide in the vascular system got Nobel Prize, Dr. Louis Ignarro and his team. Nitric oxide will be needed by all of us above 40. If the endothelium is good, it is good for us. If it is bad, the endothelium controls the dynamic nature of the vasculature. Disease. Friends, prove it. And brachial artery ultrasound is the only way we can diagnose endothelial dysfunctions, and it has been reduced in diabetics, obese, or hypertensive patients. Endothelium derived nitric oxide is the anti-atherosclerotic molecule. It is also an anti-thrombotic molecule. So we have learned a lot of lessons. So what do? We need to take history, and only 4% Indian doctors are taking history about sexual aspect of a male's or a female's life. This is a global study done, and there is a rise in patients having erectile dysfunction. It cannot be ignored. The onus of sexual health of our patients lies with us. We ask histories about allergies, surgeries, addictions, piles, fissures, but we don't ask histories about their sex life. One simple question, if you ask them, do you have problems in making love? It will open up a Pandora's box. You will be surprised that your patients were waiting for you to initiate a dialogue on this aspect. So please ask your patient, make it a regular habit. The algorithm is ask your patients first, then legitimize, tell him that most of the diabetics, most of the hypertensive, most of the obese patients have some issues in the bedroom which can be managed today. So telling him like this, you'll not making him a victim of that particular issue. It will be generalized. So he will feel he's not alone. And then if you could do something, do for him, otherwise refer or open up a discussion and evaluate and work together. So we as physicians need to break all barriers of clinical inertia and ask our patients about it. India and China are the diabetes capital of the world. And erectile dysfunction is the commonest complication of diabetes in men. So Chindia are the erectile dysfunction capital of the world. Both type 1, type 2 and males having diabetes have high incidence. Erectile dysfunction can be psychogenic, vasculogenic, neurogenic, hormonogenic, drug-induced, or even genetic. Genetic because they found SIM1 loci gene, which is now diagnostic of patients having erectile dysfunction. How do we manage it? Well, rule out psychogenic by asking him, does he get morning erections? If he's getting morning erections in last 8 to 10 days, he's got psychogenic or situational problem. He does not need PDE5 inhibitors or any medications. He needs only counseling. And there are 2 validated questionnaires, II, EF, and SHIM, which we are validated, which we do it for research purposes, advise on smoking, diet, blood pressure, lipids, eye, feet, and oral hygiene to be examined every time when they come to you, cremasteric reflex and bulbocavernous reflex to be done. The hormones, estradiol, vitamin D, uric acid, sonography of the scrotum, Doppler studies, serum PSA free and total if you are planning to give him testosterone, digital rectal examination, Regi scan has to be there. Salivary tumor necrosis factor, very simple to see. Just put a gauze swab on his mouth if you see anybody having teeth like this. This is an indication of erectile dysfunctions. And relationship between platelet and lymphocyte. If you do CBC, which we do, to take a total platelet count and divide it by the total lymphocyte count. Platelet lymphocyte ratio, if it is more than 105, he's got moderate, mild erectile dysfunction. If he's more than 116, he's got moderate. And if it is more than 136, he's got severe erectile dysfunction. So just by doing CBC without even asking your patient, you can diagnose erectile dysfunction, and you can then confront with him and ask him. He will consider you to be Sai Baba. How did you come to know? You didn't even examine. I didn't even tell you. Diabetics have advanced glycated end products. So there's a gadget, just put your hand and through skin autofluorescence, you can diagnose erectile dysfunctions. How do we treat? First line of treatment is pharmacotherapy with counseling and lifestyle measures. Second is injections of papaverine in the intracavernous tissue, vacuum therapy, intraurethral prostaglandins, counseling and lifestyle measures. If all these fail, we send our patients to the surgeons, neurosurgeons who do implants or anastomotic surgery, and along with counseling and lifestyle measures. We have 4 PDE5 inhibitors. All of them have got varied onset of action and duration of action. They all have side effects like flushing, headache, nasal congestion, etc. And the contraindications are nitrate or hypotensions. If your patients are on nitrates, you cannot give them PDE5 inhibitors. But if they want PDE5 inhibitors, you can switch over to ralanosine, and which can be taken, and he can try PDE5 inhibitors. Low dose PDE5 inhibitors are the best. Even if you have HbA1c, which is more than 9, hypertension, prostatic hypertrophy, or even dyslipidemia, low dose 10 mg tadalafil on a long-term basis produces very good results. There are 40% who do not respond. My friend Dr. Jyoti Dev put patients on diabetic patients on insulin pump and found 83% improvement in their sexual functions. Metformin has now been proven to be very good improvement in endothelial dysfunction, and SGLT2 inhibitors, because of its class effect, weight loss, controlling hyperglycemia, dyslipidemia, antioxidant, and controlling hyperglycemia. It is controlling every cause of the vasculogenic cause of erectile dysfunction. So if you put your patients on SGLT2 inhibitors and metformin for diabetes control, which they anyway need, they don't need additional drugs like PDE5 inhibitors. Buried penis syndrome is so common. Just apply 1 gram of sesame seed and L-arginine gel with 1 gram of metformin every day for 6 weeks. You see a beautiful results in them. Novel treatments include low intensity extracorporeal shockwave therapy, platelet-rich plasma. There are so many molecular targets and treatments for erectile dysfunction on the pipeline. Amongst them, the promising is stem cell and gene cell therapy, which has been, which has got some evidence, but not so much robust evidence so that we can indicate. Now, phytonutraceuticals, particularly L-arginine and fenugreek in saponized form, has been a boon. They increase the desire. They also increase the production of nitric oxide. What is the new in the treatment? What is novel treatment available today is avanafil, which is a very, very beautiful molecule. The onset of action is 15 minutes. And the duration of action is just 5 hours. You take it after 5 hours, it is not there in your body. So you can give it to your patients who are on nitrates, skip the nitrates on the same day so that he can use PDE5 inhibitors. It has been tried in diabetes, very good results. Even this sexual encounter second time with this PDE5 inhibitor like avanafil is fantastic. Newer molecules include SLX, mirodanafil, lodanafil. So point to ponder is, do you consider erectile dysfunction as a symptom or a disease? If you consider it to be a symptom, give him pharmacotherapy. If you consider it to be a symptom or a disease, you need regenerative medicine in the form of stem cell or phytonutraceuticals. One path-breaking study was, they found some epithelium in the diabetic patients. If that is blocked, you can cure the endothelium. So now my last part of my talk is, PDE5 inhibitors are a boon. They improve the mitochondrial functions and improve the cardiac contractility. So if at all, even if you do not have erectile dysfunction, or you have hypertension, or you have dyslipidemia, but you may get it. So if you take a low dose of tadalafil or PDE5 inhibitors, it is a boon for every patient. It is a vasodilator. Empagliflozin has been studied, proven beyond doubt in patients who are diabetics. Metformin also improves diabetes. So metformin, SGLT2 inhibitors and low dose PDE5 inhibitors along with L-arginine, fenugreek are the best for any patients. Direct study proved that with just lifestyle measures, you can reverse the diabetes. My friend Dr. Paresh Dandana proved that with testosterone therapy, he could stop the diabetes. He could reduce the insulin resistance. So diabetes is reversible today. It's not a myth. Dean Ornish proved that coronary artery disease can be reversed only with lifestyle measures. So genes, only what happens to us is 20% genetic. The rest is all lifestyle. So most of the modifiable factors which give us disease are modifiable. They are either diet or lack of exercise or erratic lifestyle, smoking, etc. And Mediterranean diet has been useful. The current approach, see, there is improvement in every risk factor. But one risk factor which we still have, because of which the cardiovascular deaths are more, is the central one, the healthy diet score. We all lack in healthy diet. That is what is lacking. So Cleveland Clinic proved beyond doubt that nutritional intervention will not only halt atherosclerosis, but also reverse atherosclerosis. Look at this study, the perfusion scan, completely cleared up just with nutritional intervention. Such a huge plaque without stenting has been improved only with nutritional intervention. So nutrition is so important in our life. Please, friends, remember. That's why Thomas Edison 200 years back said, doctor of the future will no longer treat the human frame with drugs, but rather will cure and prevent disease with nutrition. Even two-time Nobel Prize winner Dr. Linus said, nearly all diseases can be traced to a nutritional deficiency. And endothelial dysfunction, is it reversible? This is a news. Yes, it is reversible with statins, ACE inhibitors, antioxidants, L-arginine and estrogen therapy, proven beyond doubt that it is reversible. Intuitively, it is at this early stage that arterial wall damage is most likely to be easily reversible. So if you can reverse the endothelial dysfunction, you can cure almost every disease. And that is possible only with nutrition and the particular things which we just mentioned. So if the Platonic ideal of science is that it guides us to the truth, endothelial dysfunction is reversible. So ED, which is due to endothelial dysfunction, is reversible. It could be due to any causes. All the causes are modifiable and treated. It's a shame for a man to grow old without seeing the beauty and strength of which his body is capable of. You all can challenge your body and make it as you want to. It is up to you. Be committed, be dedicated to what you want to. As far as diet, exercise is concerned, see, you can change yourself. My take-home message is, ED is not just erectile dysfunction, it is penile angina or penile attack. It's the earliest marker of cardiovascular disease. It's diabetes type 5, it's a tip of an iceberg. Bedroom. Today I find bedroom everything else except sex. You have laptops, you have televisions, you have mobiles. Bedroom ethics is, bedroom is only for sleep and sex. And give your patient realistic expectations. Don't tell him, don't guarantee him 100% cure. You guarantee him that you will try 100% of yours to see that you become better, but don't guarantee 100% cure for anything. Look at your partner's inner beauty. Don't change her, change yourself if you want to. Try 64 different positions rather than changing 64 different partners. So the key to having good sex life is take a detailed history of your patients, give a reversal to the metabolic imbalance, avoid smoking, all good foods. These charts, I don't want to narrate it. Whatever is good for the penis is good for the heart. Bariatric surgery reverses most of the diseases. Husbands watch porn and wife is working in the kitchen. Wife knows it. What is a signal husband is giving to the wife? He's giving her a signal that you like the movie, like the girl in the movie more than her, which is stupid. Don't do like that. Watch the movie together and criticize the girl in the movie. That is what is required. After play, husbands ejaculate, turn themselves on the other side and sleep. Ho gaya, maza kaam zala. No, you have not satisfied her. You need to hold her tight even after you have ejaculated. Maybe it was early ejaculation. Maybe it was not giving her enough orgasm. So hold her tight, hug her, thank her, compliment her, tell her she was awesome, she was beautiful. Do everything what you did during foreplay again. Because if you look at a girl who's good looking, did a lot of makeover, anybody would tell her that she's awesome, she's beautiful. But if you're complimenting your partner in the bedroom, you are giving her a signal that you like her the way she is, and that speaks miles. So that is very important. Silence is a girl's, when you come home and she's quiet, don't think everything is okay. No, that's not. Women also have some roles to do. She has to regard him as a hero. Yeda hai, teda hai, lekin mera hai. No, she has to. And never give him any pressures to perform. All these women were abandoned by their husbands and they got a makeover done and they were again admired by them. So don't make your stomach as a waste paper basket. Come khao, gum khao, nam jao. I have a principle. Eat less often. That's simple. Do workouts. Touch. Husbands hardly touch their wives. There is no touch. Vitamin T is lacking. Vitamin romance is lacking. They don't hug each other. There is no GST on romance. They've forgotten what is romance. Yoga, beautiful. Do whatever relaxation exercises you do it. So the bottom line is healthy lifestyle will reduce the pro-inflammatory milieu which we are in because of inflammation. It will reduce the insulin resistance, which is the cause of erectile dysfunction, oxidative stress and endothelial dysfunction, and give you improved well-being and reduced burden of sexual dysfunction. Lifestyle should be you may be Hindu, Muslim, Sikh, Isai, whatever, but make lifestyle as your first religion. That is what is important. So we have 4 PDE5 inhibitors. They don't increase the desire. There are 40% who are non-responders. You can give them testosterone, but it can cause azoospermia and prostatic issues and heart failure. So the Raja of all is L-arginine, fenugreek, and lifestyle modifications. So for male sexual response, you have L-arginine, fenugreek, testosterone, PDE5 inhibitors. They can give you everything what you need for a good, satisfying sex life. Love each other unconditionally, your partners for life. Bring in harmony in the house. Don't bring in disharmony. Get charged. We are exposed to so much of erotic material. Nothing wrong. What is wrong in getting charged? Be fearless, passionate, and focused in the bedroom. That is a must. Every wife is a mistress for her husband. Miss for 1 hour, stress for the rest 23 hours. This is what all men say. But that's not true. A woman is a masterpiece of God. She's the best phenomenon in the world, not to be compared with anything else. The origin of all of us is from a woman. She has taught us what sharing, but still we don't regard her. There is total disregard for her satisfactions because mutual satisfaction is the buzzword. This is what is required for conjugal life. We call it samabhog, means equal joy. We just don't have to do it for our own self. We shouldn't be self-will. We need to listen to her, keep her mouth shut when she's speaking. Feminism needs to be adored, admired, and respected. Look at Mahabharata, look at Ramayana. What has they taught us? If a man who doesn't adore, admire, respect feminism, I pray to God that he should get permanent, incurable erectile dysfunction. We fall in love, but staying in love is very important. Wrinkles don't hurt. Love doesn't have any expiry date. So erectile dysfunction is not an option for anyone. It is how gracefully we handle the process and how lucky we are as the process handles us. We have so many things to give to our patients for erectile dysfunction that this is a correctile dysfunction. My serious plea to all is ask your patients. We are aware of what is going to be and we have the tools. We must act now. Men are born between 2 legs and they spend rest of the life trying to go back. It's only because they love to go back home. This is what is important. So Voltaire beautifully said, be monogamous. Monogamous is just like being a garden, and polygamous is like a jungle. So both are beautiful, but to make your garden beautiful, you need to devote time. You need to water. You need to cut the right type of grass, give fertilization, etc. So Voltaire said, try and cultivate your own garden. Be monogamous. It's really nice to know that once a young patient gets erectile dysfunction, it's a blessing in disguise. You can modify every risk factor for him and make his erectile dysfunction as a correctile dysfunction and give him a good quality of life. So if you have patients of erectile dysfunctions, don't send them to quacks. वो सिर्फ पुंगी बजाएगा. Send them to good sexologists. You will see that he gets a good erections. This is my book, Sex Has No Expiry Date, available. Erectile dysfunction is very common in diabetics. Is a tip of an iceberg. Is the earliest marker of coronary artery disease. It is endothelial dysfunction. Remember, endothelial dysfunction is reversible today. It's diabetes type 5. PDE5 inhibitors, short course of testosterone is ideal. L-arginine supplement, fenugreek is a boon. A heart that loves is always young. Age, weight, height are just numbers. Lifestyle measures can reverse metabolic syndrome, and hence erectile dysfunction is a correctile dysfunction. And if so, sex really has no expiry date. Thank you all for your love. I'll be happy to answer any questions you all have. I have another webinar in just 5 minutes, so please excuse me. She said, your lecture is last. I told her sex is always last, though it is here, but it is always last.
Thank you, sir. Now I request Dr. Vidyut Shah, sir, to felicitate, sir.
Everybody agrees with me. What a lecture. Scintillating, exhilarating, electrifying, and whatnot. A good academician and a better orator. Masterpiece, clinician, and in the end, a friend par excellence. Thank you, dear friend. And as you have prayed early at the lecture, God will always bless you. Thank you.
And I request Dr. Narute to felicitate today's chairperson. We had a wonderful day today and it has ended really well. I hope we soon in future we get to attend more and more physical lectures. It was indeed a pleasure to listen to you, sir. Thank you. Thank you all for attending. I really appreciate all the seniors for being there throughout the whole day conference. Followed by dinner. So I request all the members to stay for the dinner. As an important part of the session, that is photo session. Favorite part of Dr. Khattare sir.
मी बोलणार माणूस आहे. नाही Hello.
Good evening, everyone. Thank you, everyone, for attending the lecture. The session today was wonderful. We have concluded our today's session. So we had a total of 4 sessions today. Wonderful sessions. We have covered various aspects of emergencies, and also on the World Health Sexology Day, we have had a special lectures on sexology as well. So to all the online and the present physical people who are just doctors who are present over here and have attended the lecture, I would like to thank everyone from IMA Akluj, and the physical people who are present over here. I would request everyone to join for dinner, and the online people who are there, I hope so you had a wonderful time today, and I would like to invite you for tomorrow's meet as well. Tomorrow also we have got wonderful sessions. The sessions will be starting early tomorrow. We would be starting our lecture by 9 o'clock. So everyone do log in as early as possible. The links for tomorrow's login would be the same which we have used today. So you need not have a extra login view. You can just go to the DigiShield app and directly start the Zoom link. Whoever needs any help with login process can message me on my WhatsApp. I will be easily available. So I have sent you the mails accordingly. If there are any suggestions, if you need any help, you definitely can message us. You have got respective emails as well sent to you. So good evening, and hope so you had a wonderful time today, and meet you tomorrow. Thank you.